7:25, so we will start. Ones on the internet to the EVTM Hot Topics 2021 in live in real. And we will start, we have Professor Mats Karlsson, Professor Wallin, and Professor Nogran here. And I thought that maybe you can start, and then we will ask Lars at the end after to speak after you, if it's okay.
Okay, sure. Well, friends, dear colleagues and friends here in Örebro and all over the world, my name is Mats Karlsson. I am Director of Research at the University Hospital. So on behalf of the University Hospital, the region Örebro County and Örebro University, I wish you very welcome to our research community here in Örebro City and at the hospital. Obviously for you, rather few, that actually are attending live here in Örebro, we welcome you to a very cold city today here in Sweden. We still miss the white snow that we hope will arrive soon. More importantly, I would also wish you very welcome to the youngest university hospital here in Sweden and the youngest medical school. As such, even though it looks a little bit different here on the podium for the moment, we are still teenagers. But due to Tal Hörer and many other young colleagues of ours, we have already received a reputation in science and therapeutical efforts. Achievements and results have already traveled worldwide and even brought you here to Sweden in December. As a director at the University Hospital and as a fellow scientist, it's been a pleasure to follow and support the efforts of the EVTM concept to develop and communicate both the progress in science and the advanced treatment concepts that you are using here at meetings in Örebro, in meetings worldwide, and also in the new publication of the Journal of EVTM. So, friends and colleagues, I wish you all attending here on site or in our new virtual reality an interesting and pleasant stay in Örebro and at the conference and at the symposium, sharing your knowledge, doing the best for our patients here today, and sharing your new scientific achievements and ideas, doing the best for our patients tomorrow. So once again, welcome to the symposium and welcome to the Örebro University Hospital. And when you are returning in a few days here from Örebro, Sweden, or staying at home, joining the virtual reality, I wish you all a very, very happy Christmas. Thank you.
Tal, so I had some pictures. So Yes, that's perfect. So my name is Göran Wallin in Swedish, Wallin, and I've been chairman for Department of Surgery. So I would like also to welcome you all to Örebro, to this EVTM meeting. It's nice to see a lot of people, even if it's few people in the audience for the moment, but to have a meeting face to face, that's almost the first time in 2 years. So I hope we will have a very good meeting with learning, discussions, and a friendly meeting. Next slide. Oh, no. Yeah, that's fine. So I also would like to say some words to Tal. So I've been your chairman, and you were from the beginning a resident, and you were absolutely full of energy, positive energy, and the thing is, don't stop me now. Next picture. So in Örebro, we had a very good surgical education. So if you look 50 years back, we have many surgeons that had good careers all over the country. But next slide if people in the future will look at what has happened this year and in the beginning of 2000, I think they will pick out you, Tal. And this is from your dissertation photo. So you have done a lot of things and in a short time of period. So that's been very good. Next slide. So today, start a medical journal would be possible, but you did it. And it's also very difficult to keep it running. So I'm just impressed. And you have the education with this meeting, you have a lot of international collaboration, and I just end up with your own, no ego, just good science, care and collaboration. Welcome all, and thank you, Tal.
Thank you. We see you and hear you. Lars?
Okay, well, anybody want to listen to me now?
Yes. We see
I'm
you.
sorry to be outside the meeting room, but I decided to stay outside the place. But I have a lot to say about the research you performed for the first 10 years during this decade. And that depends to a great extent on health. Can I have my slide, please?
It will come in battery.
Jag försöker lösa det här på några ben.
I hope they will come up, but you can continue speaking.
All right, if you can't get them, I can speak, of course, but it would be good if you have a chat.
Yeah, we have
Oh,
it.
there they are. Oh, could we continue?
Yeah.
Jag kan komma med hand då.
Nej.
So, what I'm talking about is the vascular and related research in these years. Next slide, please. I'd like to say that we have 3 key words. Next slide, please.
Next.
Could you get the next slide? Okay, thank you. No, it was there. All right. We have 3 key words for our research in these years. That were ischemia, that were metabolism, and that were endovascular. And we adopted microdialysis in order to look at the happenings during surgery and during procedures overall and caused by disorders. Next please. We had a couple of cases and a lot of complications during these years. The first one to deal with this was Sherry Olson, who is a very energetic man who dealt with the technique and the result of intraperitoneal microdialysis that we developed as a side part of the EVTM, doing that in patients. Sherry is a fantastic project during these years. Next, please. Then Charlie came along. And what Charlie was following up on chest material, looking at consequences of complications during surgery, which also was groundbreaking in this field. As number 3, we have Paris 2, who I believe is in the audience. I don't know if I don't see you. And Per dealt with next one, please. Per dealt with the compartment sugar and microdialysis. This means that we have both animal and human experience. Finally, Thomas Larsson, who many of most of you know. Next slide, please. Thomas has worked with endovascular methods since very long, and also the groundbreaking issues there. What he did now was that he got into the scientific part and defended his thesis on endovascular procedures with the orthodontist. Next, please. I'd also like to say a few words about how and his way of working. He is such a drive to make it simple. He came to me a couple of years ago say that when this aortic obstruction, balance and so on, I think one would have registered for that. I told him that, yeah, that's complicated, it takes time, it's a lot of work to do. Now they are on our starting the Swedish Vascular Agency back in 1987. But the simple answer I got from Carlo, we'll fix that. And that's typical. And yes, he certainly did. And he did not only fix the registry, he fixed the Worldwide Society and the journal, by the way. He can again, as Ramali recently said, he's good on that way. Certainly to admire one and how that happiness. Let me call it beauty. Today he's doing a fantastic job, and I'm sure the meeting will be successful. Sorry not to be with you, but I will listen and look at the meeting throughout the time. Wish you all welcome, and thank you very much for letting me speak to the people and to you personally. Thanks a lot.
Okay, thank you so much for your kind words. Thank you, Lars. Hello, everybody, both in place and in worldwide. Just some few words in the seconds we have before we start. We will start in 4 minutes the first session. Welcome to our brew, and welcome all of you traveling. It's not easy time to travel. We are on the internet on live broadcast, and thank you, Johan and Doug, for helping us on this in different platforms on jvtm.com. It's a short delay, but it's possible to comment on Twitter and if someone wants to communicate. This work, it's not as usual congresses. It's very limited time, and we have 6 minutes per talk. And it's coming from inspiration of the VEIT Symposium in New York. And the idea is you have to deliver your material in very short time. It's 6 minutes, and then discussion, 6 minutes discussions, and the chairs can choose also to have the discussions later on. It's a dynamic thing, but we have to hold the time. So I would ask everybody, both here on video, to hold the times. This is very important. We want good discussions. Of course, there were some minor changes or bigger changes due to the COVID-19 situation. So we have some of the speakers with us live. They will be here on my side. We can see them. They have a special Zoom link, so they are live. For the people here, there is some food, drinks, refreshments outside here. So I hope you feel comfortable. And thank you very much for coming. This is possible only with the help of our hospital, Mats Karlsson, the Örebro University Hospital, and our colleagues and the industry. And I would like to thank our sponsors, and this is very important. Without them, it's impossible to do it. Prime time for their help, Frontline, Limedic, Tokai, and all the other companies that are helping us. It's impossible to do these things without the help of the industry. I would like also to thank the European Society of Vascular Surgery, the ESVS, and the European Society of Trauma and Acute Care Surgery, ESTAS, for their collaboration. I think it's great that we have this collaboration with other societies. I want also to thank the MCON, our office helping us out here, our helpers, people helping us from the department, and the local EVTM team. And I want also to thank our colleagues that are working now in the hospital, and they are taking care of the patients when we stand here. Thank you very much for coming. We will start with getting the first session up and running. So we have Anna Maria that will come up, and let's see if we have on Zoom. Come on, Maria. And Professor Ken Boffard, and I'm not sure if Martin Malina is online. We will proceed. Yeah. So the stage is yours.
Thank you, Dan. Good morning to everybody. Thank you for being here. I'm glad to be here, and this is a great occasion to share our opinion, our ideas, and our experience. Let me thank Tal for the organization, for the efforts, and for the enthusiasm that he put in the organization of this important talk and meeting. Now we start with the first station. I introduce myself. I'm Anna Maria Gerardi. I'm interventional radiologist. I work in Milan, in the University of Milan. Other chairs are Professor Ken Bofford from New Zealand and Martina Malina from UK. Martina is there? Okay. So we can start with the first talk, Professor Tal Oler with endovascular resuscitation and trauma management. Where do we stand?
And Professor Beaufort is with us live from South Africa. I hope I can see him, but he will probably join. All right, I will speak shortly just to give an introduction for this. We talk about endovascular resuscitation and trauma management. Where do we stand? And I just have to say again, this is not one man's work. There's a lot of people. We stand on the shoulders of giants. It's a lot of people working on things. So, and this is a teamwork in the vascular unit. And it's a lot of people working, and we know this. It's not a one-man show, a lot of hard work from other people. So the concept itself, if we're talking about very shortly, we're talking about concept developed during the recent years, maybe 20 years or so, when we can use endovascular and hybrid tools for bleeding control. As for many advances in embolization, in tools, in imaging, a lot of modern tools, and a multidisciplinary team. So this is the background for EVTM. We know today we can treat 100% of the ruptured abdominal aortic aneurysm with endovascular techniques. And this is an article I hope will be accepted. We will see. But what we learned is that you can do it. And we learned some lessons that you can use for the hemodynamic unstable patient. And this is what we call the EVTM concept. It's been published in different places. And we're talking about a group of tools that you can use, or, for example, effective teamwork, working on vascular access very early, doing CTA as much as possible, balloons and other techniques, adjuncts to help you control a bleeding or hemodynamic instability. And the idea is that endo might help you and does not replace open surgery. This is just one example. It can be used in trauma and non-trauma. And when we're talking about the bleeding patient, this is not only trauma. It can be iatrogenic, it can be spontaneous bleeding, it can be postpartum, placenta accreta bleeding, and others. And it might be also, and this is what we think, also in non-bleeders, in different other shock situation. This is an example of a patient that is being intubated as a vascular access is a procedure, as it being done there. And there are more examples, and we try to focus now on the correct use of different tools, for example, rBOA, the aortic balloon. So it's not just using it, it's using it on the correct patient, in the correct time, with the correct team, and the correct indication, of course. Partial rBOA, intermittent rBOA, etc. It's part of the concept. It's only a balloon. Other tools like endovascular treatment of the aorta in injuries and other acute situations as seen in these ones, or injuries to the subclavia, other vessels, as you see in these examples, when you can help the patient by doing hybrid or endovascular methods to get the bleeding control. Or in this example, when we have ongoing bleeding with your hands in the problematic area, and you can solve it with other tools. And of course, open surgery. So the idea is not to exclude open surgery. It's not instead, it's another tool. So you have to use it in a good way. The landmark article textbook just came out, and this is a summation of articles that are of interest for EVTM, and I hope everybody here got it, and we can send it by request, of course. And we're talking there and in our EVTM meeting about the EVTM developments. And I think the major point is that we want to get data. That's the most important thing. We can speak, we're enthusiastic about issues like the balloon or others. The idea is to get data, to publish it, and of course under the EVTM area. We need evidence to what we're speaking about in traumatic and non-traumatic. And some of it has been published and some needs to come. JEVTM is now Scopus and Web of Science Index. We're working on other indexing services. The next one will come soon. We're working about the society, other issues of collaboration, and I hope it will succeed. We're talking about hemodynamic instability, and I think there is a lot of things to do. Get data, work on the scientific issue to do this in a correct way, and we will see how it goes. And I do think that no ego, just good science, clinical care, and collaboration is the important thing. Thank you very much, and thank you for coming to our brew and online.
Okay, thank you, Tal. Thanks for the overview. I think that if other chairs and panelists agree, we can go on and we can do the discussion at the end. So I introduced Professor Ernest Moore from USA, the unstable bleeding trauma patients. Where does EVTM come in?
Thank you very much. It's a distinct pleasure to participate in this wonderful forum, and I appreciate the opportunity to return, Tal, and great to see all my colleagues from around the world. Well, I was asked to present a topic of when's EVTMs indicated unstable trauma patient. And the reason this is important, as I'm sure you all are aware, is that bleeding is the most preventable cause of death after trauma, and it happens very quickly. This is a review from our center recently where the majority of deaths occurred within 60 minutes. And in fact, virtually every death from bleeding in that trauma center occurred within 2 hours. So when we think about the hemodynamic unstable patient, I think that there's a lot of factors, as you all recognize, and we can have a discussion of these various points. Importantly, what is the location of the bleeding site, how accessible, what expertise is available, and what are the resources at that particular institution. And I suggest that there probably is somewhat of a bias depending on what discipline you represent. For example, trauma surgeons tend to bias more open, whereas the interventional radiologist more endovascular, and somewhere in between is where the truth lies. Well, let's start at the top because in the cervical region, I don't think there's any question that in zone 3 with branches of the external iliac artery in a patient who's bleeding actively, that endovascular embolization is appropriate. However, and the same would hold for vertebral injury. However, I would submit that patients unstable with a zone 2 that is anticipated injury of the carotid artery should undergo exploration. Zone 1, of course, has revolutionized the care of injuries to the thoracic outlet, and the incisions are both morbid and difficult, as shown here in the endovascular stenting of subclavian in particular, and proximal axillary arteries are clearly the standard. However, it's important to recognize that the patient in the emergency department exsanguinating from a subclavian into the pleural cavity, there still is a role for open thoracic control and control of that left subclavian in particular, posterior to the chest. Blunt thoracic aorta, there's no question that endovascular is the dominant way. The bottom right is our usual left heart bypass we use for decades, and that clearly belongs in the museum now. Blunt innominate artery, the same. We haven't had any personal experience, but while this used to be done operatively, openly, now the standard is stenting. Blunt renal artery injuries, additionally, In addition to the quick access, this provides a lot better renal salvage than we used to do with open renal repair. Complex liver injuries, however, I think is a debatable area. In my bias, again, being a trauma surgeon, I think patients who are unstable from complex liver injuries ought to undergo prompt exploration with vascular control of the liver. However, there may be a role for endovascular work, and this is a recent case. We have a retrohepatic cable injury, and we used a rAAA both to occlude the aorta at the diaphragm and occlude the vena cava at the junction with the right atrium, and then put the patient in a vena-vena bypass. It's interesting, if you look in the bottom, in 1997, our colleagues described stenting a right hepatic vein injury. So this is an area that's still in evolution, and I suspect will continue to result in increasing stenting of the retrohepatic vena cava. Extremity vascular injuries, I realize there's enthusiasm for endovascular work, but I would debate right now, and again, the bias of a trauma surgeon, that there's a very limited role for endovascular work in these young, otherwise healthy trauma patients who have 50 plus years of life left on. So I appreciate the opportunity and look forward to comments.
Thank you, Professor. Congratulations for the great cases. We go on with Stefan Auland from France. Advances in endovascular surgery for bleeding control in ruptured aortic and thoracic aneurysm and acute dissections. He is online. Stefan Auland is not here, probably is online. No? Okay, so we go on, we jump this presentation, and we go on with Victor Reva from Russia, EVTM multidisciplinary uses, the vascular trauma, interventional radiology, and endovascular and anesthesiologist role.
Yeah, thank you very much. Hello, everyone, and thank Tal for the invitation to have a talk at this conference. My talk is an overview of what we can do in collaboration and what are the new approaches, new techniques in developing of endovascular technologies, maybe in different areas, not only in trauma and non-trauma. So it is truly multidisciplinary. We are talking about EVTM in different scenarios, and probably it can be divided in two main areas: stable or unstable situation and patients. And actually, in stable situation, the algorithm is quite known and widely spread among different trauma centers across the world. And the patient is admitted in emergency department, then CT angiography and performed, and according to the picture, we decide whether we can intervene with endovascular procedures or not. In unstable scenario, it is going a little bit faster, and we proceed with damage control resuscitation if the patient is already coagulopathic and hypothermic. Anesthesia team is included extensively in this process, and endovascular surgery according to institutional protocols, and many other specialists if available and required. And the main idea is to stabilize temporarily or permanently this patient to make their uncontrolled situation more controllable and predictable. And one of the procedure is rAAA, as everyone knows, that it can stabilize patient hemodynamics, central hemodynamics for certain minutes. And in this aspect, an aspect of EVTM, it works like on different types of support and assistance at the mechanical epinephrine. So we avoid using vasopressors and crystalloids for this period of 20 to 30 minutes to prepare ourselves to hemorrhage control or massive transfusion protocol. It's a kind of aortic clamp. It's a stabilizer not only for a patient, but also for the team, because to work with a patient with a systolic blood pressure 100 is much better and comfortable than a patient with a systolic blood pressure of 50 or 60. It's a life and cell saver, and there are papers demonstrating that less transfusion is administered to the patient who underwent rebore. Uterus saver and perfusion assistant is not new, but these are techniques that are developed, and in St. Petersburg we use very frequently rebore for postpartum hemorrhage, for placenta accreta. As I know, about 40 or 50 cases already done in only one city in St. Petersburg with very good results. So our protocol for trauma cases started with this line, where the patient is coming. We start with the vascular access, and depending on hemodynamic stability, if it's unstable, we just stabilize them with the rebore and can proceed with the CT scanning to perform CT angiography to identify the problem and solve it either endovascularly or in open fashion. Like in this particular case with the stab wound into the left chest with the huge abdominal hematoma, retroperitoneal hematoma zone 1. To control this hemorrhage, to operate in a dry field, we performed rebore, zone 1 rebore, and explore this hematoma to avoid extensive bleeding. There are different types of EVTM as we propose, maybe the general or systematic system EVTM, when we apply this for very difficult situation, unstable patient, unstable scenario, and in this patient, the patient experienced cardiac arrest, witnessed cardiac arrest. We started with rebore, and on Lucas device, it was return of spontaneous circulation, and no blood in the abdomen, was a huge wound in the perineal area, and we switched from zone 1 to zone 3, and that allowed to control this bleeding with the rebore followed by embolization of both iliac arteries. Another one is local, as you can see. Can I play this movie? Could you please press on the picture? The second one? No? Oh, yeah. In a patient with open femoral fracture and extensive bleeding, where we just took 15 minutes to puncture in antegrade fashion, puncture the femoral artery, put a stent graft for the patient with polytrauma with severe TBI and chest injury. And tactical, when we use it for military austere environments or in pre-hospital arena, when the circumstances are not very sterile, but we need to save life, have been demonstrated that most of the people die within first 30 minutes and not within an hour. So now, new paradigm of resuscitation. I heard from Michael Rotonda and his concept of no flow, low flow, and slow flow. It's a fantastic paradigm, and in pre-hospital we try to make our best to control the situation. And in this picture, you can see that we propose to use complete occlusion if the time of arrival is estimated time of arrival to hospital is about 20 minutes, less than 20 minutes. And then in the ER and OR, we switch to partial occlusion, as we have new very nice devices for this technique in the ICU. And further, we can modify. It's a kind of endovascular variable aortic control, as was proposed by Tim Williams and his team. Is it truly a rebore or something else that can save our patient? And in this study, we compared our data from rebore. This is the first analysis from 24 cases compared to ABO trauma register from different countries. And we found that it was not rebore, actually. Partial rebore was a predictor of death, but the main thing was crystalloids and massive transfusion protocol initiated. In our reality, we use more crystalloids, and we initiate massive transfusion protocol later than in other countries. And you can see it was a very important predictor of death compared to another group. Different types of local EVTM is seen. You can use it in GI bleeds, ruptured aneurysm, IVC injury. Even in TBI, this case is demonstrating how we embolize the epidural hematoma, which has an arterial source of bleeding. Obstetrics, as I said, it's developing more and more. And a couple of words about perfusion. We started using EVTM techniques for hemotherapy for cancer patients, and these are just samples of using it in real patients with liver perfusion, with full of metastasis from cancer, colorectal cancer. We isolate only liver and perfuse it using ECMO machine or heart-lung machine with the fantastic doses of chemotherapy. And the same we use now for brain and neck, as the picture at the right, for a local hemoperfusion with chemotherapy. Another one is limb perfusion, when in a tactical EVTM, in a bad scenario, when no one can explore the artery and shunt it and fix it, we can cannulate in typical places like here in posterior tibial artery and make a circuit, a perfusion of only this limb until the patient is evacuated to an area where someone can fix the problem. This is how it works in an animal study. We occluded arterial flow and IVC flow, and then perfuse only limb for 2 hours, for 3 hours without any adverse effect. So hybrid techniques are developing. It's a kind of shunting and vortex technique that can be used in hybrid embolization. When you open abdomen, you don't need to do endovascular. You just puncture the internal iliac arteries and inject gel form for temporary embolization. And I can announce that there is a sourced vascular register. You can see this this is a website link. You can go and see and register yourself with all the vascular trauma cases can be submitted, and we can gather all the data about it together to analyze it, like, for example, Prove It, Trauma Register, and many others. I think together we can do more. Thank you very much for your attention.
Okay. Stefan Olon, can you hear us?
Yes, I can hear you loud and clear.
Okay, good morning and welcome.
Good morning.
I introduce your presentation, Advances in Endovascular Surgery for Bleeding Control in Aortic and Abdominal and Thoracic Aortic Aneurysm Ruptured Acute Dissection.
Well, can you see my slides?
Yes.
Oh, okay, great, fabulous. Ciao everyone. Sorry for not being with you in Orebro. I would have loved to come back in this beautiful city. I'm going to focus my talk because in 6 minutes I can fix all the topics on ablation together around production, post-dissection, abdominal aneurysms, and those are my exposures. And one of the first issues I wanted to address is the issue of the backflow once you treat the dissection, the rupture dissection, backflow from distal epicures into the false lumen. And Keynote Talks described the implantation of a large occlusion device called the Camify. You can see here the device that will completely backflow to the ruptured outside. So this is how we do it on the fusion guidance after having implanted the endograft in the lumen to completely occlude the proximal epicure. We get access to the false lumen through another epicure, and then we position this large occlusion device in the false lumen at the distal level of the endograft. And once we have done that, you can see there's no backflow. The flow appears into the lumen, goes back into the false, and it's actually blocked here by the occlusion device. This kind of block that you can see here. So that's the best way to treat those dissected thoracic aneurysms that are occluded. This is an example of the ablation of the graft and such an occlusion device here. Now, sometimes you cannot do that because the lumen, the false lumen, is too large. And you actually have an aneurysm that involves the distal artery. So in those patients, we need to be behind the thoracic endograft, the bridge endograft, with a fenestrated or bridge endograft. Obviously, if you're talking about an acute case, it's more a bridge endograft that you need, and And then you really have to be careful about bridging, meaning that some cardiac vessel, this small vessel will be perfused by the trunnion and other fiber folds. Here you can see that right through acidic trunk and SMA are perfused by the full fluid. You need to find proximal entries here, proximal to the original cardiac vessel, and position your branches above that here. So you can see that the branches have been positioned above the here, and this will lead you to have quite long bridging stairs all the way to the cardiac vessel. Usually when we do such long bridging stairs, we will use line. Now, an issue with those coronary dissection and rupture is that most of the time you need to get a good proximal mechanism. You need to go all the way to the left coronary. So because we were covering a huge amount of coronary, because most of those patients are in shock, to reduce spinal cord ischemia, you need to keep the left subclavian open. So either you have off the shelf those left subclavian branch devices, or you need to do a bypass at the end of the procedure to the left subclavian. So those are examples of patients treated with such a branch to the left subclavian artery. Now, for the branch access to the distal artery, the real game changer has been the cerebral sheath, and we are using the larger one from Medtronic, the 16 French Aptus cerebral sheath. So now we can actually do we can access and implant and the bridging stents from the groin exclusively in maybe 95% of the patient. And this is an example of a patient that had a prior frozen elephant trunk that came to us with a rupture. We treated him with a branched endograft, and what I wanted to show you is that the cerebral sheath from the groin, you position it through the branch, and here this is the left subclavian branch, and then you have a very stable platform to go through the branch, and then with a catheter find your way to your target vessel here at the celiac trunk. So for the sake of time, I'm going to move forward. We perform a condom CT at the end of the procedure to check that all branches are nicely open and that we have excluded the rupture artery. Also, in those rupture cases, we tend to include the large intercostal to avoid type 2 endoleaks. Now, there's an issue that we have encountered during those large abdominal acute cases is that sometimes when you open your endograft, one of the branches comes through a communication tier, and you cannot access anymore the true ligament, for example, to get access to this left femoral artery. So in those cases, what we did is from below into the true ligament, we perforated the dissection membrane with a laser probe, and then from the branch that is through the communication tier, we advance the snare and manage to restore the route towards the true lumen and get access to that left renal artery. Now, an easier way to do that is to have off-the-shelf preloaded branch and fenestrated endograft. Preloaded meaning that you can actually have direct access to those branches from an axillary approach if needed. And this is one of those cases that we treated with such a case. But I don't know why I don't have access to my video, because I wanted to move forward and to show you how we do that. So here was getting access to the true lumen, because you see that we position true and false lumen markers to make sure that throughout the case we know exactly where we are. Let me move forward, because I'm not going to show you the whole case, but it's just to show you that despite those very large entry and despite branches opening in the true and the false lumen, with this preloaded catheter, we managed quite easily to get access to all those target vessels. And this is another example with a very large entry tier, and you don't know again where your branches are going to open. So to secure the access to the true lumen, sometimes what we do at the beginning of the procedure, from the groin, we push a wire through the communication tier. So in case the branch opens through this communication tier, we already have a wire that we can snare from the branch and restore the path to the true lumen. And this is example, just to show you that there are no real limits, technical limits, except that sometimes it's just better to do open, because don't make an easy open case, don't turn it into a complex endo. And having said that, again, you can see this young patient, 37-year-old, with a very large type B contained rupture with pain. We didn't wait and we didn't perform an endovascular procedure, because we still believe that open is the way to go. And again, here to prevent spinal cord ischemia, we restore flow to the left cavity during the same case. Another case, a young patient, also a very large thoracoabdominal aneurysm, but you can see huge in the thorax and not that large into the abdominal. So what we decided to do is to treat open the proximal part, which was ruptured, and then came back a couple of months later and treated the distal part with a branch and fenestrate endograft to reline the open proximal repair. So in conclusion, those endovascular cases to treat those ruptured chronic dissections can be very straightforward or very complex. You need off-the-shelf devices, but you also need a huge ancillary toolbox, including the laser probe, including steerable sheaths. 3D imaging is mandatory, because if you want to find your way from the true lumen to the false lumen, if you want to know at each stage where you are, you need this type of hybrid rooms. And obviously, you need to perform those repairs in high-volume centers that have an expertise, both in open and endovascular repair. That's all, folks. Thank you very much for your attention, and happy to answer to any questions if you have any.
Thank you, Stefan. Now,
Go forward. I think it's Martin, I'm not sure he's online, then it's Professor Frank Plani.
okay,
We will proceed
okay.
with.
Professor Frank Plani is here.
Is he with us?
Is online?
Should be on. He's not with us at the moment. And if it's not, there are some technical issues. He was here. Yes. Professor Plani, good morning. You're muted. Professor Plani,
Okay.
you have to open your microphone. It's the problems with
Yeah.
hybrid, the virtual world. Professor Plani, can you hear us? You're muted. Yes, now. We can't hear him.
Microphone is
Patrick,
off.
can you check it? Why? If it will be a problem, we can wait a bit and go to the next presentation. Ana Maria, what do you say?
Yes, with Thomas Larsson.
Let's do like this, Professor Plani. We will try to solve the technical issue, and we will go to Thomas Larsson on the meanwhile and get back to you. Patrick? Okay, we go to
Okay, to the
Thomas
next.
Larsson. Okay.
Thomas Larsson with the developments in bleeding control in endovascular times. View of a senior vascular surgeon.
I want to start to thank you, Tal, for giving me the opportunity to be here once again. When you started this 4 years ago, the first symposium, that was really a tough thing, but you have shown that it works. And also I want to thank your wingman, David McGreevy. So my disclosure, I was formerly clinical, working here as a clinical chief of the vascular surgery, and now I continued with the startups in medtech, one in California based doing a closer device, and one Vital Signs doing a platform technology company. And if I look back, what are the important milestones that is the reason that we are where we are now? I will say 25 years ago, we did the first rupture in in the United States of a ruptured aneurysm with EVAR. Catheter works, and here in Örebro we did the first case with a ruptured thoracic aneurysm during CPR, and that was a big step forward. But I want also to go to another area. What happened in when Silicon Valley started to develop in the 80s? The secret source of Silicon Valley was that there was a skilled research base as Stanford. There was a plentiful of venture capital and a steady spending from the US defense. And that created an environment that was excellent for innovation, for collaboration, also risk-taking. And an innovation space, I would call it. And this has, the endovascular procedures have facilitated bleeding control. When we look on the large selection of medtech products now compared with 20, 25 years ago, it's a huge difference. And we have infrastructural improvements. We have hybrid suits, we have emergency room with both MR and CT, and we have the accelerating development of the computer industry that, as Stefan Holland presented, 3D technologies that makes it possible to do things we couldn't think about before, and sensors. Sensors are very strong coming. This is a picture I had 4 years ago. I wanted more from new smart balloons, and absolutely, we have balloons for different, both in the arterial and in the venous system, large vessels, small vessels. We have new positioning systems. We have perfusion. We have local perfusion has developed a lot. And we have also we have emergency department protocol as early arterial access. And the pre-hospital protocols, not there yet. Someone would say that when you go to the scene of an accident, the ambulance comes and should they stay and play or should they scoop or run? I think we need to know more when it's benefit to do one thing or the other. What I think we haven't solved yet is to optimize the golden hour. We know from from research from many studies that early intervention in a trauma situation is a critical thing for outcome. And or I would say, here you will have a challenge. Why? Yeah. This is a hierarchical system. It is, in some reasons, very effective. That was how Napoleon once built up his army. That was the system that the industry, successful industry, built up their system. Think about General Motors. In the 50s, during the glance period, they were the biggest company in the world. When you have this system, you are a super specialist. You look down, every section you look down and dig deeper and deeper, but you don't look aside. And General Motors, they just dig. They didn't look aside. The world changed. The Japanese industry outcompeted them, and you all know the history. They went bankrupt in 2009. So, the golden hour today, there is an accident, you call an emergency number, blah, 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 and they say, okay, this is a prior one alarm, and we send an ambulance, and the ambulance comes to the scene, scoop and run, and go back to the hospital and start to monitor the patient. And then it comes to the emergency room, and then the trauma team takes a decision what to do, and they might go to the OR or to the suite or whatever. and you see almost the golden hour is gone when you start to do the intervention. How do we change this? Well, I think you must start with doing this. You must break down and start with a blank sheet, a blank paper, and think, what is optimal? What could be optimal? And I have an idea. Can you start the film, please?
He could be bleeding. His pulse is high, so we need to prepare for O negative blood. Can you sort that out?
Yes.
This is an example of how you can use the first aid platform to radically shorten time to decision and action and save lives.
Thank you.
As well as
Yes.
these are some technical difficulties. So we'll see Patrick, Martin Melina, Frank Clanny, and Lionel, who can deliver the next talk.
Malina is here.
Malina is here, yes.
Okay, good morning. I introduce your presentation about the modern technology, new tools, and the endovascular trauma management, endografts, embolization, and balloons. Where do we go?
Okay. I'm trying to share my screen.
Okay, full screen.
Okay, can you see my screen, guys?
Yes.
Good morning, everybody. Firstly, I must say that I'm really devastated not to be with you in person. I was so much looking forward to this, and you know it. But here I am in a dark, rainy London. And thank you, Tal, and everybody for arranging this and for giving me the opportunity to join you and present. I was asked to share my view on what will be the modern new technology and the new tools. And that is an obvious opportunity to, be aloft in just a few years. It's always difficult to predict. I actually think that the major changes will not be the mechanical plumbing aspects that we, or at least I, love. I regard myself largely as a plumber. But when it comes to the medical steps forward, I don't think I'm the right person to predict that at all. So I will stick with a simple plumbing and just share a few aspects with you. This is a picture showing how we worked not long ago, how we had to modify the stent grafts and stents and sheaths on the table ourselves. This is something that we have almost forgotten by now, because industry is supplying us with so much better equipment, and we now have access to gadgets for virtually any kind of situation that we will encounter. One technology that I would like to draw your attention to, that I'm a strong believer in, is the in situ fenestration. And the wonderful lady next to me here is Professor Furusan from Istanbul, who actually started this in her animal trials together with Medtronic many years ago. This is a grateful area to kind of practice in, because we have a safe playground in the left subclavian artery. And what this is about is, instead of trying to do fenestrations and branches and make them fit accurately in a difficult morphology, we just place a simple stent graft right across whatever vital branch there is.
And then you come from the periphery, or recently also from the graft itself, and you pierce the graft, and then you insert the covered stent and flare it. And here you can see some images, and I struggle to make my videos play, but these are our experiments with the glass models. And here is actually the very first human covered stent placed across the whole aortic arch. At that time, we used long needles that we inserted through the carotid arteries, piercing the graft, and then snaring it on the inside and dilating the hole in the diaphragm fabric and putting in covered stents, or in this case, even bare stents. And this is the patient very quickly after the operation, because you didn't need heart lung machine and you didn't need lengthy ITU stays. When it comes, sometimes it takes a little bit time to achieve the fenestrations, and then you need to achieve brain perfusion while you're doing the fenestrations. Initially, we used external bypasses from the groins to the carotid arteries, but we are also developing internal shunts, that is sheaths that you insert from the inside up into the carotid arteries. And the sheaths have large fenestrations beyond the aortic stent graft, so that blood flow can enter from the aorta into the shunts and go up into the carotids. And the sheaths are then retrieved once you have achieved your in situ fenestrations. And of course, we now also have started using lasers instead of needles, and steerable catheters, etc. The other technique I would like to draw your attention to is the fusion technique, where you superimpose a pre-existing 3D imaging onto your intraoperative fluoroscopy. And that allows you to see where the various branches are. It makes orientation so much easier. All of these were videos, but I can't make them play for some reason. I apologize for that. There you can see the wire coming in, and you see where the arch is and the arch branches. It's almost impossible to do certain things without the fusion. Here is the thoracoabdominal aneurysms with multiple intercostal and lumbar arteries that are notoriously difficult to target if you don't use fusion. But with fusion, you can identify them and then coil them in a preemptive way in an attempt to reduce the risk for paraplegia. This is the Leipzig group that is leading on that, but we embarked on it also in Copenhagen, and our initial results have been very promising. Yet another example, this is a patient with pulmonary arteriovenous shunts, the so-called morbus Osler, where it is so difficult sometimes to target these small shunts just under fluoroscopical guidance. But with the fusion technique, you can mark your pathway through the various pulmonary artery branches, and it makes it so much easier to target fistula. Yet another fantastic example is this, where you use a catheter with a marker on its tip, and through a complex algorithm. This is actually the Philips force technology, where the laser light passing through your catheter can be read by a computer, so that the computer recognizes the shape of your catheter. And if you combine that with the fusion technique, then you can navigate through the body without the need for continuous fluoroscopy, and you reduce the need for radiation. And this is the perhaps latest technique that has been around amongst the cardiologists. It uses a magnetic field to recognize where the catheter sits. You can see that it's you put below the table this device that generates a magnetic field that then senses where the catheter is. And on the right here, you can see from this year's VEITH conference in Orlando. This was a video where we had a catheter in our hand and could maneuver it and see on the screen how it was moving relative to the aortic model. So those are the techniques that I currently believe are most important: the continuous refinement of the gadgets from the industry, the in situ technology for the difficult morphology with multiple branches, and the development of 3D imaging that will allow us to work more accurately and with lesser need for radiation. Thank you very much.
Congratulations. Thank you. Is Frank Plani here?
Yeah,
Okay.
I'm here.
Okay, can you hear us, Professor Flani?
Yeah, I can hear you. Can you hear me now?
Yes. Okay, welcome. Welcome. What is new in trauma management for hemodynamic unstable patients in South Africa? Where does EVTM come in?
Yeah, I cannot share the screen while other people are sharing the screen. So
Yeah, we will fix it. Patrick will fix it. You will share the screen, no problem. And then we will later on try to have a discussion here, both virtually and in place. We have, after Frank Plani, one more talk.
okay, so basically the report in South Africa, update and short-term lessons. What have we done and what can we do now? Now, just a little wrap-up of what we've done. 30 cases in Johannesburg from 2017 to 2021. Only one in 2021, actually. Not only Reboa, but also hybrid, in which we wanted to do a Reboa, and then we decided to, in an open procedure, to actually put a sling around the aorta, do a multi-cross clamp in that way. Also because until recently, officially with no Reboa catheters in the country. So at the moment we couldn't pinch them from conferences because of COVID, but we found ourselves without any Reboas. They've also managed to do 3 trauma cases and 1 upper GIT bleed in KwaZulu-Natal, and 1 pre-hospital case done by a trauma surgeon in Johannesburg for an trapped patient who was trapped under a truck. In terms of cases, you can see in terms of trauma cases, quite a few, not great survival, not a great survival rate. And I think most of them, however, died after a few weeks because of the days or weeks, because of the nature of the injuries, not immediately because of failure of Reboa. We've done a lot of placentas and both extrauterine pregnancies, placenta accretas and secretas, some AAAs. And again, these are not all Reboas. There are cases where we may start with a Reboa, or we wanted to do a Reboa and decided, like this 15-year-old girl, we thought the vessels were very small, we just placed a central line in the femoral artery, then opened up, so it could actually it was easy to actually cross-clamp the aorta, and then we did what it did. So in principle, we're going to practice Reboa now that we got it available, and I'll tell you the pathway, how we got it available. 80 femoral access for everybody, 80 femoral access, and have the emergency room thoracotomy set ready in case it fails, or in case you can't do a Reboa. Needs assessment. We're going to need Reboas in the future now that we got them available. With 20,000 attempted murders, 200,000 assaults, GBH, grievous bodily harm, I think yes. Also, wasting blood in South Africa is a crime. We've got less than 1% of the population of blood donors. Of that, actually down 60% during the COVID lockdowns. We're only getting about 400,000 units of blood available, where according to the population, about 60 million, we probably have about 1.2 million units of blood available per year to be able to compete at normal levels, to actually follow suggested protocols in terms of early blood administration. Only 8 medical practitioners per 10,000 population, of which only 3.5 per 10,000 population in the public sector. So basically, you need to team up and train whoever is available. And basically, it's really encourages the concept of multidisciplinary team, which are mainly anybody that's available needs to be trained. And we can only spend about, well, $550 per year per capita of health spending, so we can't really go and splash out. So from approval to reports on the ground in November 2017, the funders, private funders mainly said, yes, perhaps not a bad idea. But it took quite a while, basically until August 2021, to actually manage to get officially 10 rescue reboa catheters in South Africa. And in November 21, we really introduced them to DLCC course, which we are running at WITS, and then basically not to do it a reboa course, but basically to show the advantage of having access, early femoral access, and be able to combine hybrid surgery. So reboa training, so basically we think it should be not only for trauma surgeons, there are only 30 practicing trauma surgeons in South Africa, and only 4 trauma units with on-site trauma surgeon 24/7 for such a large population. Most other units manned only on site by surgical registrars, covered by various surgical fellows or consultants remotely after hours. But we've got well-trained emergency physician, very keen and very good practice in doing ultrasounds. And this is what we're looking at, introducing basically dry simulation mannequins, as well as being able to work on live animals. The plan of action, therefore, is emergency physician, peripheral hospital surgeon to be trained on femoral access, credentialing by vascular surgeon, intervention radiologists, vascular access skills, identification of the indications of acute care surgery as well as trauma. Very few centers at the moment where you can actually say if the reboa is not successful, people are going to immediately do an emergency thoracotomy by somebody that's going to do it knowing that it's going to be done well. So the launch, we plan to launch in early 2020. We started with a Zoom meeting with about 50 trauma surgeons, acute care surgeon, emergency physician institutes on 29th of November. Under the auspices of the Trauma Society of South African College of Emergency Medicine, utilization of reboa during DSTC, practical skills and scenarios, and face-to-face symposium early 22. Reboa versus emergency thoracotomy. So at the moment we feel it can replace for profound patient shock as the first step for damage control. At the moment, we should really replace emergency thoracotomy in dying patient with CPR in progress. In conclusion, a short exposure to reboa has taught us important lessons. Clamping the aorta by whatever means should not be limited to trauma, and reboa has proven a great temporizing tool with facing delays in multiple patients, and substituting reboa with open aortic looping may be suitable in some cases, but not for all. And therefore, we think in our setting, we need to be familiar with both techniques. I thank you for your attention, and thank you for inviting me, and I'm really sorry I'm not there. Thank you.
Thank you very much. The last speaker is here. Lionel Lamourt is here or is online?
I am online.
Okay, good morning.
Morning.
Endovascular resuscitation, what is new and what is coming?
Thank you for the invitation. We will discuss shortly about what is new and what is coming probably in the next year or 2 years. First of all, my conflict of interest. Okay. First of all, I think what is new is the dissemination of the techniques. Everywhere in the world, just said before in South Africa, in France in this course, or yesterday in Norway, everybody learn how to do or reboa or CPR or all techniques endovascular. This is a first step. If we would like to have more and more cases, is to knowledge the techniques. And in a lot of conferences too, we have now a lot of subject about this topic. Second point is trauma and reboa. Today, I think it's angel and demon. We don't know exactly the literature, what is a good way to think in. But I'm not sure the methodology was used is a good one in trauma, in severe trauma. We know they are very different between two different trauma. And we know if we do nothing, the control group is dying people. This is why I'm not sure the statistic, like we're doing RCT, for example, are the best way of thinking. What is a good control group, in fact, we don't know correctly. Have we to use a Bayesian model? Probably yes, and a selection by Bayesian model. And you know the Bayesian model, it's a statistic model where what the doctor thinks is included in the model. And for the selection of the patient is included inside, and we keep in mind what happened the last time. That's a way of thinking, probably, to design the new study. And what happened? We have developed, for example, in Paris, we are able to do pre-hospital REBOA zone 1. And we know the challenge of timing is, and if a doctor on scene can do a REBOA zone 1 or zone 3, that means we can save more life probably. And that's possible because ER physicians now in the setting are more and more huge and are able to do these techniques. I think the major shift is the REBOA in medical indication. And the most important one is for medical out-hospital cardiac arrest. You have in this slide the physiologic interest. We block the flow to have more flow on the brain and on the heart and the coronary artery. And that's amazing things to think can replace epinephrine. In fact, we do exactly what we would like with epinephrine by mechanical way, without any disadvantage of epinephrine to have a vasoconstriction on the brain. That's probably the major things in the next years. And we have done some study on SWIN with my team, and we've seen clearly, if we compare to epinephrine, REBOA look like to be very interesting in terms of blood flow and on less complication. And some team now doing on the field, they use REBOA in cardiac arrest after a fail of advanced life support. And you can see the blue one is without any trauma, it's a medical one, green one is a medical one. The number is very few, it's few patients, but anyway, we see an increase of CO2, that means doing the work we ask for perfusion. And the last point is the new guideline of cardiac arrest. You've seen we have ECPR inside and an increase in level. In fact, we can do in or out of hospital. That's the first time they said we can do in out of hospital, but we have to have some guideline to do that. And probably they increase the level of proof by the study of Minneapolis, who has stopped after 30 patients compare ECPR group and standard advanced life support, because the number of survivors is so huge with ECPR. Change your mind, because if we have a remember of the algorithm, I take out everything without any RCT or proof. Epinephrine, cortisone, everything, amiodarone, have no proof. Now ECPR have one. That's a major thing, I think. And now a lot of teams try to decrease the time, like we're doing in Paris in the hospital, to decrease the time to do ECPR and do ECPR like the advanced life support. Very shortly, English group do at 30 minutes. And now, to conclude, we have a lot of new strategy about cardiac arrest or shock, in fact. The interest is to say we have to monitoring what we're doing to have a pressure, and we can be helped by medication. But if we are not enough increase the pressure with medication, we can do, for example, mechanical device like REBOA. That means we have to include a line of treatment, different line of treatment when we have a severe shock or cardiac arrest. My conclusion is REBOA increase endovascular resuscitation, ECPR, REBOA increase day after day, because we have more and more practitioners and we have more indication and more proof. For the first time, we have since 20, 30 years, we have a techniques increase the survival rate with good neurologic improvement in cardiac arrest with ECPR. That's amazing things. That means probably grow and grow more and more. Thank you for your attention.
Thank you very much. So now I think that this session was a great overview about the EVTM application, and all of us have a lot of questions in our mind. So I invite you to do questions and to open the debate.
or comments.
Or comment, consideration.
And we have online with us the people speaking, so they're of course available as well. Just one comment. I can start just one thing with Professor Moore. You said about trauma to the extremities and endovascular method. I happen to agree with you, but the question, it's possible to solve problems with endovascular tools on the bleedings. For example, a 20-year-old that is bleeding, you can solve it with a stent graft very easily. But I guess you would say, no, don't do it. Can you elaborate on it a bit? The place of open surgery and how to think about it when you can do endovascular surgery, from your point of view as an experienced trauma surgeon.
Well, I think, again, it's a lot depends on the resources available and, of course, the patient's situation. If a patient has advanced traumatic brain injury, complex liver injury, and has an SFA transected, sure, I think a stent's a reasonable choice. We also have the option, as you well know, that under conditions of multi-system trauma, we can always place a shunt and come back the following day to repair the vessel. So I think the stent would be attractive in certain scenarios, but I still would submit at this point it's a relatively small number. Now in the future, when we have retrievable stents, and I know those models have been used experimentally, that becomes very attractive. Put a stent in, have the patient physiologically restored, follow the next day, isolate the vessel, take the stent out and repair it. And I would forecast that that will be in the future, particularly for large vessel injuries.
Okay, thanks, Professor. I have also an observation, a question for Professor Moore. You showed a very nice case about a retrohepatic lesion in traumatic injury of inferior vena cava. Do you use rBOA in the inferior vena cava traumatic lesions routinely, or what is your opinion about that?
Well, in the vena bypass case, we used the rBOA in the retrohepatic vena cava at the suprahepatic level. Now, there are, as you all know, venous balloon catheters that are probably more suitable for large vena cava. But in that particular patient, we used it in the retrohepatic vena cava. We've also used, I'm sure others in the audience have as well, we've also used the rBOA in infrarenal and iliac vessel injuries.
Okay, thank you very much. Other questions, observation? From my point of view,
Yes,
sorry.
We have microphones
Sorry.
here.
Tal?
Yeah. Yes, we hear you.
Yeah, I just heard something that I really fancy, the mention of retrievable stent grafts, and I would like to remind everybody of the work of Shinichi Maru, who designed and actually tried the first retrievable aortic stent grafts, I believe. The one thing that we struggle with a lot is once the patient reaches hospital, who should be doing this? And because I think that once you are in hospital, you should actually have access to the usual endovascular gadgets. And should you then be using particular rBOA devices, or should you be using the balloons and catheters that we use routinely in elective work that we have at ready for the occasion when we actually cause a iatrogenic trauma with bleeding? What is your view of the panel and the participants on that?
Someone wants to answer or comment on this?
maybe we should move on. Okay.
Yeah, thank you, Martin, from Helsinki and ESVS. Thank you, everybody, for excellent presentations and Tal for this really, really great meeting. I have a question for Stefan Hulon. Hi, Stefan. It's a pity that you aren't here. I would like to ask on those complex endovascular procedures for rupture patients, for example, T-branch, which we can do technically. But I have found that the problem is, at least in our cases, that the risk of paraplegia is huge because patients are hypertensive. And if you put them in general anesthesia, they are even more hypertensive. I have done one case in local anesthesia, and actually that case didn't get the spinal cord ischemia. So what have you done to avoid this problem?
Hey, this is Marit, correct?
Marit, yes.
Hi, Marit. Nice to hear you. It's a very, very important question. And those ruptured thoracoabdominal cases, if you treat them open, the spinal cord ischemia risk is even higher. Now, if you treat them endo, it depends if you're talking about a real rupture or if you're talking about a contained rupture. Because I think in the first case, there's no other option than to treat them from top to bottom to completely exclude the ruptured aorta. In the second option, there's always the option to stage it. And you've seen a couple of cases I've shown where we decided to go open for the proximal part to only treat a limited length of aorta to reduce the spinal cord ischemia, and then to come back later and do the distal part endo as a stage approach. Now, apart from doing the usual adjuncts to prevent spinal cord ischemia, I have no specific tricks, but we are very aggressive in giving them hemoglobin to keep the hemoglobin level above 10 or 11. We're very aggressive in keeping the glycemia with insulin at a normal level. As soon as we have treated the rupture, we increased the mean arterial pressure so that it's above 85, and we wake them up as soon as possible if there is sleep, and if there's any weakness, if there's any signs of spinal cord ischemia, then we would drain them right away. We do not drain them routinely, especially for rupture, because we don't want to waste any time. We want to get them on the hybrid room table as soon as possible.
Thank you.
Pleasure.
You.
Any other comments?
Any other comments, questions? I would like to highlight, from my point of view, in the presentation of Stefan and Martin Malina, the role of three-dimensional imaging and the fusion imaging. In compliments and congratulations for your cases. I use it in my daily practice, of course, only in elective cases at the moment, because and at least in my experience, it was they are very, very important, and they change your procedure, they improvement your procedures, but they are very time consuming, and it is necessary a team training, and you have to spend some months to do it. What in your experience?
I think this is a very important point that you're raising here. And I think it really depends on the type of system that you have. When residents and fellows arrive in my department, after a week, they know how to use the system 24/7. So it is actually, we do not need a specific PhD that is on the workstation to make this work. The workflow is very user-friendly. Even a surgeon can use it. And you have to make it routine so that when you need it in an emergency case, there's nothing different from your everyday practice. But again, I think that all manufacturers have made huge efforts to make those systems user-friendly in order to be able to use them also for those acute cases.
Yeah, thanks. Martin?
how about you, Stefan? But I usually set it up myself. I think it's then you can also choose wisely what you want to mark and where you make your preference to make the fusion as accurate as possible. And as you said, the development has been tremendous. The software is now so much easier to use than in the early days when the number of steps to achieve the fusion were so many that we, as you said, needed special dedicated technicians who would do it. Now I think the operator should be doing it himself, actually.
Okay.
I fully agree, and this is a 3D world where you and I, Martin, are part of the dinosaurs, and the young generation. It is for them. It is what they have been raised with. So it's really not an issue to switch to those imaging techniques.
Yes, I agree with you. At the beginning, when these systems were introduced, you can't move the patients because if you move the patients or the landmarks were lost. Now we know that it's not so. So you can do enlargement of the imaging. You can choose the position of the patients, and nothing change in your practice. But we are at the moment at the beginning, so we are training our staff. Thank you.
May I ask, just both from Zoom, all of you, and Professor Moore here, but are we going too far? You know that we get a bit, as Thomas said it, and we're getting it today, are we going too far with endo? Lionel, the point that you have ECMO, does it mean that I will use it? And then we will say the same about rBOA, we will say about grafts, and I would like to hear what you're saying. Stefan, also you mentioned some open case you did. So we can do a lot of things with endovascular tools, but does it mean we should use it? And how do you see it? If we can start with Lionel.
Yes, we can do a lot of things now with endovascular resuscitation. Now the good point is to do something with science and to be sure what we're doing. And if we have good tools. Today, we are believer, we think it's good, we have example, but probably we have not enough proof of effectiveness. But for ECPR, for example, this year we have a major evidence to say it save life. And I think we have to thinking about what is a good design of study for this type of patient. This is why probably today we have so much variation between two studies in trauma patients, for example, for rBOA, one time is good, one time is it's not good. It's very complex to have an understanding. And this is why probably a lot of people are afraid to use it and use all this endovascular device. And we have to fail over all the barrier we have in the spirit to use it more and more.
Okay, other colleagues?
Well, I'd make a closing comment, which is controversial, but I would submit that a lot of these advancing endovascular techniques in the soon-to-be bed trauma patient could be viewed as an opportunity to salvage organs, a highly ethical issue and dealt with differently around the world. But I would guess in the next decade, we're going to start using some of these techniques in the pre-hospital arena and early emergency department area to be able to recover organs for transplant. It may cost one patient's life who is already dead, but save 3 to 5 others.
Okay, any Stefan?
Yeah, can I just add that those are great comments, and when you look at the outcome of a patient with a ruptured thoracoabdominal aneurysm, usually that are really not that good, and that's why we're pushing the envelope with this minimal invasive therapy, having in mind that this is not a war between open and endo. And I think that the critical take-home message is that you need to have those cases arrive at places where you can do both open and endo to find the best strategy. It can be a stage strategy with both options. But obviously, we are working differently than we were 10 years ago because we have those endografts, we have the imaging system, but it has to be a multidisciplinary approach with the the ICU people, the surgeons, CT surgeons, vascular surgeons, trauma surgeon. I think the multidisciplinary team is the best way to go, and that's really something I would like to emphasize.
I've got a raised hand. Yeah, a comment I'd like to make is that we've seen the Cristiano Baragona Academic Hospital Trauma Unit. We used to average about 5,000 resuscitations a year. And there'd be probably about 2 or 3 emergency room thoracotomies a month, or sometimes even 5 or 6. And the moment you realize the implication, the complication that come from an emergency room thoracotomy, the fact that often you're delayed because you think perhaps it's unnecessary, you're going to lose a lot of blood, you're going to lose a lot of heat. To actually be able to say, now, for a start, I'm going to access the femoral artery, and then I'm going to see, and then I'll be able to put a reboa quickly if I have to. You'll be a lot more prone to do it in when it's needed rather than too late. And I think that's my main impression that I get. Even situations where we're borderline, and true enough, until now, with very few reboa catheters available, our selection may have been not too good. We've put in patients that probably had no prognosis in the first place. But clearly, there's a big difference between putting a line in the femoral artery, inflating a balloon, and opening the chest, sometimes bilaterally, because you can't really have good access in a morbid obese patient. And clearly, that really makes it a lot easier. So I think it's just the ease of doing things. Sometimes it's bad, but in this case, I think it's very good.
Okay, Martin, any final comment from your side?
I think that so many cases you can't solve with endovascular technology, and the problem in real life is that what will remain for open surgery will be the very most difficult cases. And those cases will need to be tackled then by people who have less and less experience of open surgery. So unless you are in those really world-leading large centers with huge volumes, this is a practical dilemma. And I think that we will be going increasingly towards the endovascular technology, and we will have to accept that there will be occasional patients that perhaps could have been solved earlier days with some master open surgeon that we won't save in the future. But for the benefit of most patients, I think that the endovascular technique is the way to go.
Okay, so I think that we can close the session. Thanks to the colleagues that are online. Thanks to the technician for the efforts for the connection. And thanks to everybody for your contributions. Thank you.
We go to the next session directly. Just feel comfortable here. If you want coffee, there is coffee outside. The Zoom participants, again, this was a COVID-related problem that we're doing hybrid, and they can stay with us. So we go to the next session and continue. Thank you very much.
timetable. So now we are coming to the next session, which is on access, the first part of the management, both in trauma and in other austere situations. We have a setup so that I'm here, Stefan Ullon should be stayed on the Zoom. Claes Forsell is a bit late, I heard. So we have Per here, Per Skog from Örebro, but you moved to Gothenburg. To Gothenburg, yes. And then on the list we have panelists and speakers. So in order to activate, I invite panelists to come to the podium and ask questions and discuss. So please feel free to come up here. Hello, Martin. And then I think we should start with Jim Manning talking about the landmark papers on vascular access. And is it so that Jim is on Zoom or here? Ah, here.
May I just comment? We have microphones here. If people want to speak, we want people to speak. Our students here with microphones will come to you. Just raise your hand.
Yeah, we noticed that it's a bit difficult to ask questions, so Tal promised to add more microphones to the auditory.
Okay, all right, good. So just waiting on the slides, I guess. Well, hello, everybody. I'll just start by saying thank you to Tal and all the organizers for the opportunity to be here at EVTM. It's great to be somewhere other than stuck in my home. So it's nice to be traveling. It's the first time across the Atlantic in 2 years. So it's a pleasure to be here. So I'm going to talk a little bit about vascular access, particularly femoral vascular access. Okay. First disclosures is I've worked on a technique called selective aortic arch perfusion. It'll be discussed a little bit here. Defense Department funding and a corporate entity to try to advance these. So those are nothing on the market. So not promoting any product now. Endovascular resuscitation is clearly advancing, and I think beginning to advance rapidly for both trauma and non-trauma. And we are, and even though those techniques vary in terms of which what is used for either trauma or non-trauma, or how they're used, there is some variation. But the common pathway and the overlap between all of these endovascular resuscitation techniques is femoral vascular access. And while I was studying, reviewing the literature as part of developing an endovascular course to teach that, I was struck by the fact that there's a lot of literature on vascular access, but a lot of it has to do with TVAR and various things. There's really very little literature specifically on emergency vascular access for endovascular resuscitation, the sort of thing that we're doing. So it seemed appropriate to begin to sort of build a little bit of a literature in this area, which led to this review article that was just published a couple months ago, or in the past couple of months, on femoral vascular access for endovascular resuscitation. And it just so happens that the genesis of this review article was a discussion at the Pan Am EVTM meeting in Denver, Colorado. All of the authors that are on this paper were at that meeting. We all kind of talked a little bit about it and decided, yes, let's write a review article on vascular access for endovascular resuscitation. And what we sought to do with this review article was to describe the key anatomy, the important anatomy that we need to know for endovascular access and resuscitation. Now, obviously, I'm talking to, this is like preaching to the choir. I know everyone in here is involved in endovascular resuscitation, knows vascular access. But as we expand this into more and more centers and start teaching younger people and more providers, emergency physicians, interventionalists, whatever, to do endovascular resuscitation, we're going to need some tools and stuff to help teach this. And one of the things that was clear as I was trying to develop this course is that for many people who are interested in endovascular resuscitation, they have very little experience or knowledge in the area of femoral vascular access. So with a number of, with descriptions and with some high quality medical illustrations, we hope to be able to promulgate this and add something that can be used for education. So just defining landmarks that are important, understanding the fascia, especially if doing a surgical access technique, what you're going to have to deal with in order to be able to identify the vessels. And so those sorts of things. What the course of the size, the diameter, the course of the common femoral artery, and how deep it is if you're doing either percutaneous or a surgical technique. So we just wanted to actually have some good anatomical description and figures that would actually help teach this. And also just how the relationship of the artery and the vein changes. And again, all of you know this, but how that change in relationship where the vein can slip behind the artery can actually lead to, in hypoperfused states, low pressure states, can actually lead to inadvertent problems like percutaneous going through the artery and going into the vein, misplacing an endovascular catheter that could have, one, not provide the endovascular control that you want, but also potentially have deleterious effects. So the anatomy, some of the pitfalls. We also described at least the essentials of percutaneous technique, the anatomy that you need to know, what it looks like when you're doing endovascular resuscitation, or what you're looking for for needles. There's more detailed stuff on percutaneous, and there are videos and stuff that are good, but we at least wanted to cover the basics on that. In addition to the percutaneous, we felt it important to describe how to do surgical access, with the notion that although many people when doing endovascular resuscitation will probably attempt to do percutaneous access, if that fails, that shouldn't be the end of your attempt to try to save these patients. So all of the practitioners that are going to be doing endovascular resuscitation should be fairly facile, not only in percutaneous access, but also in doing surgical access, if need be, in order to place a resuscitation catheter. So we went through that in detail, again, with some illustrations and photos and stuff to try to give people a sense of what this anatomy is. And that's sort of the purpose. I think our goal is to try to help begin to add something to the literature that will actually be useful as we educate new interventionalists, new endovascular resuscitationists. And I would just simply say, sort of in this last minute, there's a lot of anatomical variation stuff. I would actually suggest that this organization maybe consider trying to begin to pull together essentially like a little library of photos, ultrasound images, maybe if there are photos or videos of vascular procedures, and pull those together so that those could be used as teaching materials for young trainees or others who are getting involved in endovascular resuscitation. And with that, I say thank you very much.
Thank you. Now, I think you can join us here. And we'll continue, or do we have some immediate questions now? I think we're really starting from the basics, and you identified the problem because without the access, we are doing nothing. But I think we're going to hear a lot about access during this session. So Martin Delle from Stockholm SÖS is continuing. Please, Martin.
Thank you. Good morning, everybody. Special thanks to TAL and the committee for fixing this event again. It was quite some years ago, and I'm really appreciated to be here again. So the next few minutes, I will try to give some practical points regarding access, especially femoral access. And what struck me when I began to think more systematically on this is that when God created us, he must have realized that somewhere in the future we would be subjected to endovascular interventions. And then he designed the femoral artery, because the femoral artery is perfect to get access. It's quite shallow and it has a good width. It's easy to feel the pulse. It's not tortuous, and afterwards it's easy to compress against bone structures. So far, so good. But in reality, when you come into a trauma situation, things can be very dramatic and very, very difficult, and I speak from experience. The width can be very small when you have hypovolemia, or if you have spasm in the vessel. It might be a child you try to get access in. It might be obesity. And not least the stress you feel when you are in a room with a dying patient with 20 other doctors or nurses trying to get a room for their special actions. And even though you have a controlled situation, we know from literature that there are severe adverse events in about 3%. Hematoma and also extremity ischemia occurs now and then. So my perhaps most important message today is use ultrasound, because in a trauma room there is almost every time an ultrasound machine. Use it. We know from literature that using the ultrasound decreases the risk for severe hematoma and damages to the vessels significantly. And use the linear transducer. That means we are at a high hertz level, 10 megahertz or more, and I would suggest an axial image. So you get the puncture at 12 o'clock in the vessel, because that secures good result from a closure device later on. I don't use a needle guide. You can use it if you want to, but small adjustments with a needle is easier if you don't use a needle guide. And ultrasound is also excellent to orientate the anatomy. You can see where the profundal takeoff is, and you also can see where the inguinal ligament is, two very important anatomic landmarks. So you can very well start with the longitudinal view, where the inguinal ligament is located where the common femoral artery dives into the deep parts of the pelvis. And more distally, you can easily identify the deep femoral artery. And there, somewhere in between, you can put your needle. And then I turn perpendicular. And if you're unsure which vessel is vein and which vessel is artery, compress the transducer, and the vein will be compressed before the artery. I forgot to say, when you infiltrate anesthesia, go beside the vessel, like the arrows up there, so you get anesthesia on the sides of the vessel and in top of the vessel. That prohibits spasm, which is a rather lousy condition. And then do your puncture at 12 o'clock. Now, if you are in a stressful situation where there's no ultrasound available, but you have fluoro, then you have some classical landmarks. You can aim your needle at an entry point 1 centimeter medial of the lateral aspect of the carpus femoris, and in between the cranial and lower part of the carpus, and go with your needle through the skin some 2-3 centimeters further down, and then enter in the middle center part of a carpet, like the red cross here. And here, when you put in the guide wire, always check with fluoro when you advance the guide wire, because you have to avoid to get the guide wire position in the artery of ilium circumflexa profunda. It's a small artery following the ligament, and if you go there in with your guide wire and push your introducer in, you can create a huge bleeding. And if you have no fluoro either, then you go for anatomical landmarks. Find the superior spina iliaca and the pubic tubercle, and then you go for 2-3 centimeters below that. And you can do, while you do your anesthetic infiltration, do frequent aspirations, and suddenly you will feel that you get arterial blood in return. And then you can advance your guide wire and get in with your micropuncture set and exchange for a 035 wire. So this is what I use in each and every case. It's a 0.9 needle. You can't do any harm to the structures in the groin with such a thin needle. And you aspirate until you get arterial blood. And this is the situation if you can't feel any pulses, you don't have ultrasound, or you don't have fluoro. So lesson learned is use ultrasound, very important if you have the ability. Be sure to have be sure where the guide wire position is, so you don't are in the wrong artery, which can create great damage. And if you don't get blood return, check with contrast so you don't advance your guide wire subintimally. And beware of the circumflex artery. And if you have difficulties getting in with your introducer, use a stiffer guide wire like an Amplatz super stiff. Thank you.
Thank you, Martin. Now I think, does everybody agree on all of this? You're an angioradiologist, right?
Yes.
Yeah, okay, so I know Pekka doesn't agree. We train in longitudinal always, but of course we use axial at some point as well with the ultrasound. So I put two questions to you. One is sterility and one is in the trauma or the emergency situation. And one is whether to always perform axial ultrasound, because we are used to puncturing very calcified, because we do for atherosclerotic people. So there, at least, the longitudinal puncture system is much better, because you can navigate the calcifications and so forth. You can do that in axial as well, but that's probably what you're used to, but I would disagree there. The other question was that in the emergency situation, how important is it to cover the ultrasound probe and have sterility?
Good points. I think the greatest advantage using axial imaging with ultrasound is that you get your puncture at 12 o'clock. If you have a narrow artery and you go longitudinal, it might be that you get your access within the vessel at 10 o'clock or 11 o'clock or 2 or 3 o'clock. And then you will have great problems when you put in your closer device. But I can agree that the calcified plaques might be better visualized if you have longitudinal. But the great majority of trauma patients are not have arteriosclerotic problems. So, well, it's a matter of what you're used to do. So I think it's up to your own preference. The second question was in the trauma setting, if... Sterility, yeah. I would say if it's extremely urgent, just use some alcohol from where you wash your hands and take on the skin, and use sterile gel. And you can also take the alcohol on the transducer, and then you have a rough bacterial wipe out and puncture, because if it is that urgent, the patient will definitely not die from bacteremia or septicemia in that situation. It will probably save his life or her life if you come into the vessel very rapidly. So I would say that takes some 15 seconds just to wipe out with alcohol. No green dressing, no scrubs, no nothing. Just go in.
So this would be well, the ultrasound companies might not agree with you, because putting alcohol on the ultrasound probe is not a good idea in the long term. Other questions?
Yeah, a comment.
Hi, Martin. This is Martin from London.
Hello, Martin.
So for the sake of the argument, I completely disagree with you. We just heard one of Sweden's most skilled interventional radiologists, who is used to working in a brilliant environment. I think that if you are in the scenario of a messy operating theater, or even worse, emergency room with staff who are not trained, etc., I think you should definitely go ahead without ultrasound. You don't need ultrasound to puncture the common femoral artery. And the anatomical landmarks to me are the spina iliaca anterior superior and the tuberculum pubicum, because it's between those two that the inguinal ligament runs. So if you put your thumb on the spina iliaca and your index finger of your left hand on the tuberculum pubicum, then you know exactly where the inguinal ligament is. And if you then puncture just below that, you're extremely likely to hit the common femoral artery. You will, as Martin said, feel the femoral pulse, except in the patients who are in shock. They may not have a palpable pulse, but then you are really in a hurry, and instead of searching for an ultrasound machine and somebody who can plug it in, etc., you can, under local anesthesia, incise the skin and perhaps with your fingers tear apart the fat. And you don't need to expose the artery, but simply by opening the skin and opening bluntly the fat, you will be able to palpate even a pulseless common femoral artery and then go ahead. And that takes just a few seconds.
Thank you, Martin. This is actually very important when you're planning your training, that should you include the ultrasound in all the ER procedures and so forth. But that's probably local decisions on how to do it. Per, you had a question?
Well, a short comment. I don't really like to choose either or. So I have a actual approach in the beginning until the point I'll get blood response, and then I just shift the probe to a longitudinal, and that's my routine. And it's really usable if you are going in a antegrade.
I do agree with you that we often do so, that we do longitudinal first, then you see the needle and everything, and if the visibility is suboptimal, then you change to axial. So yeah, I agree with you totally. More comments from the panel. Good.
Yes, Anna Romagnoli from Baltimore. And at our institution, we have shifted towards early arterial access in patients with a potential for decompensation. So that gives us the luxury of doing things in a sterile situation because we're not waiting for them to crump before we try to get access, and makes it more easy for us to utilize ultrasound because there's less chaos going on. So I think that kind of ensures that we have common femoral artery access in a sterile scenario before we're instrumenting the vessel any further.
And one more, and then we're moving on.
Yeah, just comment about the Federico Coccolini from Italy. I'm just to comment about the infection risk you mentioned regarding sterility. It has been demonstrated since the 80s that excepted for the orthopedical issues, no higher risk exists for trauma patients with invasive access, thoracic tubes or chest tube or others. So no need for real sterility, no need for preparing all the stuffs with the cover and the sheets and everything. So just to clean up the field and then proceed.
And then you can do the emergency stuff, and then you can maybe convert to more sterile. That's the other way around, yeah. But we need to move on for time, and we have Anna Maria again here on the podium. Please join us and tell us everything about difficult vascular access tips, tricks, and solutions.
Okay, good morning again. The difficult access tips, tricks, and solution. Vascular access is the first step in EVTM, so it is very important, and the time is a factor that you can't forget. And all of us knows which are the percutaneous approach. The femoral one is the preferred, of course. And you have to consider that in some situation, unstable patients, obese patients, or patients with the calcified arteries, the vascular arches should be not so easy to obtain. In unstable patients, because they are hypotensive, the pulse may be weak or absent, the blood may be dark or not pulsatile. In obese patients, you have a distance from the skin to the true lumen of the artery that sometimes should be more than 5, 6, 7 centimeters. And in calcified arteries, sometimes it's not easy to obtain with the guide wire the true lumen. So keep calm, breathe deeply, and carry on. Time is life, but you have to maintain your calm and go on. You have always be ready with an HS kit, and I suggest to have more than HS kit ready, close to you. All of us well known which are the anatomical landmarks, and you have to keep in your mind always the anatomical landmark that we remember last 2 minutes ago. And And the Seldinger technique in this situation sometimes is not feasible or not recommended. So my suggestion is to use the ultrasound guidance and to follow the guide wire inside the artery. So to be sure that the sheet will be introduced in the true lumen of the artery. In general, this approach reduces the overall complication of almost 50% and improve the first attempt success of 40%. The fluoroscopic access, as we said right now, is the other way that we use. The femoral head is our landmark, and on the medial part of the femoral head we have the common femoral artery. But not always the X-ray is available, and do not forget radiation safety, because you are in an emergency room, you are in operating room, or I don't know, in a angio suite, and you are a lot of people that are going and coming, and so you have to advise them when you press the button and you use fluoroscopy, because not all can have the load we're on. In obese patients, these authors suggest to consider another important anatomical landmark, the pubic tubercle, because the inguinal ligament should be lower than in other patients. In obese patients, you have to move the belly, and so you can have the field clear, and sometimes you have to use the longer needles, up to 15 centimeters, and in ultrasound guidance should be the solution. I suggest to use large needles, 18 gauge needles, because in this case you can have a clear flashback of blood. When you use micropuncture set, sometimes flashback is not good, and is more difficult to understand where you are. But no consensus is present about that. A J guide wire, a starter or a Benson guide wire is suggested. And when you have a flashback of blood, you can insert the wire. The wire must glide on without any force. And if you have the ultrasound, or if you have the fluoroscopic, you can check. I suggest to check. If you have no flashback and you have fluoroscopy, you can introduce a contrast media to check. If the guide is not glide on, you can traveling into the media, and the dissection should be present. But this is not a problem if you are using a small sheet, or only the dilator or a small sheet, 4 or 5 French, because you can remove everything and you can try a new puncture without any problem. It's difficult that a small sheet can create a big damage in the artery. When you obtain the femoral access, we recommend to secure the sheet with the suture to the skin. And if you are planning to perform a pelvic embolization or to use a RIBOA, a bilateral access is recommended. When to remove the sheet is a good question, because the answer is when the patient is hemodynamically stable, but you don't know when the patient is hemodynamically stable. The recommendation is to leave inside a sheet up to 7 French of sides, and to remove the bigger one. The training is very important because all the staff can improve they're comfortable with the training, and the practice improve the learning curve. Other access are radial, humeral, and axillary, but apart from axillary, you can't use a big sheet, and usually you need the X-ray guidance, and sometimes this should be time-consuming. So, in conclusion, we can do that. There is not a good method to overcome the limits in these patients. But each method have merits and demerits. You have to use the method in which you feel more comfortable, and you have because the vascular access is the first step in EVTM, you can do it with calm, and if a colleague close to you is more skilled, you can let him or her to do that. Thank you very much for your attention.
Thank you, Anna Maria. And immediately we got a disagreement here. So we just heard from Martin that you should always use the micropuncture set. And now Anna Maria is saying you should always use the bigger bore needle. So which is the correct answer, or is there any?
I don't know. I never use. I think that there is no consensus about that also. But I never use the micropuncture set for the reason that I explained. Because the flashback, especially in hypotensive patients, should be not so good, and it's sometimes not clear if I'm in the true lumen or not. If I have the ultrasound, it is easy to understand it. But for example, we don't use ultrasound. Usually, we don't use ultrasound. We have always the ultrasound ready with cover also. But I use the blind puncture.
Okay, sorry, we had two votes. We have micropuncture or big bore, and then we have ultrasound, no ultrasound. So I like with two votes. So who uses micropuncture always, or mostly?
I think
Swiss American?
I do think it depends on what you're doing, though, because if you are doing something that's going to require an 035 platform and you have an unstable patient, puncturing with a starter needle and going right to an 035 wire does save you an exchange step.
Yeah, but you can take out the inner sheath of the micropuncture set, so you can change it to a 035 without doing
You can, but you still have to needle, microwire, microsheath, then that step, as
and
opposed
then
to
take it
just
out
starter
and then put it in.
needle
So it's-
to
it's-
working sheath.
yeah.
It's one exchange.
Okay,
that
but it was a
potentially saves
Swedish
you.
problem, okay? And who uses the bigger needle? No real difference, actually. Okay, so we got no consensus. How about the ultrasound? Puncture with ultrasound?
Most of the
Puncture mostly without ultrasound.
Yeah.
Okay, so ultrasound is, but it's a matter of teaching and learning and doing, and you probably do about 1,000 punctures a year. We're actually struggling with Mari, with one of our medical students. We put him to go through punctures because we thought that there are more complications if you puncture the SFA instead of the common femoral, and he went through like 300 or 500 patients. And he did not find many, but we do see the complications every now and then. And then we realized that the cardiologists do about 5,000 punctures a year in our hospitals, the angioradiologists about 3,500, and we do less than 1,000 punctures a year.
But I want to underline that highlights that to my residents, I say to use the ultrasound.
Yeah, okay.
When they become
Once
they
you've done the
become more
5,000,
skilled.
then you're like, forget about it. Okay, that's the other way around. Okay, any other comments? Then Class Forsell is coming a bit later. So we have David Lindström to talk about surgical, non-surgical open solutions for the failing access.
So thanks to the organizers and Tal for inviting me to talk about access. We can get my presentations. I'm David, maybe on top, bottom there. So for the ultrasound, we used the needle guide, the longitudinal. I must say I learned the axial view from Martin, but I abandoned your, I'm sorry. I think especially for the trainees, we do get a lot less complications when you use the needle guide because they only need to control one hand. Can we get there we go. So with this technique, you can see the wire, and I just think it's a lot safer. Another problem, which is not related to trauma, is to reduce the complication, is to reduce the size of the sheath when you're going into the groins. So the traditional fever, you have a large sheath with a graft. You have a multi-sheath on the other side, which can cause leg ischemia. So we abandon this big sheath on the other side, and we can stay with 12 to 16 dry seal, which includes one sheath and some wires only. So this sheath can also be used if you want to remove cava filter. You can use it from the groin and use a laparoscopic grasper together with a catheter. So just a video to show when we deploy a graft, we only have one sheath in the target arteries, and the rest is only wires. So we looked at the first 150 target vessels with good patency, so it doesn't seem to be a risk for the target vessels without all these sheets. So another problem with access is if you do branches, you traditionally have arm access or axillary artery access, which will cause some stroke risk. So our approach is to go from below, from the groin with a reversible sheath, either a 16 French or a stabilizer wire through a 12 French. So this is a case planned for a 2-branch, 2-fenestrated device where we can actually go from below up and down into the celiac trunk, and also go with the stent into the celiac trunk from the groin, so the VBX stent in this case. So this will speed up the procedure. We don't have to do the cut downs in the arm or the axillary, and we don't get the stroke risk for going from above. So we heard about these complications. We have seen a lot of TAVI complications. We also get complications from neurointerventionalists. They don't use ultrasound, it seems, in Sweden. This is a recent case, of course, on Eliquis and clopidogrel. They have 18 French in the right groin, and they call me because they see this one. They have closed it with their proglides. So complete occlusion of the common femoral. So my strategy now is to stay away from opening these, go from crossover. This one I could use the back end of a Terumo wire to come through, and now I stent all groins. It's had a good outcome here because these patients tend to be quite sick. They're under local, sometimes in just a cath lab, and doing cut downs is not very nice in those circumstances. So the same team, when we're removing the other side, you can see they managed to puncture the SFA, even though they told me they punctured the common with ultrasound. So I think ultrasound is key. And I think needle guide is very good, especially for trainees, because they see where they puncture. So moving on, sometimes we don't have the access for the very big sheets for the aortic procedures. You can, of course, try to find lower profile devices. You can stent the access, or you can try to crack the access if it's calcium with these shock waves balloon that present acoustic wave to crack up the calcium so you can advance your graft. Or you can do an open conduit. So this case needed a 22 French device from the groin. And if you look in the right groin, we have to place a conduit here. So you can see it's a 45 millimeter external iliac along with a 10 millimeter synthetic graft. That was used first, then put the TEVAR in to facilitate the next step with the actual graft, then coming with a large 22 from the right, and from the left a 12 French dry seal to be able to do the 2 fenestrations, and then moving up to do the 2 branches to the SMA and the celiac. So to be able to, sorry about the sound here, to be able to close the graft then without having to do a cut down in the fresh graft, which sometimes leads to infection, you can use the Manta device to close the puncture. And on the 18 months follow-up, we're quite happy. Oh, it's a bit slow here, sorry. This is going to take forever. So of course, these are not trauma patients, but I think it's the same principles. You want to have a safe puncture. You want to have a tiny access to prevent ischemia. It's like with the occlusions balloon. You don't want to have a big 12, 14 French sheet staying for a long side in a small femoral vessel. Maybe in a trauma situation, they put it in the emergency room. They do multiple surgeries, and then they call the vascular team to remove it day one, and it's thrombosed in the leg. So sometimes we may not be able to do the endovascular approach, even though it's our first choice. So this patient's presented with abdominal pain, had a very large SMA aneurysm. This is going to be slow again, but maybe it's good. You can appreciate the anatomy. You see a very large 5 centimeter multilobular SMA aneurysm in this sagittal view. And we can see shortly that the only real normal SMA is the first few centimeters, which is in a bit of a hostile anatomy, of course. So we decided on a hybrid approach. Again, we're sagittal view, the sheath into the SMA. And you can see some branches of the SMA early up, and distally, there's also multiple branches. So we decided to stent the first branches. So there's a via bone here coming from the aorta into the proximal branches. We coiled some middle feeders to the aneurysm. You can see we used the wrong size of the coil, but it blocked it, but it was definitely not a good choice. And then distally, we put a bypass from the left common iliac to the distal branches of the SMA. And on the follow-up scan, you can see on the top, patent via bone perfusing the upper part of the SMA. And distally, there is a bypass making a loop from the left iliac to the SMA branches. I think that's what it is. Thank you.
I think Tal has a comment.
Fast comment, just. First, I think the class just missed your beautiful comment. Thank you very much. I think today you can close the access in different ways. Now, class is my second mentor, and she showed me how we close with one suture, very big access. I think there are different ways to do things. I'm sorry, yeah, 2 things. I have 2 comments on this. I think it's possible to do a lot of things. What I think happening also, it's a big problem that we are stopping using open technique to close things, which means also the training would be a problem. And I guess Uppsala has the same problems, and other less and less we are opening things, even for teaching. And I think it might be a problem. Now I stopped, because of class, I stopped opening the axillary, which was a standard. I don't know opinions on this, but for the education, it might be a problem. And the second, just a comment, the EVTM is not about trauma. It's endovascular resuscitation and bleeding hemodynamic instability. So those of you that of course think it's trauma, it's also trauma, but not only. Thank you.
Thank you, Tal, for that, because I was actually looking for a presentation on closure devices and differences, but we don't have one. Maybe we hear in the presentations. We saw one closure device, but there are several on the market, and the differences should be discussed in an objective manner. Questions?
May I say something?
Comments? Martin? Yeah,
yes,
please.
I just would like to mention that I'm aware of groups of cardiologists who do the TAVI with very large sheaths by an intentionally high puncture. And they combine that with a low puncture. And once it's time to pull out the large sheath, they insert a covered stent through the lower, smaller puncture site. So I think that's an option. Tal, you just brought up again this dilemma of the open surgery. As we talked about before, there will be less and less open surgery, and whatever open surgery there will be more and more difficult. And this is an equation that I think is utterly difficult to solve.
Martin and Tal, don't you do hybrid operations with cut down and femoral endarterectomy? Because that's the longest queue we have in Helsinki. So you can send your juniors to us. Please, sorry.
Sam Bedre from Örebro. I have actually 2 questions. First of all, as we know, as the population is getting older and older, we expect that the trauma for older patients will be more often, and maybe we need more access. I got to know that we have to avoid femoral access in trauma setting for all patients over 70 years old. I don't know if it's right or wrong, but it has to do with the complication, the access for all patients with their fragile and calcified vessels. My question is it like more harmful for the vessel to get in with 5 French and upgrade if it's needed, or maybe we can get it with 8 French immediately? And maybe we can use cut down technique for all the patients instead of puncture. What do you think about that?
Well, I think cut down is certainly unnecessary in the very majority of the cases. So if you use ultrasound, I think you simply don't need it. But of course, there are situations if you're not familiar with ultrasound or you don't have the resources, you can do cut down. But I don't think it's either or. You have to use what you're familiar with and what's safe for the patients. And I don't believe in opening groins in the sake of students. I think it's in the sake of the patients we should do it.
Marit Venermo has a question.
Yeah, I like this session because there is a lot of controversies, and I would like to say my opinion about things. I have controversial opinions. So first of all, I think we should avoid groin cut down whenever we can, because the risk of infection is quite high. And many times in ruptures, we have to use puncture without closure devices and then shut the access. And we use different kind of closure devices. But here also, and actually I have taken it to routine also in elective cases when I do peripheral interventions, when I put closure device, I use ultrasound. You can see nicely where the plug goes. You can avoid the complications of closure devices. Thank you.
I'd like to congratulate you, David, on your comment that we should avoid doing things that actually are unnecessary only to train people. I think that's something I keep hearing in many places, and I absolutely hate it. I'm very glad you said that.
Okay, in the sake of time, I think we need to move on. Or do we have a quick question?
Yes. In patients who are very, very obese, I think there are 2 reasons to use ultrasound. One is that the subcutaneous tissue is very deep, yes, but also if there's a significant amount of intraperitoneal fat, the inguinal ligament will bow. It'll develop redundancy and laxity. And if you use landmarks, you'll end up with a high stick because you've gone above the ligament, simply because everything falls down lower. This is perhaps a bigger problem in the United States than in many of your countries.
It's a problem here as well. Yeah, I fully agree that obese patients and ultrasound should be a combination. And I think David does that as well. So we got Klaas here. Welcome.
Thank you.
Are you ready for your presentation on tips and tricks?
I hope so.
Yeah, let's see if we can get the Klaas Forsell's presentation up and running.
Okay, then we move on.
Then we move on, and we figure that out.
They put it in out there.
Yeah, but it's not there. The lines are too slow. But Lionel is here, I heard.
Yes.
Okay.
Online.
Yes, that's true.
Okay, we share my screen. Okay, now we will discuss about access during ECMO ongoing CPR, and you will see it's a little bit different discussion we can have with ultrasound. Anyway, my complicated fast arrest. Okay, Jim showed you this very nice picture of the article. It's very important to know the anatomy to understand why we choose a technique or another one. First of all, you have to understand when it's a surgical access, generally is upper what we discuss after the hybrid techniques. That means it's upper. That means can be more difficult if you are not a surgeon. What is important for repair when we use different techniques is the fascia and the superficial venous to know where we are exactly. And the second point, very important for us, is to have a good understanding. More upper you are, more it's easier to find the venous and the arterial artery is very not in the same plan. Because if you are too down, it's really in the same plan and you have a high risk to have transfixion of the artery. Anyway, to choose the techniques, we have to keep in mind what are the major complications when we go on ECMO. For example, this is for cardiogenic shock and cardiac arrest. Whatever, you have some medical problem like acute kidney injury, but you have to keep in mind the bleeding and infection is very high for this patient. For me, the most important problem during eCPR, that means when ongoing CPR, when you poke the artery, is a risk to go in the venous and to do a VV ECMO and not a VA ECMO, what you would like. And that's a very important point. And this is why we are not so confident with ultrasound, because the risk for me is more higher during CPR. Now, if we compare the different techniques, the surgical one is probably what everybody call before the reference. You show the vessel, you are sure where you are. The puncture is very simple. You see what you're doing. Less arterial damage, because you can do everything on the arterial. The reperfusion is less challenging. And after, for the ablation, it's really more easier. The major problem is to have a surgical equipment and a surgeon in emergency 24 everywhere able to do that, and not just a CT surgeon. That's a major problem because it's time consuming for a surgical team, and generally in hospital we need the surgical team to do OR, more OR than ECPR, because we have a large flow of ECPR, in fact, if we check carefully. It's not so easy in case of CPR. The major problem, you have some movement of the abdomen by the CPR, and generally surgeons ask to stop the CPR, and this is a disaster for the brain. And this is, I think, the major problem of these techniques. And we have more complication, more infection, if we compare to something with ultrasound, and the repair sometimes is more complex. Percutaneous is attractive, but not so simple. Really less infection, more accessible for non-surgeon, because now all ER physician intensivists are very knowledge about puncture under ultrasound, but we have more bleeding. In fact, generally during cardiac arrest, it's not so easy to have a good angle. So many times you punct many times, and after we have a very large hematoma because this patient do DIC and they need heparin and everything, and that's a major problem. And I saw some patient dying for this hematoma. In pre-hospital setting, it's not so easy to do ultrasound. Your screen with a light is not so easy to see. You need more people because you need one use the ultrasound because you are in sterile condition. That's not so easy. And you have to keep in mind, if you do a pre-hospital setting, ECPR is not very easy to have ultrasound for all patients. And the reperfusion is really harder. And some teams now do in percutaneous the ECPR and after do open surgery to do the reperfusion. And you have to keep in mind, during cardiac arrest, the flow is it will be harder to be seen on ultrasound, and the distinction between the venous and arterial line is not so easy, in fact. This is why we have developed enabled techniques where we opening, we know where are the vessels, and we do after Seldinger techniques to see where they are, and we dissect with a finger, in fact, the major part of the dissection. We can do the reperfusion at the same time. The ECMO is not so hard to do an ablation, and in case of ECPR, it's not a problem because the CPR we are done lower than a surgeon, we never stop the CPR. We have more complication in terms of infection, the same of surgery, but more than ultrasound probably, and need a special training, but not so hard to do. This is the techniques we have developed, we opening, and after we do really something like cell ligand techniques, but we see where we are in each step. That's a very important point for me. And we after able to do the cannulation and the reperfusion in the same time. That's very important point for us because we are in pre-hospital setting. After we go to the angios. I mean, in terms of time, it's a long time. And after we go to ICU. At the end of the process, it's closed. It's a small incision. But you see, we are really lower than a surgeon. Probably a surgeon will be on this point. That means it's not the same. And at this point, we have no problem with the CPR. We have no movement of the leg. The failure rate is 7.4 and no difference in pre or in-hospital insertion. That means it's really constant. And this is a difference with ultrasound, because with ultrasound sometimes you have not the same rate in and out of hospital. To conclude, it's very important to have a femoral arterial access. Whatever the techniques you would like to do, rAAA, CPR, SAP, ECLS. The question is how to access to the femoral arterial access. But it can be changed between patients in CPR. For example, in my team, we do hybrid technique for CPR techniques. And when we are without CPR, we do in percutaneous. We need to adapt where we are and for each patient. That means you need to know many techniques. Thank you for your attention.
Thank you, Lionel. I personally don't put in ECMOs, so I'm a bit on a thin ice here. We do treat with the cardiac surgeons, we do treat ECMO complications. So it's a bit familiar, but we do have femoral access during the automatic resuscitating machine, Lucas. And there I heard, there I learned myself the Yoda way of failure, that stop the machine while you're doing the exact moment of puncture, because if you don't stop it, then it goes like this. It's you can fail the puncture. So that was my learning point, and the next one went okay. But do we have comments for this ECMO? Martin, are you familiar with the ECMO? Can you challenge Lionel here? Silence. Now we have a comment from the floor. More.
Yeah, great session, full of controversies. I'm curious about your selection of a horizontal incision versus a vertical. Again, with the trauma biases, we always use a vertical, whether for ECMO, vena bypass, and so on. I'm just curious why you choose the horizontal.
We choose this access in a horizontal way because the difficulty is to find where are the vessels, in fact, during the CPR. And not, we just check, the goal of the technique is just to check where are the vessels and to see when we do the puncture where we are exactly. We have not to take the artery and the venous during a long way, like on surgery.
There was actually a recent paper in the European Journal about femoral access teaching paper, and there was an opinion that larger incisions make less complications because of the lymph leakage. But we have a question.
Yeah, so Tal wanted us to be controversial, but I think if you're going to do this to CPR patients, you probably just need to learn to do under CPR conditions, don't you? So if the movement's off-putting, which it is, you've just got to get your eye and learn to do it, because I don't think you can pause CPR for, maybe you said, a fraction of a second to get access, but if you're going to do this in ECPR patients, you've probably got to learn to do it with ongoing CPR. I think that's probably what we do in our system, but it's hard, but you just got to do more.
One point that I also learned the hard way, not my own, but colleagues, just a couple of weeks ago in, of course, the St. Elsewhere Hospital, the patient was referred to us, and the ECMO was venous instead of the other one being in the arterial one. So in my opinion, your point about the security, having the correct vessels saves lives.
But this is why we have developed these techniques, to be honest. At the start of the program of ECPR, we're doing percutaneous also with ultrasound, but failure rate increased a lot of time because we have some difficulty to see where exactly the vessel, and under CPR it was not so easier. This is why we developed this technique, techniques, to be sure where we are and do everything under control of eyes. But today in the team, someone of challenging sometimes to say ultrasound is good and why we don't use it. Now what we're doing more and more, we repair by ultrasound and we opening ultrasound and we check under control of the eyes to be sure we are never in venous, for example, and to be sure where we are. And poke one time.
Zoran, if you can come and prepare for your presentation about the access. So Per had a question here.
Well, just a short comment. Well, there is different needs. I understand why you do like you do, because you have a different need than I have as a vascular surgeon when I'm having a femoral access. You want to have access to both the superficial femoral vein and the femoral artery. And that when a horizontal cut down a few centimeters more distally, that's logic.
Yeah, that's a good point. Then we have Zoran Ranzik from Zurich talking about the unstable patient and access.
Can I get my slides? Okay. So I can start without slides.
Okay, so we have class.
Good morning, everybody.
Did you say that you have class for sales slides, but not Zoran's? Can we then change so class speaks now and we sort this out with Zoran? Zoran, have a seat. Have a seat.
Thanks.
Sorry.
Well, dear colleagues, again, I've been given a topic that is fairly large, and I don't think I can fill the full scope of it, but so I'll focus on two things mainly, and here you see one of them. So, complications in vascular access of especially the common femoral artery is it can cause delay of care of patients due to a persistent and failed unsuccessful attempts to get into the artery, especially in the acute setting. It can cause remote vascular injury due to large occlusion balloons in small vessels that go into the wrong vessels. Dissection occlusion due to rough handling, ischemic injuries due to long occlusion times, and hematomas, bleedings, AV fistulas due to punctures in the wrong place. And here the key to successful access is to get the puncture in order. And you have to really puncture in the right place. And there's almost only one place to puncture the femoral artery, and that is just below the equator of the femoral head and above the profound artery. If you get higher than that, you have a high risk of retroperitoneal bleeding, and if you get lower, you have a high risk of bleeding and AV fistulas. And the key actually is to get puncture in the right place. And to this, you need to puncture in the plaque-free area, and you have to use ultrasound. To not use ultrasound in our days, I think, is not acceptable, actually. And one more thing about ultrasound access is that there are some imperative prerequisites, and you have to be trained in ultrasound vascular diagnosis. And a lot of times you see people doing ultrasound guided puncture without really having any knowledge about ultrasound diagnosis, and they also don't have good equipment. You have the lousiest ultrasound equipment to puncture the artery, where you really have to use the very good and modern equipment where you can see details in the artery and see it very well. And you have to have control of the needle tip in the transverse plane. You have to puncture the artery right in the middle, and you have to see the needle going into the artery. And a lot of times you see that people puncture the artery in other places than where they look with their ultrasound. So that's critical. The other part is ischemic blocking of iliac arteries. Can be because of thromboemboli due to large bore introducers, dissection, or balloon occlusions. And if you have occlusions times above 2 to 2.5 hours, the complications and neurological complications, spinal ischemia and compartment syndrome will increase a lot. And therefore you have to be prepared to shunt. And it's very easy, and it's very good way of preserving both the spinal cord and the vessels, and the leg, and the muscles and the nerves in the leg. You should use introducer 6 or 7 French for perfusion downwards, and it has to be reinforced with steel wire, like narrow introducer. And you can connect it with some inflow from the arm or from the contralateral femoral artery with a male-male connector. This is very effective, and you reach flows from 50 to 150 milliliters per minute, and that will save the leg. So in conclusion, vascular access is hard. You have to train. You should use ultrasound puncture, and you should use it in a good way, and you have to train for it. And you have to be prepared to shunt if you have occlusion for a long time. And as a finish, I would like to stick out my neck and say that vascular access as an emergency procedure outside of hospital resources should not be done unless it's absolutely necessary. And I think rBUA in those situations is a really bad thing and will cause more injury than good. Thank you very much.
Immediate comment.
Quick question, what size sheath should you start thinking about shunting? So I'm an interventional cardiologist, so tabby sheets?
I normally use 6 French sheets for the perfusion, and for getting inflow, I usually use something like a 12 French introducer on the contralateral for reconstructions of the aorta, for instance.
And do you routinely measure flow through that circuit, or you
Not
just know that it's
routinely.
about 150
I use
mils?
it now and then, but you can flush it with saline and see the flush and see how fast it goes. It's very
So
easy.
I think we don't consider this a lot in TAVI. We just leave a big sheath in for a long time.
Yeah.
So that's a good point, actually.
And you can use the radial artery as well. From radial artery to the groin is a very short distance, and it works very well.
And are your patients heparinized for the procedure as well?
Yes.
Yeah,
Yes.
okay. Thank you.
And I maybe missed it, but what were the exact indications you use? When do you shunt and when you skip?
Well, I shunt when you risk of having occlusion times more than 2 hours.
2 hours.
Yeah. Or if you have increased risk of spinal ischemia.
I'm glad you brought up the relatively mundane issues about learning to use the appropriate dimensions on your ultrasound, the gain and depth. And the problem is we have so many machines these days that no one knows where the dials are. So our institution, for example, we have a dedicated ultrasound for rubella. Same machine, it's already set at every time we use it. But I think in our training, our trainees need to learn how to use optimal settings for ultrasound to get access.
I think that's a very good point. And to use the standardized machines and to train it. Not just use it for puncture, but use it in a wider setting than that.
Yeah, I think we're going around the question that who should do it, but we'll take that later. Do we have Zoran's presentation?
Yes.
Okay, to move on, to keep the timetable. Thank you, Klaus. Excellent.
Good morning, everybody, and thank Tal and all of you to be here with you. So I have the slides, but I cannot move them. Okay, I can move them. So the vascular access in unstable patient means the same as the patient who is stable, but is hemodynamically, there is hemodynamically specific situation. We have a stress. So that is the same as we are doing in a normal elective cases. So we can do it transfemoral access, percutaneous, or open surgical. And whatever we are doing that according to the CT angio. So we identify calcification, arterioma, stenosis, aneurysm, to see exactly where we are puncturing. And whenever we have that, we make that with ultrasound. We are doing that in the normal elective cases because ultrasound, as we heard, aided puncture when it's okay. And what we are doing always, we are always going 2 centimeters above bifurcations in case that we have problems to obtain the closure after using the closure device. We are using always one closure device, pre-closing monofilament, similar to the suture. We're using up to 24, 26 French. And if it's up to 18 French, we're using 2 prog lights. If there is more than 18, 20, 22, 4, we're using 3 prog lights. And the third one is at the position of 12. What is interesting, I want to show when we have the patients, and in this case, when there is a renovisceral debranching and we have a scar, in this case, we are also doing the percutaneous access. There is something what is interesting to know. We make the puncture of the artery. After puncture, we are going with the dilatator, made 1 prog light, and after that, we are going with the PTA balloon. With the PTA balloon, partially within the artery, partially outside of the artery, we dilate the scar, we dilate the graft, don't make a tear within the graft, and then through this graft, we are going with the sheet and proceed with the procedure. What is exactly here, when we put closure device at 10 o'clock, then it is a PTA balloon, partially within the artery, partially outside, and take care to push it down the skin when we are pushing the dilatator to omit the disruption of the anastomosis. The first case that we did it without the ultrasound, and we puncture exactly at the level of anastomosis, and it was, we have to convert to open surgery. Looking where we are going to puncture the artery, look if there is what is external or common iliac artery, and if there is a narrow, we can use pave and crack as some tool to overcome the problems. But don't forget that we can approach to the femoral vessels with open surgery. We said if we are doing that rare, but it is obvious to know, open purse string suture, fascia closure. I'm not sure if the Thomas Larsson is that one of the startups he's developing. And the third one is surgical close, which we are using in the university hospital. That means for transmural stitches, 2 Prolene sutures, we are making 2 Z sutures. And what's important, we just dissect the anterior wall of the artery, never make a circumferential to have less damage. Then exactly with the finger, we identify there is no plaque, there is no plaque where we're going, or atheroma, intimal fixation, and we are producing no tear up. When then we are just puncture artery between 2 sutures, going with wire. At the end, what is the advantages of this? We don't have a clamp, we don't have the plaque rupture, we don't have local dissection, and we did not have the bleeding, and we go up to the 24 sheet. At the end of the procedure, we just tying the knots, but and this is the results when we show no bleeding 90%, but of course, in some cases, we have to put additional stitches. And this is why at the end of when we are knotting the sutures, we leave these needles, and with this needle, we put additional suture just to close the wound. Leave outer needles. Of course, we try that for 2-3 times with ultrasound. If it does not work, ultrasound, or then we are doing that open surgical. There is other access possible, transbrachial. If we are doing that always open surgical. There is transaxillar. This is as it's done open surgical in this case, or in this case when we did transbrachial in the patient with a rupture, occluded aorta with, here it was a small bleeding, and a patient deteriorated, and in that case we needed access, so we made access transbrachial, did a local anesthesia, then put a balloon from that, and we opened abdomen and made the aorta bifemoral bypass reconstruction. What is for a transaxillary approach? As I said, we are doing that always as with ultrasound assisted, and in that case, we have to be sure not to make it too obtuse or too acute angulation. Maybe in these situations, the only way when we're using micropuncture sets. And with this technique, to be aware that at the end we have to close the wound and to be prepared for the failures if that occurs. If after finishing the procedure it's still bleeding on the puncture side, we are using another pre-close proglide. If it's work, it's fine. If it does not work, with transfemoral balloon occlusion with thrombin injection to prevent against the pseudoaneurysm, or implantation stent graft, transfemoral or transbrachial route. And this is important not to remove the wire from transfemoral, because we are snaring the wire transfemoral to here to facilitate deployment of the stent graft. As you can see, here is the wire who was snared here. The next one, we are going over the stiff wire. We are going to the lesion artery, axillary artery, then using over the stiff wire deployed a Vivan, and the end, the final angiography. Never remove, and always think as a bailout to have through and through the axillofemoral wire. Don't forget that there is a limitation. This is the aortic arches, and for example, look at the diseased aorta. This is why we need CT scan to see in the aorta, probably not so strange, but in the same patient we have a huge, this is a COVID patient, a huge thrombus in the descending aorta, so not good for the use reboa. Also think that we have to make all the procedure, not just to gain access, so have in mind which procedure you have to do using this access. To conclude, whenever possible, use CT angio-thoraco-abdominal to see where it is to gain access. It is a daily routine of the team as an elective EVER. Think on possible use of reboa, possible to treat all the underlying disease, and think in the beginning how you're going to close the access. Thank you very much for your attention.
Comments, Martin?
May I ask Zoran something?
Of course.
Zoran, when you do the transaxillary percutaneous approach, are you trying to avoid the nerves?
What do we track?
Are you trying to avoid the nerves? Are you trying to visualize?
Exactly. Well, thanks for the question. We are not looking at this, but we are going always infraclavicular with the ultrasound, and then we don't press a lot, so we see where is the artery and the vein, and then we are trying not to go through the pectoralis muscle, and this is when we see the artery. So of course that we can see the nerves, but actively tracking the nerves, we don't do this. And we did not have any lesions out of 15 patients.
Yeah, using these, that was my question, using these percutaneous closure devices, do you see any nerve damage? Is Klaas have a comment on that? You're an expert on this.
Well, we use axillary access for that.
But axillary is probably to say it's here. This is part one, infraclavicular. Well, you're not going here in the axillary.
We think it's easier. You can have pressure control of the bleeding. You can see the nerves very well with ultrasound and avoid puncturing the nerves. So we prefer axillary puncture to subclavian.
And it's also important while puncturing here in the axilla part 1 because our arms can be close to the not disturbing during the moving of the CR.
I have another question about the percutaneous suturing with the closure device. If you have one and it still bleeds, how do you practically perform the second one? Do you use ultrasound guidance or you leave routinely in the
at the beginning
and then just put it blindly, or how do you do it?
Yeah, thanks. At the beginning, when we are using transfemoral, we're always using 2 proglides, one in 10, one at 2 o'clock. Then if we are not happy closing, then we are going to use the third one. So that means our wire is still inside, and we over this wire going to deploy the third proglide. And what is important, not to close both, not to tight both proglides, then to tight only one. And because if we tight both proglides and then you're going with the third one, you can make more damage with this third one. So that means 1, 2, and then the third one.
We've been using, if you go in an emergency situation and you don't have time for the proglides to put in, we've been using ultrasound posts when you have a big sheet and it bleeds a lot, then you have to have something to pressure it, and you press it with the ultrasound probe. Probably best to have 2 experienced vascular surgeons or interventionalists, because the other one can press and the other one can manipulate because otherwise the end of what do you call it, the thing in the proglide, it will come out from the big hole. That's something to be considered.
I was planning to give the 3 talks, but Tal took the last talk, how to close the wound, and this is exactly what I addressed in the I separated, how to gain and how to close. So it's exactly what you said, we are doing the same.
We had some comments here.
Yeah, I just was wondering if you could comment a little bit on your practice when using upper extremity access for aortic occlusion regarding heparinization in a bleeding patient.
Whenever, how to say, if there is elective cases, we are always trying to go ACT above 200, so we're always giving heparin. In the rupture cases, there is no some recommendation, there is no guidelines, but what we are doing, if we puncture the artery and we see the clots, then we are going to give the heparin. If we puncture the artery and we don't see the clots, so we will say, okay, then wait with heparin. So I will say this is our state of art at our hospital. So no strict rules when.
We should change to the last presentation, but we have from Per, did you have a comment?
Well, I actually wanted Klaus to comment about that because he told me or taught me how to use a single proglide for large bore access, and it functions extremely well. I used to do like Zoran, 2 or 3 for 20 French or 24 French, and then Klaus taught me to use a single proglide, and it's fantastic how effective it is. So I've started to use a single proglide for large bore access, and it's really efficient. So try that.
Okay, so you use the single one and you pull it, and then if it bleeds, what happens then?
Then I can put in a second one.
Just a comment. I have that subject tomorrow.
Yeah, okay. So let's skip that one. We move on to the pre-hospital setting. Welcome. We're going to hear about the topic that Klaus, I think, already objected.
Thank you. Thanks for the invitation. Thank you, everybody. Patrick, I hope you're ready. There are some video clips that you need to run because there's no mouse. There's a thumbs up from the back. Excellent. Good. I'm Paul Rees. I'm a consultant cardiologist. I also do pre-hospital care. I normally work in Bart's Heart Centre in London, which is one of Europe's largest cardiac centres, and also do pre-hospital care with East Anglia Air Ambulance and a military pre-hospital consultant as well. So there are differences. We're normally talking about doing this in an operating theatre or maybe an ED or maybe in our lovely cardiac catheterization lab where I have a team of people around me. In fact, I was so unemployed on this occasion, I got to take a picture of fellows and people helping you get access in a lit environment. Pre-hospitally, things are very different. So if you're arriving at the scene in an air ambulance or part of a ground deployed team, what are the challenges? There are plenty. As we learn as a group to take our in-hospital therapies to the pre-hospital setting, we need to learn to breach those problems. And actually in forward austere military settings, although that's an operating table, it's pretty austere and remote. And I would suggest that that or the back of an aircraft is effectively a pre-hospital environment. So we're going to talk about the challenges of doing this stuff in that setting. The first thing I'm going to show you, if you can run this, is a video showing you a pre-hospital Reboa case.
Ambulance, what is the emergency there, please? There's a cyclist on the ground run over by lorry. She's been shot and she's not good.
Okay, continue straight for 1 kilometre, take the first exit.
So base goal 460, go ahead, over.
Just to give you an update, patient street nurse at the scene, but pelvis and delay bunch.
We are 30 seconds away, over.
Watch your heads, guys.
My name's Simon, I'm a doctor. Can you tell me your name?
So look at her respiratory pattern
She's
and
obviously
her
a
colour.
code red, she's got an unstable pelvic fracture.
It's quite possible for the bleeding to lead to a cardiac arrest within a few minutes. I had a dilemma with Victoria. I knew what she needed, but I didn't have those things with me.
I'm just thinking if we can get the team to us with the Reboa kit or whether we go to the Royal London. Can you get on and see if the team are available if she needs it now?
We would only consider using Reboa in patients where they're bleeding to death at the scene.
Every second does count. Sometimes the devastating side of it is very hidden, and actually everything on the outside looks intact. Meanwhile, on the inside, they're catastrophically bleeding. These patients are sometimes referred to patients that talk and die.
Tell me your name if you can hear me. Vicky, what we're going to do now is we're going to give you an anaesthetic so that you don't feel any pain anymore.
When you're about to give an anaesthetic to someone who's that severely injured, you're conscious that they may not survive this accident, and that your voice might be the sort of last voice they hear.
I know it is, and this is going to take all the pain away, okay? Hi, Sammy. So she's cyclist, wheels have gone over her pelvis and right femur fracture. Good.
If you want to anaesthetise, we'll do Reboa.
Can we have silence now, please?
This procedure is inserting a balloon into the aorta to stop the patient bleeding to death. You know that it can go wrong so easily, a millimetre of movement either way, and it goes wrong, and that might be your only chance.
Okay, so we can start the blood.
Let's go.
On you.
Emergency on.
Okay, so compared to the in-hospital setting, everything is wrong, isn't it? The equipment's probably wrong. The patient cohort is really difficult. They are as sick as a dog, peri-arrest patients. It's a pretty resource-heavy environment. It's a very busy scene. There's lots of stuff going on, and the environment is all wrong as well. There's poor light, there's poor positioning, there's wind or rain or weather, and patient compliance is difficult as well. They're often in pain and maybe a bit agitated. Ultrasound-guided femoral access, we think is probably mandatory in the UK for this, but actually that presents its own challenges as well. So it does not, if you can just run that clip, it does not look like it does on the simulator when you do it pre-hospital. Let's just go forward one slide. If you can run both those clips, just click on both of those for me. On the left-hand side panel, that's what we're doing it under, mechanical CPR conditions. It's a subcostal view, and that's what it looks like in the groin. So it's not a nice still picture. We've got pulsating vessels, we've got mechanical movement. So there are real challenges there. Next slide. Okay, once you've got your access in, you've then got the problem that this patient was actually upstairs in a house with ROSC, or variable ROSC, and a blood pressure of 40 when we got in. So you get your access in, you've then got to move your patient. You're not just rolling on a trolley to OR or CT, you've got to stitch that in. That's my inexpert suturing happening on the left-hand panel there. And you've also got to have equipment to hook it up to. So your service needs to have transducers ready to go. You need to have monitors that are compatible with arterial pressure monitoring if you're going to do this stuff in the pre-hospital environment. So is there any data? There is actually. So the Austrian pre-hospital service published some data a few years ago now on arterial line placement. Interestingly, they quoted an 83% first-time success rate, which in anaesthetist hands I thought was pretty low. So, but they were doing it mostly in patients, some patients with cardiac arrest, some patients with post-arrest care. So can you place arterial lines pre-hospital? Yes, you can. The crazy guy, Jim Manning, are you there? There we go. So published this as well. Feasibility of blind aortic catheter placement in pre-hospital environment to guide cardiac arrest. So that was using that beautifully packaged system you can see there, all ready to go in the car, going to cardiac arrest, using pressure monitoring, which you can see in the bottom left panel, to guide therapies in cardiac arrest. And that reported on 22 patients, and it is indeed feasible in the pre-hospital setting. The Parisians, they're online. I'll be careful what I say, but actually they've well established that it's feasible to get pre-hospital access, although they're doing it for ECMO with a low failure rate. I think Lionel said about 8% failure rate, but using a hybrid technique. And coming up to date, so with the Norwegian HEMS data, again, they reported on 10 patients they did rAAA in medical cardiac arrest with high success rates using the 7 French system, ultrasound guided, in inserting the device to 50 centimeters. Interestingly, so procedure time there for getting in, 11.7 minutes mean, and they've actually reported nicely on the vessel sizes, so what you can expect to see. The London Air Ambulance data set as well reports on a case series of patients having pre-hospital zone 3 rAAA. And interestingly, so of the 19 cases where it was attempted due to exsanguinating pelvic hemorrhage, which is their indication, they only got it in 13, and it failed in almost a third of cases due to difficulties with operators' ability to get access to the common femoral artery using ultrasound guidance in the setting of shock. So in those patients also did quite badly. And where access was achieved, inadvertent SFA cannulation was quite common, and there was almost ubiquitous thrombus. So there are real challenges with doing this in the pre-hospital setting. And both of those services didn't stumble into doing femoral access by accident. They trained and trained and trained. So on the left-hand panel there, I've got my colleague Claire Park doing a rAAA sim at the Royal London on the helipad. On the right-hand side is the Norwegian HEMS teams preparing to deliver this in the pre-hospital setting. Other data, military setting, the US SOST have reported as well. This is a very sick group of, I think, about 20 patients who they did pre-hospital rAAA in. Very unwell, tachycardic, hypotensive patients. Access 14 percutaneous, 6 were open, using a 7 French sheath and an ER rAAA catheter. And the news from that was 6 were placed by people. The surgeon was busy operating, so you've got to train the rest of your team to do this. You can't just do everything as the surgeon. So there is data. Interestingly, their approach to closure was quite different because the patients were being moved off to another center. So I think they said, 2 of the 14 cases underwent an arteriotomy due to puncture site bleeding, but the rest they took it out and pressed. They went in and fixed the artery. Looking at complications, so there's this meta-analysis which cites just a 5% complication rate, which for me is surprisingly low. So I'd have to look at that data set a bit more carefully. But that's the aim of the game, is to avoid complications. The signal there is about 5 or 6% for groin complications. But that includes all comers and hospital patients as well. So in summary, there are lots of challenges doing this in the pre-hospital setting. It can be done safely and quickly. You need the right person with the right equipment and the right training. And in my second talk later on today, I'll hopefully present some solutions to you. So thank you very much for your attention.
Thank you for a very, very controversial issue and very training intensive treatment and how many lives can we save. This is, of course, a wide discussion. I don't know if we have time for the whole discussion. I know that HEMS and military teams are experts on training people. Tal has a nice story about what it means to train and then drive into the lake with a tractor. I don't know if you want to share it with us, but training is the key here, right? So how many hours of training is it per saved lives?
It's hard to say, isn't it? So for our military training program, we take people who've often done no ultrasound guided puncture, and they get a morning on the simulator with a session on a simulator with one-to-one hands-on tuition. Really, you need to go and do it in your base hospital, don't you? So you need to go back to wherever you work and force yourself to get the probe out and force yourself to go to IR or cardiology or wherever is doing it, if you want it to work for you with a hemodynamically unwell patient. Pre-hospitally, we're doing this all the time, and we've gradually grown our cohort of consultants who are trained. So most are anaesthetists or emergency physicians who are doing it in hospital as well. And really the training is just, this is the equipment we're going to use in the pre-hospital setting. But also mentally contextualizing it and thinking, well, how's this going to work on the floor, under the kitchen table, with CPR going on around me? I think that's important as well. And most of these people are used to operating in that environment. So the environment's not a challenge, but the equipment is. So rehearsing it, thinking about it, I think all of that's important.
May I ask a question, please? My name is Anitha Du. I'm a vascular surgeon at Mass General. That was a fantastic talk. Just a quick question about your patient selection. So that girl, Vicky, how did you know that was a patient that would need something like this? I mean, would it just not delay you getting to hospital in a place like London where it'd be fairly easy to get to the hospital quickly? And what if you blow up something like this in the renal or
Good point. So everybody who works in hospital never understands the pre-hospital timelines. They are always much longer than you think. So you can look at it and think, yeah, we'll be in hospital in 5 minutes. But by the time you've moved her off the floor, you've given her some analgesia, you've put her in the ambulance, you've loaded, closed the doors and gone, you've lost 10 or 15 minutes. And I think their feeling was that she was her respiratory pattern. When do you ever see patients in ED who look like that? You don't, because they're dead before they get there. So I think their feeling was that she was peri-arrest, she had an unrecordable blood pressure, she was just managing to cerebrate, and without doing anything, they thought she was going to arrest. And I think they're probably right. And we have pre-hospital blood products. I think you're right, case selection is important, but I don't think hospitalists really see the true pre-hospital picture in terms, we often think, well, it took them, how did it take you an hour to get here? But to get somebody off the floor, intertwined with bits of mechanics that have driven over them into the back of an ambulance is a challenge. And I think some of those patients will just arrest during the pre-hospital phase. So their feeling with her was she was pretty time critical. And, the second team, that was 2 medical teams actually attended her there, arrived before she was in a position to be loaded into the ambulance anyway, really.
How do you know that it wasn't like a tamponade or a tension pneumothorax or literally anything else?
Yeah, I mean, she had lorry marks over her pelvis, and her lungs were going up and down. She didn't have surgical emphysema. If you want to know, you can put an ultrasound probe on and see the lungs are up. So it is possible to work out what's going on. But often, you're right, it's a combination, isn't it? Nobody usually has just one system that's injured.
I mean, are you tracking the scene times? And I mean, because I think this is a big question of time on the scene, transport time, and the nature of the patient's injuries. In an urban environment, your transport time is probably, 5 minutes or less once you're packed up.
It's never 5 minutes. It's never 5 minutes anywhere in the world. It's
I
never
think we
5
do not
minutes.
have time for this discussion because this discussion can go for ages and ages. This is a very, very interesting, and I'm very, very impressed by the HEMS people in our units as well. And we all know that they train a lot. And I think we will, during these days, want to ask the question, who should do the access in which cases? It's a local and political question. Think about it. But now let's have some coffee.
So as a sample exam, until now, a lot of reports of the early intervention by HEMS have been in zone 3 report.
I mean, if it's a prolonged transport, like in an austere
Hello?
environment, fine. But if they're in a city, like, how much time are they spending trying
They are
to
spending-
get access and not ruling out other injuries and unpacking the robotic kit?
Yeah. But I can understand his point because
And they have physicians in their model. They have physicians on that.
Yeah.
So that's the other difference. I think, at least on the U.S. side, we don't have physicians in every hospital.
I've heard them describing it, and it's really controlled, so they never access the balloon above the bifurcation, and it's a very, very narrow patient selection. I've been working in the hospital, and they have a point. It doesn't take 5 minutes, it takes 30 minutes, even if it's a 5-minute consultation, because you have to load and it's fiction. But even though it's so in most areas in the world, it will never be. I mean, the whole Scandinavia, large part of Britain, large part of the US, is scarce.
Yeah.
I suppose.
Yeah. Okay, nice talking to you.
Yeah. For you, that should be done axillary too. Okay.
Very well, you can see where the artery changes color. Yeah, you have to perform the artery here.
Okay. And
So you get this puncture just above where the artery is larger.
Okay, this is also good. Actually.
Would you like to take the first place?
Okay. Thank you.
Yes, thanks. We can put maybe.
Already.
Yeah. I agree. Yeah. Should I take this? Yeah. I will take my iPhone here so I can see. Yeah, I agree. It's great. Yeah, yeah. I think we are quite well in the schedule, so we'll have to. Oh, we are. Yeah. Let me see. Should I open the session? Yes. Okay, let's start. I think we are now 11 o'clock, and I think people are slowly moving from the coffee break to the auditorium. Hot topics in Endografts and other tools for the bleeding patient. And we start with landmark papers on endografts actually, no, we just heard that unfortunately the first speaker is not able to be with us today. So we go to the second talk, and it's, yes. Would you like to present him?
I was, but where is he?
Yeah.
He's coming, okay, sorry. The problem is because Tal changed all the program. I'm looking at the paper and then I'm completely confused. But I'm honored to invite Pekka from Helsinki, rupture, AAA tips and tricks. How to maximize survival. I think this is the point that we're looking for, that the patient survives. So, Pekka, here you are. Thank you. Thank you for the kind invitation. And to start with, you need good equipment. And at Helsinki University Hospital, we have the third generation of hybrid theaters now going on. But I start with the access. And this is a video many of you have seen already, but I just show the start here. It's made of on a live real rupture case. And you saw that I had a longitudinal view in the ultrasound probe, as you can see here, and it's very nice to puncture it and steer the needle forward. If there's a calcification, as in many cases with aortic aneurysm, as you can see here, there's a huge calcification in the back wall. You can really steer the needle above the calcifications, because without this, it's a very high risk to do subintimal puncture. And here I had to let loose the needle because I have the left hand in my ultrasound probe, but I put in the wire, and you can also see that the wire enters freely the artery. It's not going in the subintimal space. If you use a closer device, like in this case, it can be stuck under the calcification in the back wall. But it's very easy just to push it back a bit and then rotate. Then you can free it from the calcification. And with longitudinal view, you can see that it sits nicely in the front wall of the artery. Push it back, rotate, and pull it back. There. Always check with ultrasound that the flow is free. There's no dissection or anything else complication after the closer device. The closer devices, as you know, they go in without the guide wire. So in this case, there was also an aneurysm in the common iliac artery, and unfortunately, the closer device ruptured that also. So there was a rupture also in the common iliac, which we could manage with the occlusion balloon and continue with the EVA procedure as normal. As previously shown, the guide wire can easily go to the circumflex artery and rupture it in this case. So beware of that. Handling with wire and the catheter can also rupture an artery, and this had to be we had to do an endarterectomy to correct that. This is a blind clamping of the aorta in a rupture case, as we did before earlier. And as you see, it's not easy. You can't see anything actually. There's the clamp, and the aorta is somewhere there. But unfortunately, we nowadays have possibility to put in an occlusion balloon. In this case, there's not really room for the clamp either, because the aneurysm is so huge. Occlusion balloon, we use nowadays occlusion balloon in all aneurysm rupture cases, whether we do it open or endovascular. We can put it even though we do CPR to the patient, but nowadays we have this Lucas machine, which is very handy because you can continue the procedure with the Lucas on. You have to be aware that the balloon needs enough support. Like in this case, it tends to bend down and come down, especially if there's a big aneurysm. That's why we nowadays use
Two introducers, we put in a 18 French dry seal first, and then inside that a longer 12 French sheet. Then we can put the pigtail catheter in between them, and we have a very good support for the balloon. This is our routine nowadays in the rupture cases. You can also clamp the aorta, though the introducer sheet is in there, or put in a temporary axillary renal bypass, like in this case. Oh, that's a schematic drawing. And this is interesting thing because if you've previously done open surgery to the aorta, there can be common iliac aneurysms which can grow. And in this case, it's very difficult to put in a covered stent, or actually it was earlier impossible. But nowadays, when we have the steerable sheets, it is possible because you can, I'm really fan of these steerable sheets. You can put the covered stent in and then slowly deploy it while we're drawing the sheet slowly away. So you can deploy the Viabahn in the inner curve of the aneurysm with a very nice result. If there's tortuosity in the iliacs, it's very difficult to cannulate the contra limb in the EVAR. Even highly appreciated specialists struggle sometimes with it. But if you use the so-called, which we call the side rail technique, you have a stiff wire outside the stent graft, and then you can push the sheet up to the contra limb like this. Then you minimize the distance between the sheet and the contra limb, and it's very easy to cannulate then the contra limb, and this saves a lot of time. Thank you.
Thank you very much, Pekka. Now you have shown us tips and tricks how to maximize survival. So what is the survival of rupture patients in your hospital? Is it 100%?
You asked what's the rupture mortality in our hospital. Well, it used to be like something like 40–50% in the old days. But since we've done this simulation training and do most of the cases with the endovascular means, so I think it was something like 23%, the operative mortality. And we do, this turn down rate is very, very low in our hospital.
Any questions from the audience?
I think it was very beautiful. Do you have any estimates of the time of surgery in the ruptures? What is your time span? And if you have any, my feeling is always if the surgery, the endovascular opening is shorter, the survival will be higher. But do you have any numbers or more from Finland on this or from the Canada?
Do you mean if we compare open surgery with endovascular at time? Well, I have a gut feeling that the endovascular is much quicker. But really, I don't have any figures. No, I don't know.
Yeah, just to say that a couple of last years, we did 51 cases, ruptured aneurysms, and 15 of them were open surgery and 36 were endovascular cases. I don't know the time. Yeah, please go on.
Sorry. My understanding of your question was if cases are faster, is survival going to be better? I think for sure that's the case. Right? The easier it is to do, the faster you can do it, the less blood loss there is, the less likely you're going to have abdominal compartment syndrome after to deal with. So I think those cases are going to, they generally do much better.
And in our material, if I remember correctly, so with open surgery, the mortality is something more or less like 40% still. But with endovascular, it was less than 20.
I have a question actually, because this was something we came up in our group, is is there a situation where a patient is fit for endovascular repair of a ruptured aneurysm, but not fit for open repair for whatever reason? Would you ever not do an open repair in a patient you would have done an endo repair on? In a ruptured situation.
I couldn't hear your question.
So for example, let's say you had an 85, 90-year-old patient with ruptured aneurysm. They're, physiologically frail, and you would offer them an endovascular repair, but for whatever reason, you don't have the option because the table's not working, the C-arm just broke, and you have to now do open. Would you ever deny that patient open surgery?
Well, not in our case, no. We would do something anyway. It depends always. You have to see the patients. You have to talk with the patient and feel the patient and do the decision yourself. Is it wise or not to do? And you have to know whether the patient can live at home, move, just go to outside or not. And so it's a tough decision here.
Yeah, I guess my bias is that there's like a surgeon, eyeball test, and some patients you just think they're not going to tolerate open surgery. Even if you do the best operation, they're just, doesn't matter. They're not going to do well.
I think for that particular question, I would break down a patient into whether it's going to be a thoracal or it's going to be infrarenal. If it's an infrarenal aneurysm, then the chances are I'll treat it like the same way. So if I'm going to do it endo, and I could have done it open infrarenal clamp and do it, I would do it. But if we're talking about snorkeling a bunch of stuff or, having to do a fenestrated or PMEG, and you can't do that, and now you're talking about bypassing renals and this and that, then it would change things for me. Also, in the absolute worst case scenario where you can't get into the renals, we say dialysis is better than death, right? So sometimes you just throw a graft across the renals and you're going to lose the renals. But obviously, in a case of an open, you wouldn't be doing something like that. You'd be trying to salvage. And so I think that's what my cutoff would be, whether or not you're going to do anything beyond just clamp and sew below the renals.
Yeah, thank you. Final comment from Pirkka, and then we move on.
Yeah, I have a question about the partial or total occlusion of the balloon. How do you tackle with that? Because you know that if you put partial rAAA, then the patient will continue bleeding from the hole, and maybe the risk of intra-abdominal pressure is higher. So what is your guidance on how to tackle with this problem?
That's a good question, because I've seen in many cases that the patient stays more or less stable without the balloon opened. But the procedure takes about half an hour to do, and during that time the belly gets very hard, and afterwards we have to open it. There's a huge hematoma, so I tend to close the aorta if I suggest that there's a big bleeding. You can see really actually in the CT, previous CT, if there's a big hematoma, then I more or less tend to close the aorta, even though the patient is quite stable, and not use any partial rAAA in those.
Good, thank you. And our next speaker is Artai Pirosram from Sweden, talking about thoracic ruptured AA and endovascular solutions, technical aspects and reflections on multidisciplinary work. Welcome.
Thank you so much. It's really amazing to have this meeting face to face. Thank you so much, Vital, for all your efforts that you've done. So I'm going to share with you some of our experience in treating ruptures, thoracic aneurysms. Now, there is no doubt that TEVAR is superior to open surgery when it comes to the ruptured thoracic aneurysms in terms of mortality, in terms of morbidity. So that's why if you look at the European Society of Vascular Surgery guidelines, they have a class 1 recommendation to use TEVAR in all kinds of ruptures. So the role of open surgery is quite clear that it's in no way to go. So when you want to consider repairing thoracic aneurysms in ruptures, you have several things to think about. The first thing, we've heard a lot about today is the access vessels. It's about the diameter, the tortuosity of the vessels, the calcification amount. Then you need to have a proximal landing zone. Sometimes you need to get into the arch, and then there are issues covering left subclavian artery or carotid artery. There are some issues you need to consider when you are about to deploy your graft in the arch concerning the conformability of the graft. And of course, you need to consider distal landing zone, which we try to land above the celiac trunk, sometimes covering it. And then, of course, the last question is the risk of spinal cord ischemia. And we know that the most sensible part of the thoracic aorta is the lower thoracic aorta. So these are the issues that you need to concern and consider before doing your procedure. So everything begins and stops with access vessels. The amount of calcification can be some hard. And TEVAR devices normally need 7 to 8 millimeter of diameter of access vessels to come in the aorta. That's why you need to define your strategies for poor access vessels, because in these cases, there is no time to think about how you solve it. You just need to have these thoughts before. So there are different ways to do that. Pave and crack, we've heard before. Conduit free access is actually the type of access that we've published when you deliberately puncture the external iliac artery and then come from above, below and cover it. You can use, of course, conduits, but they are time taking. And most of the times nowadays, we can use shockwave just to make the access very, very quick and fast. And you can come up with large bore devices easily through the calcified vessels. So otherwise, these are the scenarios that you might typically see. The junction of the internal and external iliac artery is a very poor place if you are calcified vessels, and in order to avoid ruptures like this, then you need to prepare the vessels well before you go up with your device. Now, coming to the landing in the arch, there are different types of arch described before, and when it comes to entering the device in the arch, the inner curve of the arch is really good to notice that there are different types of arch, and this could give you some headache when you want to get proximal sealing zone in the arch. Normally, in cases like this, you can have a bird beak that will give you a type 1 endoleak, and this cannot be tolerated in the ruptured case, so you need to use the right kind of device for the right kind of arch. So there are different devices available on the market, and you need to, they have different capabilities, and they have different conformabilities, and then I think it's good to have at least 2 or 3 devices in-house on the shelf to use the right device for the right kind of patient. Now, this is a paper that we gathered some years ago. This is a multi-center study in Sweden, 6 vascular centers, including Linköping and Örebro. And they actually took a look at the all ruptured cases that were registered in SwedeVasc between 2000 and 2015, 139 patients, which is quite good to do the study. And in this case, majority of the cases, majority of the proximal landing zone was right after or right before the left subclavian artery, and this is the case that we recognize. And in this study, they could show that in 53 patients, the left subclavian artery was deliberately covered to extend the proximal landing zone. In 25 patients, which is about 80%, arch vessel revascularization was performed. So coming to the covering of the left subclavian artery, there are a lot of articles. Some of them say that you can do it without any punishment. Some of them say, well, you need to consider it. If you look at the European Society of Vascular Surgery guidelines, they recommend that you should consider revascularization of all arch vessels when it's in elective, and when it comes to emergent cases, and you have the patients at high risk, which is if they have a marine artery used in previous CABG, or if they have a dominant left vertebral artery, you need to consider to do that. And the ways to do that is that you can either use the chimney grafts, like in this case, to preserve the left subclavian artery. You can use chimney grafts in even left carotid artery and occluding the left subclavian artery. Physician-modified fenestrated arch devices is also an alternative. I'm sure that Klaus will going to tell you some about that, and this can be beautifully done in the arch, even in urgent cases. Branch devices are coming more and more. In some centers they are available, but I think that we are going to show more of the branch vessels in the arch soon. When it comes to the complex ruptures involving the thoracoabdominal aorta, like in this patient, which is actually a ruptured dissection with a concomitant infrarenal aneurysm, you should consider what kind of patient you have, what kind of hemodynamics you are facing. So in highly selected patients, you can do a damage control with TVAR just to exclude the rupture side. And if the patient improves, then you can proceed with your off-the-shelf device for the thoracoabdominal repair. This is one of the cases that we did in thoracoabdominal repair. And of course, these cases, you cannot stage these patients. You need to cover the whole thoracic aorta with high risk of spinal cord ischemia. All this is not done by a single surgeon. I think that everything begins with first call, and then we try to give these patients the right kind of care in the operation room. But I think without an effective ICU care, you're going to lose these patients in multi-organ failure. So it is very important. So in conclusion, access vessels should be considered before planning your TVAR cases, and getting proximal and distal landing zone in ruptures is critical, because you cannot end up having a type 1A middle leak, because you're going to lose the patients. And you need to choose the right stent graft for the right type of aortic arch, and you need to have a clear strategy if you want to cover or vascularize the arch vessels. Thank you very much.
Thank you very much. Great talk. And it's not easy to explain everything in 6 minutes, or I'll have to change these 6 minutes talks a little bit longer. This is why treatment of ruptured thoracic aorta is so complex, because there is so many issues that have to be covered. Especially I like first, because you mentioned ESV guidelines. I think we have to stick to these ESV guidelines, because we have to have some reference what we are going to do. Some of the complications that can occur by thoracic rupture is the spinal cord ischemia, and then discussion about should we revascularize left subclavian artery through parallel grafts or through the bypass can be answered during the procedure if we are doing that in the local anesthesia. So that means in the local anesthesia, we can have perfect neuro monitoring, and we can see if it's necessary to make something. So my question to you is, how often are you using for the rupture thoracic aorta local anesthesia?
We always start with local anesthesia, and we try to keep the patient awake, and imaging could be a challenge if you are in the arch to get the right imaging, but our goal is to start and hopefully finish the case in your local anesthesia.
And when we say local anesthesia, we think local anesthesia with analogous sedation. That means also the patient is sedated, so not agitated. Of course, the same is, we're doing the same if the patient started to be so agitated, then we are going to intubate here. And then maybe also the point, if we finish the procedure, wait as fast as possible to make fenced window to see if he's moving legs or not. Exactly. So also if we decided to cover that. So,
and of course, the other things is that if they are in rupture, the HP is not quite perfect, so you need to give them blood. You need to work up with the middle arterial pressure, so you just try to diminish the risk of spinal cord ischemia.
Do you put a drain in these patients typically?
Sorry?
Do you put a spinal drain in the patients postoperatively?
No, we don't do
you just-
that in preoperatively, but if the patient develops some spinal cord ischemia, we do it fast.
So only with symptoms. Interesting. Thank you.
Just a short question. I had a discussion with Zoran for the sake of the anesthesiologist. As I learned from you many years ago, you don't give a drop of blood to all ruptures, thoracic or abdominal. And if, of course, it's hard for the anesthesiologist not to give blood. Can you guys comment, Artai and Zoran, not to give anything, or how to do practically?
I think in both abdominal ruptures and thoracic ruptures, there are two phases. The first phase is damage control. So you're working with a permissive hypertension. You are allowing the patient to have low blood pressure, and we know that if you try to transfuse these patients, the blood pressure will go up, and we can end up in very bad situations. So the phase one is just damage control. Once the stent graft is in place, once you get control of the bleeding side, then you just go on and fill the patient up and try to have good diuresis. And so you need to think in two different phases.
I will confirm. Can I speak here in Israel? Israel calling. Hello. Oribro.
Hello.
Hello. Do you hear me?
Yes, we can hear you. Do you have a question?
Yes, my name is Simon. I'm a vascular surgeon in Israel. I wanted to make a comment about the previous question that you asked about treating endovascular or open surgery for elderly above 90. I would like to say that if you consider treating endovascular, each endovascular treatment can become an open treatment. So the decision is to treat or not to treat. That is an important part from life experience from last week. With regard to the thoracic talk, hi, Yurai, nice to see you. Thank you for your talk. I would like to say that the Cook or the Gore seem to be more appropriate for women thoracic aortic aneurysms in terms of the access vessel, more friendly and appropriate size, as well as the new Gore thoracic graft, which is very, very low profile. So I wanted to add that comment.
Thank you for the comment. Would you like to answer or try to move on?
Me? No.
I mean, I think in parts of, depending on the axis, then I think that the first thing is to analyze the axis well. And before you go I choose my device depending on where I land. And if I need to go into the arch, then I start with picking up the device. And then my other strategy is to fix the access vessel in the proper way. Even though it will cost you 10 minutes more, it's better to take care of it instead of ending up in iliac ruptures.
I would like to comment the access issue. You said that it's very important to plan ahead the access, but sometimes the CT images, you can see very, very calcified iliacs, and you think that no way, no access. And then, well, we had a case where a female was turned down from the elective surgery because the assumption was that there was 1 millimeter iliacs and no access, and the aneurysm was not that large. And then she became in rupture situation, and I made ruptured EVAR and had no problems to get dry seals through the iliacs. They are very hydrophilic, and I think that sometimes CT overestimates the problems in iliacs.
I agree with you. I mean, when I look at the calcified vessels, I start to notice when you have circular calcium, then I start to get worried. And in combination with tortuosity, it will give you another problem. So the combination of tortuosity and circumferent calcium, it could give you a headache, but sometimes you're surprised. But I think in order to instead of try to test if you come up with your device, it's better to fix it first, because if you have a clear strategy, it won't take you a long time to fix it before you introduce the device.
Thank you.
Thank you.
I think we will move on. And our next speaker is here, correct Magi, how you say it? Innovative solutions for ruptures.
Thanks. It's McGee. Thanks. Thanks for the opportunity, Tal, to come to Sweden. It's my first time here, and I'm really excited to speak with you all about ruptured thoracos and suprarenal aneurysms. These are my disclosures. So, as we already heard and we know, ruptured infrarenal abdominal aneurysms have much improved survival from EVAR as opposed to open surgery. That's been pretty well documented as the level 1 evidence and recommendations are for endovascular repair. We also know that elective endovascular repair of suprarenal and thoracoabdominal aneurysms has lower perioperative mortality and morbidity compared to open thoracos. And we know that ruptured suprarenal and thoracoabdominal aneurysms, as we've just discussed briefly, have extremely high mortality. And outside of very, very few select centers who are doing a lot of open repairs, the open repair mortality is nearly 100%. The reasons for this are pretty clear. Number one, you have to involve, it's complicated to do these endovascular repairs. It requires visceral and renal branch involvement. And there's an extreme time constraint. So you can't just leave a prolonged balloon occlusion device in the thoracic aorta for 4 hours while you're doing your repair. And there are no dedicated devices, at least in the United States, for ruptures. I don't think there are anywhere. So there's several different techniques for how to do this, how to treat ruptures. And they're the same pretty much for patients electively. So parallel grafting is a known option. It's been discussed. Physician-modified endografting, where you're tailoring the graft at the time of the case on the back table. We've described that double barrel technique where you put 2 endografts in the thoracic aorta and you're parallel grafting them into SMA and the celiac, and then have IBEs reversed into the iliacs going into the renal arteries. And then in situ fenestrated repair, which I'm going to spend a little more time talking about here. And I think that this technique is really useful in the ruptured scenario. So this allows for, in situ fenestrated repair allows for rapid control of aortic hemorrhage by deploying the aortic graft in the thoracic aorta. So once that aortic component is deployed, you have proximal and distal control. So that's actually a key difference between standard FEVAR, where the hemorrhage control is not achieved until the very last device is implanted, which can often take several hours. So after you've deployed the graft in the thoracic aorta and completed your seal, then you sequentially revascularize each target vessel. And this can be very advantageous in patients with rupture, as even the patients who have contained rupture can undergo sudden cardiovascular collapse due to a free rupture or their circulation, their response to anesthesia. So this is an illustrative case example. 88-year-old patient of mine who came in with a previous infrarenal repair, had a type 1A endoleak, and had sudden onset of severe abdominal pain. And I'm not sure if this is going to play, but 11 centimeter ruptured pararenal. And sorry, can we play that? Okay, unfortunate. So he had a very angulated neck, as you can see here. He was alert and oriented on exam, functionally independent, active lifestyle, regular exerciser, and he desired all forms of treatment be pursued. He had a prior infrarenal repair right up until the lowest renal artery, so there's no option for not incorporating the renal arteries, and he was hemodynamically unstable. So we took him for a laser fenestrated repair. We obtained bilateral femoral access, left brachial cut down. He suffered a cardiovascular collapse during the operation, which required several minutes of CPR. We put a balloon occlusion device up to the level of the renal, just above the renal arteries during placement of the endograft in the thoracic aorta. We released the top cap, and then you had basically a functional balloon occlusion from the graft itself. Came down from the top, from the brachial artery, with a 12 French sheath into the graft, and then through the graft, laser fenestrated a hole, made a branch cuff with the ICAST, and then incorporated first, the celiac artery, which is marked on the screen. This was not using fusion, and that's important because in our setting, at least, fusion requires actually taking the time to do that and registering ahead of time. So then we incorporated the SMA, then released another 2 stent rows, and then incorporate the left renal artery with 2 covered stents, followed by the right renal artery, and then deploy the rest of the graft into the previous EVAR and obtain seal. Unfortunately, he was hemodynamically unstable and had abdominal compartment syndrome, so we evacuated that, temporary abdominal closure, and then closed him in post-update 2. He did have a take back for stenosis in the renal arteries, which we fixed, as you see here and there. And he left without being on dialysis. So he recovered after a month. He was discharged to a long-term care facility, but no endoleak at the time of discharge, and all the stent grafts were patent. We reviewed our data on ruptured thoracos over the last several years, and we compared people who got in situ repair versus non-in situ repair. We found that the mortality was lower, although not statistically significant here, 11 versus 25%. But when we looked at patients who were hemodynamically unstable, it was a dramatic difference. 8% mortality in the patients who got in situ laser fenestrated repair versus 45% who had all other techniques. And this is our data over the course of several years. As you can see here, in 2018, we had a peak of 14 ruptured thoracos and suprarenal aneurysms. And the blue here is the all other techniques. The orange is the in situ repair. And as you can see, in last year, we had just 6, but all of them were done in situ. And so our shift has gone completely to that direction. And in summary, there are several methods for endovascular repair of ruptures in the thoracoabdominal aorta, but our preference has gone towards in situ FEVAR. In situ FEVAR is associated with decreased mortality in patients who present with hypotension. However, postoperative complications and reinterventions can be high. But again, our mortality is if you survive through this operation, you survive a ruptured thoraco, and it requires a couple of repeat interventions, that's a win. Obviously, further data are necessary to assess the durability of these techniques, and we're looking to do so. Thank you.
May I ask you a quick question about how you put the wire? Like, do you put wires in prior? How do you find the artery after you put the graft up?
That's a good question. So there's
Cannulating.
what we learned about trying to do this actually from Stefan Alon's group, who published their outcomes on laser FEVAR, and they only had 2 patients, I believe, who were ruptures. Most of them were sort of elective and they couldn't get normal devices. But there's basically 2 techniques. If you have a pretty straight iliacs and straight aorta, and you're planning on doing fenestrated so that the endograft is actually occlusive at the level of each of the arteries, you can pre-stent them if they're hemodynamically stable. So you go in, pre-stent the celiac, the SMA, the renals, so you can see the stents when you're actually doing the pop-through with the laser from below. So that's a sort of transfemoral technique. And then if there's a thoraco and they have basically a more free space, or if they're really angulated, if they have a lot of tortuosity, it can be more difficult to do that because you can't see the barrel view as well. And so in those options, we come from above, from the brachial approach. So we'll deploy the graft down at least 2 stent rows to get that sealed zone. The next stent is then partially deployed, so it looks like an inverted house. You come from above, and then where the graft is partially deployed there, pop through with the laser probe, put in a branch cuff with like an ICAST, just to maintain that stability. And then it's like a T-branch or anything else. So you go through, fish around, find the next branch, and then sequentially keep going through and do each one individually. So each time you have essentially a very small portal through which you're working, where there could be some hemorrhage.
Greg, I have a technical question. That was a very good talk, very interesting. When you're coming from the top, and I assume you may be using a steerable sheath, are there any working length considerations in terms of where you choose to access? And are there times when you have to come from below because of that?
Yeah, that's a good question. So from the technical side, if you're going to come from the top, it's you could use axillary. We use brachial access just because we're very familiar with that and do it very quickly. But a 90 French steerable sheath works really well. We use oftentimes a 9 French 70 tour guide, or 9 French 90 tour guide, 7 French 90 tour guide, or 8.8 French, the Nagari sheath, which is also 90 centimeters. And so then steerable in both directions. So it's just actually advantageous because you can steer the one direction for the celiac and the other direction for the SMA.
Greg, this was excellent presentation. I was wondering, how long do you give visceral occlusion before you start going to open? And when you do open, do you try retrograde fenestration first, or do you go straight to open bypass?
Good question. So thanks, Richie. And my experience is ruptured thoracos, we have not had really any survivors. So in terms of the visceral ischemia time, it's actually not that long. So in our series, basically the ischemia time is about 15 minutes per branch. So if they're hemodynamically stable, then you can leave a buddy sheath, like a 12 French buddy sheath, along as a gutter leak. So you're purposely creating a gutter leak and then doing the branches. If they become unstable, you take that out. You can leave a single branch as a perfusion branch to the rest of the viscerals. And now, when we come from above, it's easiest to do celiac and SMA first just because of the order. But if I do it from below, then I'll do the renals first because they're less tolerant of ischemia. So, it's probably 15 minutes on average per branch, and sometimes the renals are harder because it's harder to get the barrel view from the side, and so if you sacrifice one renal, that's I'd say it's still a win.
Yeah, thank you. As you can see, this was really good discussion, and congratulations for this technique. I would like to ask one question. How many cases you have in your series? What is the learning curve? Can you practice this if we now who do standard EVAR want to start this technique?
Those are great questions. In terms of the learning curve, I think that's a really important point. And we discuss this all the time. We developed our experience with laser fenestration in the easiest way possible with left subclavians, like I think most people will do, where there's really a lot of leeway where if you are unsuccessful, you can always bypass, you can always transpo. And so once we got really comfortable using the laser probe in those situations, then we started to do it in these other situations. And really this is like where necessity is the mother of invention. So we had patients where they came in with rupture and we try to do a PMAG, which we do a lot of, but they either while we're making the graft or while we're trying to deploy each individual visceral stent, they may rupture or freely rupture and then die. And so our experience was that we were just unsatisfied with that, how long it took to get complete control of hemorrhage and finish the case. So really it just came down to saying, let's just try it because we have no other good options. And we used the technical tips we've learned from from standard FEVAR and from laser fenestration in the subclavian, and use the barrel views because that was actually the most intuitive way to do it. And then from there, we sort of learned how to do more advanced things like coming from above and then incorporating them into it individually.
Thank you very much. All the other questions, we have a long lunch, so you can continue with the questions in the break. So we will continue. The next speaker, and I can confirm he really wanted to come to Orebro, but he was stuck in London. Martin Malina, the rupture, injury, or iatrogenic iliac artery, endovascular and hybrid solutions. Please, Martin.
Thank you, Zoran. Let me see if I can turn on my screen here. Can you see my screen?
We can see your screen, but slides are very small.
There we go.
Yeah, now, good.
Okay. I believe that Tal wanted me to speak about hybrid procedures for iliac injury, but I have to admit that, at least in my hands, this is so utterly rare. I see utterly few indications for any open procedures for the iliacs. And the only thing I could really come up with was the end result of some paving and cracking. If you have to extend the paving and cracking all the way down into the groin, then you have to fix the groin with open technique. And the take-home message there, I think, is that the covered stents that we use for endovascular purposes are notoriously difficult to stitch. The fabric is so thin that your stitches will tear, so you will struggle a bit, but we all will fix it eventually. Instead, I would like to use a few minutes to point out perhaps a word of caution, something that happened to us recently and that I was completely unaware of. We have called it the pulley effect. And this was prompted by two female octogenarian patients who had SFA occlusions and were treated endovascularly for critical limb ischemia. And they were completely parallel cases, just a couple of months apart. They had normal aortic bifurcations, I would say, for their age. And both were treated over the hill by inserting sheaths from the contralateral groin. And it was a simple cannulation over the aortic bifurcation on both occasions. Yet, and the procedures were then carried out through these sheaths without much problems, really. But at the end of the procedures, after a couple of hours of fiddling with tibial arteries and SFA and this and that, the patients had, both of them, ruptures of the aortic bifurcation. And here you can see both aortic bifurcations ruptured, extravasating. There is an occlusion balloon in the left bifurcation trying to stop the bleed. That didn't work out. There is an aortic occlusion balloon in the right, and we are injecting below the balloon, and you can see the extravasation. It was a dramatic situation on both occasions. Both patients were treated with syrup, and again, you can see an aortic occlusion balloon in the aorta on the left side. And we succeeded in repairing the bifurcation with this syrup technique and seal the leak, the rupture. However, these octogenarians had bled already too much, and both subsequently died in the ITU. So it was a tragedy in both cases. That made us look into why did they actually rupture the aortic bifurcation? Because I would have thought that once the sheath sits across the aortic bifurcation, then you should be able to work through that sheath safely. It should not affect the aortic bifurcation once the sheath is in place. Yet these patients ruptured after an hour or two of operating. So what was the mechanism? I always considered such a sheath to be pretty much of a Bowden cable. That was a German engineer who made this invention where you can transmit some sort of traction through a cable to pull at a remote site, while the actual bifurcation site isn't much affected. And we are all familiar with this principle from, for example, your bicycle brakes that we use on an everyday basis. So what was particular about these patients and why did they rupture? Well, I'll show you one of them in some detail. This lady had a superior stent put into the adductor canal in her left limb, and there was an invagination of that superior stent. And so the operator tried to correct that by inflating a balloon into the superior stent above that invagination and then pulling at it a little bit. And you will see how he's pulling, trying to correct that invagination. And he didn't use very much force. My estimate is that perhaps it was 5 Newton or so. I'm sure that this was an experienced colleague. I'm sure he didn't use excessive force. But he didn't think about, and I wouldn't have thought about it either, that the traction was applied from the contralateral groin. So if you then pull with 5 Newton from the contralateral groin and the system doesn't move, that means that there must be an opposing force of 5 Newton from the other side, meaning that the overall traction at the aortic bifurcation will be the double. This is what a pulley is about. So you will actually exert twice the force that you think at the aortic bifurcation by doing this maneuver. You achieve your own aortic pulley, and the pulleys, have been used widely for sailing and for bringing up water from wells, etc. It's a common physical principle, but at least I wouldn't have thought about it before. And it's easy to imagine that if the anatomy is more complex, like a more complex pulley, then by still pulling only by 5 newtons, you will achieve significantly higher forces elsewhere in the system. We validated this in a bench model, and I think that it fits. And if you then do body floss wires and pullet wires and catheters inside the body in more complex morphology, I can't even imagine what forces you actually can exert. So I think we need to be aware of this pulley effect and be a little bit cautious. It is generated by traction at curved instruments that like sheaths, catheters, and wires. And the force that is applied by the operator at one end can get magnified 2 or 3 times if there is this type of tortuosity. And I think that this perhaps may explain some complications that we previously labeled as cheese cutting. It is possible that this was more of this pulley effect than the actual cheese cutting. Thank you for your attention.
Thank you, Martin, for your talk. A lot of physics, even though it looks very clear, but thanks. Maybe to ask the auditorium or the panelists if they have question to you. If not, or maybe they have.
Martin?
Yes.
Hello. I will show you, I'm sitting here in the back is the Middle Eastern shoreline.
Yes, we see you and we hear you.
I would like to ask, I had a similar case. Once again, I will bring up my 92-year-old aneurysm patient who had terrible, terrible friction in placing the endograft. Although in the first CT angio, anatomically, there was no tortuosity, there were no, nothing anatomic which convinced us not to offer him endovascular repair, but the tension that was felt in inserting the stent graft was something that I had never experienced before. So if you have anything that you can share with us about 92-year-old vessels that seem anatomically normal, but the friction was not normal at all and was an almost catastrophe. He did come out alive, but it was not a pleasant experience. Can you give me some advice? What you...
Well, I think that we are talking about slightly different matters, Simon. Friction for sure is a huge problem, and obviously old patients have fragile arteries, so that's one thing. But this pulley effect can cause problems without any friction at all. And you know, I've been using a lot of these body floss wires, where I apply some traction in tortuous anatomy from, say, the arm and the groin to bring up large sheaths through very tortuous iliac arteries. And now being aware of this pulley effect, I think I'll be a little bit more wary, because whatever traction or push you apply may be magnified inside that patient due to this physical phenomenon that I tried to describe.
Thank you.
Thank you. Yeah.
Can I comment or give you a warning example? I had a patient where I put a reinforced sheet from brachial access to aortic bifurcation, which was very, very calcified, and it got stuck there. And I couldn't recanalize that. And then I pulled the sheet and it got in 2 pieces. But once it was reinforced, it has this very tiny metal wire in it. And I couldn't see it in the fluoro, but when I withdrew it from the arm, and the lower part was still in the aortic bifurcation, it dissected the aorta and the patient died. So you should always have the sheet, when you withdraw the sheet, you should put the dilator in always. Otherwise it can be damaged.
Yeah, and I have actually heard that with the same sheet that you used, this has happened in iliacs. So that when you go crossover, the distal part stuck to iliac and the proximal part came out, and then you had this jiggly saw between these two species. So that is something that is very dangerous and has to be kept in mind.
Yeah, and Mari, it was Mari, wasn't it, speaking?
Yes, yes.
Yeah. Hi, Mari.
Hi.
And as you then pull on that stuck sheath, remember that whatever traction you apply with your hand will be twice as strong at the bifurcation.
Exactly, that was a great reminder from the physics we learned 40 years ago. Thank you. All right, it's time to move on. And we have here Restless Pirkka Vikatmaa waiting to give his talk on Rupture AAA saving patients is a team effort.
Thank you, Marit. Thank you for the invitation to EVTM. I'm talking very simply because I often go to congresses and I see these fancy cases, and then I go home and wonder why we cannot do it all and be always successful. I've been collecting contacts with industry for the ESVS, but the economical support goes not to me, but to ESVS. I'll start from the last century when Ilkka Kantonen, who's still our chief in aortic surgery, did his thesis on the first vascular registry that covered nationally, and he analyzed the ruptured aneurysms from the typical points of view, but he also analyzed the transportation distance, and the conclusion was that the transportation distance actually for those patients who were initiated transportation did not have an effect on the mortality. So the message back then at least was that the patient don't die in the ambulances, but the ones who are started the transportation come to the hospital, and they survive better if they come to a hospital that has better results. So this is a region of about 400 or 500 kilometers across. From the red dots, they do mainly open aortic surgery. They don't have hybrid theaters. The green dots are other hospitals, and the Helsinki is the blue dot. So we have a challenge of this about 2 million people area to cover that. The scientific team effort went forward, and Sani in 2006 did her dissertation on ruptured aneurysms, and you can see on the top that a lot of the aneurysms actually don't ever reach the hospital, so like 44% die before, and this was the early ages for us in the rupture treatment with 4 patients and 2 live, 2 dead. But the results then were like 38% in hospital or 30-day mortality for the patients. A guy sitting here as well started the endovascular era in our place, and Matti Laine analyzed, and the numbers are actually quite the same in 2016. This is the material to 2013, so many patients died before, and only a proportion of patients reached the hospital. The incidence and mortality of rupture aneurysm goes down, but we don't do screening in Finland. But what is lucky is that when the patients survive the rupture, their prognosis is the same as for non-ruptured elective AAA patients. So there has been a big change in the training of the teams. This was obviously blood going around. This patient actually survived from despite opening without any coverage. But nowadays, this also is an old picture because you don't put the knots in the holes. So the scene has changed a lot, and there's a need for training. It's an organizational team effort because you have a bunch of doctors. We have 21 consultants and 6 juniors, and they all have to be trained in some way. So we have in hospital mostly junior, and they have to be trained in putting in the REBOA for the rupture patients. And we have 7 out of 21 consultants who do endovascular stuff or endovascular aortic stuff. All do actually, more or less all do endovascular PAD stuff. And all anesthesiologists are trained for EVAR and open aortic surgery in our unit. But the people doing the ruptured EVARs, they are actually at home when the rupture happens. It's an organizational teamwork also for creating the environment. As Pekka told you, we have the third generation now going on. And we were very slow learners. You can see almost a 10-year learning curve in when we started to do more and more endovascular stuff in these hybrid theaters. And now we're going on towards the next couple of hybrid theaters and a Raptor suite from 23 onwards. Whether or not the Raptor suite will save any of these patients, we don't know that yet. When the patient comes to the emergency department, there are different scenarios. Either you know that there is a suspected, either you know it that there is a AAA and you have a CT, then you can go directly to the operation theater, and that is of course a straight line. And about half of our ruptures recently go directly to the OR. But then you have these suspected ones. You need to perform a T1 process for the CT first. And then you have these surprises, in-hospital surprises, which are the nasty ones. And even though you have the Raptor process, you will still have these in-hospital surprises, which is 20, 30, maybe even 40% of your patients. So therefore, the whole team needs to be educated. You have to, or we have decided to do these training videos, both for trauma and rupture patients. And then we have simulation practices, as many of the centers have. Specifically training for ruptures in the OR, you can see the number of people that need to be learned or taught to the process in order to have a 24/7 coverage is quite big, and therefore you have to have quite a lot of these simulation happenings. And we are very proud of our 15 hybrid nurses who can do both angio lab and open surgery tasks. What we see today is that when we have the simulation, the functioning in the OR when the patient is coming is much more calm. And actually, I think this is a moment to be very proud of your system when you have scrubbed and you're going to touch the patient, but you actually have nothing much to do at that moment. So look at your team working. And if it's a hassle, then you have not done a proper work in simulating. But if it's calm and very efficient and everybody is like doing their job, the more urgent it is, then you're doing a good job. This is a video that you already saw from Pekka, and this patient also survived. We surgeons tend to forget that the most important part is that we do fancy procedures, but the patients would actually die without the anesthesia and ICU teams. I'm a bit biased here because I'm married to one, but not the whole team though. But still, this is something that we forget, and the discussion with the anesthesiologist should be ongoing all the time. To summarize the presentation on rupture EVARs before the simulation training and after, this is a period where first 18 revars were done, and you can see a 39.2% mortality in the beginning for all, both open and EVAR together, and 30-day mortality in the later phase was 25% for all patients that coming in and are operated. The turndown rate is not included here, but it's below 10%, way below. So the 30-day mortality was lower for the ruptured EVARs, but we're comparing apples with pears because the more difficult patients are operated in open. But if you remember the 39% open mortality in the beginning, I'm very glad that even though we do more difficult cases openly today, the mortality still is in the same region. And this is the most important slide. This is 7:28 in the morning when I came to the hospital a couple of weeks ago, a team operating there. They had been working all night, but still a lot of happy faces. And I think this is the most important message. Keep your team happy. Thank you very much.
Thank you, Pirkka. Very exciting presentation. Any questions to Pirkka?
Thank you. Excellent presentation, Pirkka. Just one thing, how do you keep your team happy?
We have the Phoenician system that's working very badly in Finland, so it has to be something else. I think this is a great task in many places, but I think it's also a responsibility for everyone in the team to try to keep the happy atmosphere. There are there's actually studied thing as well. Autonomy is one of the key issues. Then what do you call it? Capability. So you have to be on the level of your capability. And then there's the team, the social team is the third studied method of having more happiness.
I think the social team issue is very important because when we started the hybrids and ruptured aneurysms in Helsinki, the nurses were very reluctant towards the hybrid procedures, and now there is a queue, and they really want to come to the team.
I also want to comment really good talk, and what I like it, the continuous and persistent simulation training that you're doing. And the result when we saw, it's really great. And it is what it's important to say in the moment where they don't have enough patients with a rupture. How can we, through the simulation, overcome the lack of patients? And this is what I think it's important. And what you said, looking how it was now when the rupture is coming to the theater, the nurses are just waiting, just have to roll the patient from the table to the operating theater. It is really great. And this is exactly what means. This is an elective case. Rupture is an elective case with hemodynamic instability and the patient who are working in a stress environment. In the stress environment is a way through this simulation, then you almost won. Then working with anesthesiologists, keep the hemodynamic. So this is the way to go and how to treat the rupture cases, have a good results.
Very good. Oh, sorry. Good.
I actually had an opportunity. So sorry, Greg, please.
That was a great talk on simulation. Obviously, high-performing teams, elite professional teams, astronauts, they train 10 times more than they actually ever perform. And my question is, how do you find the time to do the simulation in order to improve your results when you're, constantly, there's constant time pressures on doing the day-to-day operations?
What we actually do is on Monday mornings in the real operation environment. So we reserve, is it 1 hour or 1.5 hours for that simulation, and then that simulation team goes down to the lecture hall and discusses the case. So it takes, so the first case of that Monday morning in that theater starts a bit later, but not that much later.
So it's once a month, every month.
Seems worth it.
And then we have Friday afternoons for trauma simulations every 3 weeks. And then we kind of close the outpatient clinic or something for those people, but that's not so many vascular surgeons, and that doesn't close a theater. Yeah, I had the opportunity actually for a couple of weeks ago to look. This was also an interesting case. We did this was a patient who came in with a rupture aneurysm and was resuscitated with the Lucas. And then we did the balloon occlusion, but the pressure didn't go up, so we couldn't stop the Lucas. So we were thinking what to do next. So we didn't continue with the procedure because this was a dying patient, but we didn't take the C-arm there. The resuscitation team with the top anesthesiologist, they tried to do, and the Kalium was something like 13, and it went to the cardiac arrest and so forth. They put insulin, they tried to take it down. But it took some half an hour or 45 minutes of this work. We had the aorta occluded, and I knew that the patient is going to die, so we didn't continue. We didn't open the abdomen. Why would we? So I looked at the team very closely, and it's very important that the anesthesiologist is doing a good job, because if they start to panic, then the whole nurse team starts to panic, and then everything goes wrong.
Good. Thank you, Pirkka. It's my pleasure to introduce the next speaker, my co-chair, Zoran Rancic, doing EVAR in rupture aneurysm, how to achieve best results and working with the anesthetic team.
Yeah, thank you, Marit. Doing EVAR in rupture, how to achieve and working good results and working with an anesthetic team. So I thought at first that Tal made some joke and he wanted to answer me despite working with an anesthetic team, but I was sure it was fun. And it was for sure management of aortic rupture is the solution, how to doing EVA in the rupture AAA. Nothing to disclose. And the first EVA started in 1994, and I think the most important to work with anesthesiologists is to involve them, just to answer on the second part of the question, to involve them from the beginning of the working together. So in 1996, we in Zurich defined the team, vascular surgeon, institute, diagnostic radiologists, and cardiac anesthesia, that we are going to work together in case when the rupture AAA is coming, with that we are going to do by EVA. And we waited for 2 years, and despite we made the team, then came the first case in 1998, and then in 3 years, first 3 years, we did several cases, and that showed that this working together made some results. And then we in 2002 change again our protocol, how we are going to work together. And this is what we decided in 2002. You see the blue line, the blue patients are those treated with endovascular treatment, and 30-day mortality to 2018 is 70%. But what is, I want to change, why can we have a good results? Because we made the standard operating procedures, pre-hospital, in hospital, and after when the patient leave the hospital. And this is one of the 2 lines that we have to be sure. The patient with suspicions of acute aortic lesions, the first we have to lower blood pressure. It is now very clear, but it used not to be so clear in the 2000, and then make a CT scan. Depends on if it is a rupture or symptomatic, we define our pathways. When the patient is coming to the shock room, then it's necessary to have CT angio. Either they are sending to us, or we have this to see if it is possible to do EVA. That means this proof of feasibility. Then, after making CT, the anesthesiologist start to make work on the patient, anesthetic workup, and we are discussing the procedure with interventional radiologists. Are we going to make open surgery or EVA? Are we going to hybrid or what we are going to do? After the procedure, we are always doing CT angio. Patient is thereafter going to the CT. And this is the answer to the question, what is necessary to achieve good results? This is 5 key elements: hemodynamic imaging, procedure, abdominal compartment syndrome, and team. Hemodynamic, as we said, we are lowering the blood pressure and using the principles of permissive hypovolemia and controlled hypotension according to the guidelines, ESVS, and also actively lower the blood pressure with medication the patients with high blood pressure. In the hemodynamic crash, use endoclamping, and to be aware that the patient is, we are working not with 1 balloon, then we are working with 2 balloons. How can we put a balloon? Trying 2-3 times percutaneous. If it's working fine, it does not work, we are going for open surgery. Not forget transaxillary, transbrachial is also, and as I mentioned, always try to do rupture AAA with the local anesthesia that we did in almost 2/3 of the patients, only local without analgesic sedation. Imaging, absolutely necessary, also according to our guidelines, to make CT angio and to confirm diagnosis, to plan, and to size the EVA. Confirmed diagnosis, we can see here it's a ruptured dissection. We see that the patient has horseshoe kidney. Then we have to plan, is it possible for EVA to define access site, landing zone, C-arm angulation, how we are going to contralateral limb cannulate, and size. That does not exist in the open surgery, but in endovascular surgery, we analyze that in the patient with hypotensive hypotension, iliac externa, is the blood pressure is less than 100 millimeters mercury, 30% smaller than in the patient after the procedure. Post-operatively, we are making always a CT. Procedure, to define if it's possible to make the procedure, simple EVA for simple rupture. If we define which prosthesis are we going to use in our clinic, but if the patient has a more complex neck, there is simple EVA is not going to work. And then there is some other possibilities, either to use chimney, surgeon modify, or team bridge. What is important, what I want to talk here, it's about that we want in the moment of the rupture to make a damage control. So this is the patient with a rupture. After the procedure, we see the endolytic 1A, but we decided to delay the procedure, wanted to go patient from this situation of the rupture, and then 5 days thereafter, we made the branching of the renovisceral arteries, and 45 days thereafter, put a chimney to the left renal arteries and the cuff extension. So again, the patient intraoperatively was aware of endoleak type 1A. We did not put the endo anchors, but we put several days, 3 days thereafter. Or the third case also ruptured AAA endoleak type when we did it that after endo anchors and the chips to parallel grafts and the cuff. So that means we let the patient to recover a little bit. Depends on how you are trained in different technique. This is the results of Zurich when we use parallel grafts onyx to treat the patients with complex aneurysms, and we see that the increase is mortality, but still unacceptable. Distal access is the problem, and then whenever possible, leave the balloon so to have chance to close the rupture site here. If we have to close the hole, try to put a pericardial patch. The main killer is abdominal compartment syndrome. It's polycompartment syndrome. Have your own protocol, when to measure, how to detect, and how to treat this. Very easy, very cheap urinary bladder pressure to measure that. If you have to open, use the guidelines, and then define if the bowel at risk. We are using Bogota bag. If not, we are using VAC and closing the abdomen. What is very good with the Bogota bag, you see the movement on the arm, and you can also see if there is some necrosis or some problems we can follow. Opening means how to close this, and we have algorithm for that. I will skip this because we heard from Helsinki the simulation is improving the results. Important all the case to discuss that, and if possible to make simulation of PSR. And to conclude, ladies and gentlemen, if you want to achieve best results in emergent TEVR, you have to use these 5 key points. Thank you very much for your attention.
Can I ask you a quick question about one of the images? You had a rupture with was that like a pericardial patch? So you patched the rupture? Yes. You're not worried about the rupture risk of the wall?
This is, we tried before to, that means we have, this is why we're making always CT angio after the procedure. And after the procedure, despite of the angio, it's possible, we see that everything is sealed, but then we see on the CT angio, it's not sealed. And mostly it's the bleeding from internal iliac artery going to perfusing the artery, going outside. That means we are making a laparotomy to decompress abdomen, but also to suture the hole. When we're trying to suture the hole directly, because this is the weakest point of the rupture, it's not going to work. In this situation, we made in 12 patients, and it was successful. In 10 patients, we are using the xenopericardial patch, and we close 2 centimeters far away from the hole and making like a patch closing the hole. That means we did not suture, we don't close closer to the rupture site. We are making 2 centimeters big patch above on the relatively healthy ruptured vessel in common artery or aorta.
If I understood that correctly, you're doing that after you've already achieved endovascular repair, but you have a decompressive laparotomy and you're worried about bleeding, ongoing bleeding?
This is when we say we make the decompressive laparotomy. Yes, we are doing that, but we don't remove the hematoma. That means we are just opening that, and and we just decompress abdomen. And we are trying not to move the bowel. We're just not trying to go into hematoma because it's going to result in bleeding. The only case when we are going to approach to the aorta, the bleeding site, is when we see on the postoperative see continuous or active bleeding continuing after sealing. In that case, we are going to remove hematoma. That means hematoma we don't remove. And with time, then we are making the revision laparotomies, and the hematoma is going to be resorbed.
Thank you. So if I understand correctly, if you see active bleeding in completion angio, you open the abdomen if there is no signs of abnormal compartment syndrome, but just to stop bleeding.
It's not easy to answer, but the question is good. That means on the completion angiography, probably if we see the continuous bleeding, then we're going to try to solve this, maybe to inflate the balloon in the proximal if we have endoleak type 1A, or we are just going to put chimney on the extent if we think that the problem is in the proximal ceiling zone, that this is what is perfusing the heart. But if we see at the end on the post-operative angio, there is endoleak type 1A, but we say that is a low flow endoleak. That means it's not in the first second this full aneurysm sac with aneurysm, then we are not going to open the abdomen if the patient does not have abdominal compartment syndrome. So that means that in this situation, we will wait and see. That is what would be our damage control. So we are aware there is a small endoleak type 1A, patient is stable, patient does not have urinary bladder pressure requiring the laparotomy. So we will wait till tomorrow, till 2-3 days after that the patient is going away from this emergent situation where it's completely everything disturbed. Coagulation, hemodynamic, everything is at the limit. So that, but we will maybe make in 2 days, in 3 days once again, and sometimes this low flow endoleak will disappear. So that means it's not, or if we see huge endoleak type 1B from the inferior mesenteric artery, we will not react in this situation because this is damage control according to us.
Yeah, thank you. I saw one difference from our process. You said that if you go to open surgery, you go to the different operating room than if you go for EVAR, you go to hybrid room. Why not patients treated by open surgery to hybrid room and maybe put occlusion balloon and then clamp?
In general, we are treating all the patients in a hybrid room, but we have only one hybrid room for clinics. So cardiac surgery, vascular surgery, cardiologists, and interventional radiologists, so there's only one hybrid room. So that means if we see that we cannot treat that in a hybrid room and we are opted for the option for the open surgery, we are going in the operating theater, there is within the shock room. So that means we are very close, we cannot delay. But we are going in 2023 also have 3 additional hybrid rooms, so probably they will not be occupied everything. And this is why it's important, this communication within the team when the rupture is coming to see exactly where you're going to treat your patient, in which room. In hybrid, in normal surgical room, or maybe in the C-arm or some angio suite, there is many rooms. So to define where you're going to treat this patient.
Thank you. There is a final question from Pekka.
Yeah, thank you. I see that you're great friends of contrast media. So you still do immediate CT imaging after the procedure. Is it so? And is it really worthwhile doing that?
You are completely right, and I understand this. But we make the revision in 12 patients, so 400, where the angiography was completely post-op. At the end of the procedure, angiography was fine. And these patients required laparotomy and suturing the hole. So that means it was continuous bleeding. And we think in this situation, if we don't make this CT angio, we will not completely treat this patient. So I agree your concern about the kidney, everything with contrast, but we still did not change this way how to treat this.
Do you have the ability in your hybrid room to do cone beam CTA at the end of the case? We found that in cases where there's a tenuous repair, like you don't have enough seal or you're worried about a 1A, that the cone beam CTA on the table at the time of the case can really help you determine, do you need to do more or not?
We tried, but we are not happy with the results. So I think something is wrong doing this. I don't know what is exactly wrong. We tried to optimize that, but we tried 3 times and then we are not happy with this concept.
Good. Now I invite, thank you, Søren, invite David Lindström to the podium to talk about in situ laser fenestrations of aortic endograft case examples.
So thanks again for inviting me. So we already heard an excellent talk by Greg on in situ. So why do we need these? Well, many of the complex aortic patients are turned down for open repair. Waiting time for custom grafts can be long, and doing your own physician-made may be complicated. So we looked at our own waiting time for custom-made grafts. I mean, actually see that during the first month, no ruptures. By 180 days, there were about 6% ruptures. And our median waiting time was about 100 days. So we had a few interval events. So if we're going to start up laser, we wanted to do, how should we do it? So we tried to look at the evidence in the literature. And this is the recommendation we came out with, that the cold laser and dilatation with the 6 to 8 millimeter non-compliant balloon to avoid the tears in the fabric. Now, how do you do it? As you heard from the visual vessels, you would normally go from inside out, you deploy the graft, you make the hole, put the wire in, you balloon and put the stent into the target artery. In the arch, it's the other way around. You put the graft, you come from the target vessel, and you make the hole and deploy the graft into the fenestration. So still we were quite consider how should we do this and what kind of materials should we use and what does fit and does not fit well together. So as you see here, the laser, this is the Spectronexus laser going very easily through a TX2. But for the C-tag, it takes not forever, but a very long time. So this is probably not the best graft to use. We also try to examine the holes in a bit more detail to trying to figure out what's the best methods. So in the OR, we're in the hybrid room. We just bring the laser machine side by side with the table. And then we have treated patients like this with a hemothorax, a rupture of a chronic dissection, no sealing zone, distal to the subclavian. So we can just put the TEVAR, do fenestration from the subclavian and seal off the aneurysm. So this is another case just to show the technique. Again, ruptured dissection, chronic dissection. You can see now the laser coming from the arm, and there the laser catheter goes through the fabric and then in with the balloon, slide the sheath into the graft, deploy the graft, do an angio to make sure everything is patent, including the vertebral. So this technique can also be feasible in trauma cases. This man had a severe injury list from MVA, came in very unstable. His abdomen was open, there was a mesenteric bleed, there was suture in the hybrid suite. But if you look at the CT already now, I don't know if you see it, but the left vertebral is dominant. The right is even impossible to see. And there is a large hemothorax, and you see the aortic rupture there, the level of the subclavian. So multiple injuries. Sorry about the slow. So a lot of blood in the abdomen as well. If we ever come to the end. So, of course, the alternative would be here to do a carotid subclavian bypass. But again, it's a lot quicker to deploy the graft. You have already access from the arm. And once the graft is deployed, it takes not very minutes to do the hole and put the fenestration to seal off the injury in a safe way. And this is the 1 month follow-up. The patient was discharged after two months. He had a lot of orthopedic injuries as well. So this technique can obviously also be used this is a visual case. Now we're looking at the left renal. So in this semi-elective setting, this is mycotic, symptomatic, rapidly expanding aneurysm. We pre-stent target arteries to get a good view of where we're going. So you have the stent at your target, you get your access wire. You deploy the stents, and then you put the second stent to bridge the aortic graft with the bridging stents. And this is a completion angiogram of this is our first 4-fenestrated graft. We did not use a sequential deploying, we just covered everything. And the ischemia time was 7 minutes for first renal. No, 7, we started with SMA, 7 minutes for both the other renals, about 45 for the celiac trunk. So our initial, this is our complete learning curve, our first 8 patients, some ruptures, dissections, and we haven't lost any target vessels so far. We had to reline 1 celiac trunk from an endoleak. Now, we haven't done complete arch cases like this. We have only done the subclavian. We had this patient last year presenting with a massive rupture in an arch aneurysm, hematoma going up to the left carotid. Very difficult to swallow when he presented in the emergency room. So for him, we were lucky to have a device on the shelf that we could use instead. Of course, if you're going to do arch cases with laser, you need some sort of perfusion to the carotids, like a femoral carotid bypass or something. So this gentleman was turned down for open repair. But with the 3-branch device, we're able to stent all the target arteries. That was it. Thanks.
Thank you very much, and congratulations for the great cases. And it seems that this laser issue is a way to go, maybe in the future. Any questions and comments?
Yeah, I have a couple technical questions. So you're using the 2.3 millimeter spectromagnetics laser or the 2.0?
2.3 with a 018 wire.
Yeah. Yeah, that's what we use as well. And the only issue with the 2.3 is sometimes it's pretty stiff to make the turn. What are you using, an articulating sheath? And what kind?
We normally use the 7 French tour guide. I started out using the 8.5, but I found it was not really helpful, especially for the subclavian. I didn't really need it.
Yeah, no, I agree. I think for the left subclavian it's hurtful actually, but for the renals, for example, you have to make a 90-degree turn. Yeah, we've used tour guide too, but the issue with tour guide is sometimes if the aorta is too narrow, you can't get that 90-degree turn with the tour guide. So what we've done sometimes is use the Nagari sheath, which can actually it's a different instead of pull wire mechanism for the articulation, it has the braided sheath. So it actually is much stiffer. It actually makes that turn a little bit easier.
Yeah, but I agree with the renals. They can be tricky, but I think some people use the 014 laser wire. We have it, but I haven't tried it yet. But.
Yeah, that's the other thing is sometimes we haven't used the 14 because I've never actually used that one, but the 0.20, which is the 018 wire system, is much easier to turn because it's not as stiff.
All right, good. Thank you very much. And I think we proceed.
Can I ask one question, please?
Absolutely.
As a trauma surgeon, we generally are the ones who place a rAAA for ruptured abdominal aortic aneurysm. I'm curious, in what setting would you recommend that we use a transaxillary rather than transfemoral access?
The problem with ruptured aneurysms and putting rAAA is that it can coil in the aneurysm. So if you try that and, unless you're under visualization or you actually have a wire all the way through, which I think rAAA doesn't have the ability to have, then you could potentially think you're blowing up the balloon and actually just be within the sac. So in a case like that, I actually would say that rAAA would probably not be a good option for somebody with a ruptured aneurysm.
Well, Dr. Fox and I have done 5 successful ruptured AAAs with the Coda when we had a wire. The new, the prior time, actually, you could put a wire through the new one. But the question is, would there be a circumstance where we should now place it transaxillary because we clearly can do it technically? Or do you think we ought to continue just to put a wire over the prior time balloon?
I'm actually a little worried about that as well. I share Dr. Dua's concerns. I wonder, do other people have experience or technical tips about how to do that adequately without fluoroscopy? Because coming from the arm, I would imagine, would be difficult to do and make sure you're not in the arch. And then coming from the groin, especially if you have an angulated neck, how do you know that you're in the super?
I don't have an answer to you, but Hans Verhagen sent me when we were planning this symposium. Hans Verhagen sent me 2 pictures of complications when people tried to do that, and the other one was in the contralateral groin, and the other one was coiled in the aneurysm. So I wouldn't do that.
Yeah, I mean, I've seen them in the renal artery. I've seen them in the contralateral femoral. I don't know. I don't have an answer for you, Gene. I'm curious, Chuck. How do you guys do those?
To be safe, and it just speaks to the fact that we really all to have hybrid room technology, because these patients really benefit from EVAR. In our case, we did rAAA with open repair, and I think digital radiographs in the emergency department ought to give some clue as to whether that thing is in a right position or not. Should not be in an iliac if you're taking a radiograph in the emergency department. And if it's coiled or it has an odd shape, then I would immediately take it down. I think in this case, these were our resources and what we did.
It seems to me like there's the design of the rAAA catheter with the tip is great for a trauma patient, a young, healthy aorta, not a lot of atherosclerosis, not a bunch of angulation, no aneurysm. It works perfectly for that purpose. I don't know that we have a device that works perfectly for deploying rAAA in the ruptured aneurysm situation without fluoroscopy, but that's like an opportunity, I think, because clearly there's a need for that.
Great. This is really fascinating. I suggest we continue this in coffee break and go to the last presentation of this session. Alexis Smith. No, class. Yes, absolutely. Second last. Class. I'm sorry. Go for it. Surgeon-modified endografts and other special techniques for acute patients. Technique and examples.
Thank you. Dear colleagues, the indications for surgeon-modified grafts are about the same as you've heard about in-situ fenestrations. And I'm not much to conclude to that other than maybe in some cases economic reasons, maybe not in Western Europe as much as in other countries, where you can get the cost down from maybe 5-fold or so by doing your own graft. The essential thing about surgeon-modified grafts is planning. You need, of course, a good CT, 3D planning software. You have to use the right kind of graft. In my experience, the Terumo Relay, the Cook Zenit, the Cook Fenestrated, and the Cook dissection grafts are well suited for certain modified grafts. I know people have used anacondas as well, and Medtronic grafts, but I think the ones I've mentioned here have a lot of advantages. Well, you have to decide, of course, all the details of how you do your graft. And we have started making a sterile template to make the fenestrations and get them in the right places. And we do that from overhead sheets, the see-through overhead sheets that we do a drawing on, and
weld them together to a tube, and then sterilize them. So here you can see the planning strategy here. First, a sketch of what you want to do, then a planning in millimeters, distances, and so on. You do your template and you sterilize it, and then you can use it on your graft to make all your fenestrations in the right places. You can also mark the places for the restricting ties and so on. Depending on the complexity of the case, you can do this in 1 to 8 hours. Of course, if you just have 1 or 2 fenestrations for renal arteries, you can actually do it maybe in 1 hour without a template. But if you have a 4 fen or more, and you have to plan it carefully, you may need 1 working day. You need a lot of material and equipment. You need a very good sterile environment, a good working environment with good magnification and good lighting. Marking material, markings for the gooseneck snare or tip of a guide wire, cautery pen, and of course surgical instruments. You can have, you need things for reloading like rubber, cotton bands or sternum wire for compressing the graft for reinserting it in the delivery system. We've made a fenestration template. It's like a forceps with rings in 10, 8, and 6 millimeter sizes to make exact fenestrations in the right places. We also made a fenestration template with like a metal tube with grooves and 4 quadrants to get exact measurements for the reinforcement of the fenestrations and suturing them into place, and reloading funnels as well. Of course, you need a lot of other equipment, as you see here, which you need in cases like this with the multi-fenestrated and complex aortic cases, and you need good imaging equipment as well. You also need restricting ties to be able to maneuver the graft after delivery, and we use 2 kinds, the Cook kind with just loops on the back side of the graft, and the more complex kinds with bands around the whole graft to concentric restrict it. We make the fenestration. Can you start the left video there? You can see how we make the fenestration. To just do a fenestration on freehand with a cautery pen, the fabric cannot actually catch on fire. So this template is very good to cool it down, and if you twist the tip of the cautery pen, you get more exact burning and a lower temperature of the tip as well. We use gooseneck snare to mark the fenestration, and you suture it very finely with the 7/0 PTFE or Prolene suture. And we can also make branches. We use mostly wire-bound for inner branches, which we've used for visual vessels and even for intercostal branches as well as for branch vessels. So, and here, can you start this one? You can see here we put in rotation markers to get exact rotation, usually a long marker on the front side and a short on the back side. You can get very exact rotation markers that way. So you can see it's very easy to actually get a very exact rotation and good placement of the graft after your angios. Some examples. Here, the most common one we do is a single fenestration for the subclavian artery, and here for arch aneurysm. In this case, a complex arch case with double ascending branch cases, inner branches that we've made, which you can see here. Very, very nice result. In this case of a ruptured islet target chimney graft that was pushed through the aortic wall and made a big pseudoaneurysm at the edge of the graft in a very tight spot, actually, with renal arteries coming off and the SMA very close too. Very hard to do something good about this. And if we could make a graft with 3 fenestrations and in a branch to revascularize the chimney graft as well, as you can see here on the right side. There you see the inner branch that goes to the old chimney graft. And here an example of a Luxuria aneurysm with a dissection, symptomatic with lots of pain and hypertension, that was fixed with a double fenestrated graft in the arch. And to conclude, surgically modified graft is a controversial technique still, and it's not widely used. Good results have been reported in our hands. We have very good results with more than 95% good cases in over 60 cases since 2010. Concerns are, of course, long-term results and risk of graft infection. And I think you have to have some a pretty good caseload to use this. You have to keep the technique up. I think 5 to 10 cases a year in excess of other complex aortic cases to keep your skills up. Thank you very much.
Thank you. Exciting. I think this is maybe more for contained ruptures and not for patients who have occlusion balloon in place. How long does it take to build a 4-fen graft?
A 4-fenestrated one really depends a little bit on how you do if you do a sterile template, you can make that in maybe 10, 15 minutes. And then it's the sterilization time, which will be probably 1 to 2 hours. So you can, and then making the graft will take you 2 to 3 hours.
Yeah.
If you do it straight off, just using the measurements, you can do that as well. You could do that in maybe 2 to 3 hours.
Thank you.
And of course, it's not for shocked patients, but for contained ruptures, symptomatic ruptures that are hemodynamically stable, symptomatic cases, so on.
Exactly. Yeah. One burning question allowed it, if anybody wants to have.
Great. May I ask something?
Yes, Martin, go ahead.
Klaus, when it comes to the fenestrations in the arch, do you really believe that you need to provide a seal between the fenestration and the covered stent into the precerebral vessel? Because I think that the stent graft actually is plastered against the convexity of the arch. And I'm not updated about how the Japanese are doing, but there is Dr. Yokoi who has been working with the Japanese fenestrated stent grafts that have very large fenestrations that don't even attempt to create a seal. Do you know anything about that?
I think we've seen leakage from the distal part of the fenestration stent from kind of type 1B, so to speak, and out into the arch. So I think I wouldn't just do a fenestration with no seal. It's important to have the seal, I think, and it's important to have the seal towards the subclavian, the distal to the subclavian, or distal in the carotid or so on. I think that's an important issue.
Good. Please join us to the panel.
Yeah, thank you very much.
Thank you.
So we continue with the not typical
case. So what do we know about pediatric bleeding and the use on EVTM? Trauma and not trauma. Alexis Smith,
Thank you so
welcome.
much. Thank you, Tal, for having me. I think I'm maybe the first pediatric surgeon. And it's a pleasure to share the stage with a lot of vascular surgeons. About 60% of kids in the US, so 70 million, are treated at standalone pediatric centers where we don't have vascular surgeons. So we are expected to do a lot of the open vascular work, but I think we fall behind in endovascular. So I've been learning so much. No disclosures. So children and adolescents are a lot like adults in terms of trauma, but unlike the vascular patients, we have very healthy ones that have a lot of excellent cardiovascular reserve. Right? They have pristine vessels, but smaller, and they allow for effective vasospasm and high non-operative management rates. Mortality in children and trauma is really attributed to severe brain injuries mostly. But death from hemorrhage is an underrecognized entity in the trauma community. It can be preventable, and pediatric trauma surgeons themselves do not widely or do not at all utilize rAAA. So when compared to adult trauma, kids are more likely to die in the ER than to survive to the OR or to the ICU. And in large part, again, this is from the brain injuries. But hemorrhage does contribute about 15% of the overall 2% mortality rate. So rooms for improvement. But non-operative management in pediatric trauma is very successful, even with multiple high-grade injuries with active blush on CT scan. This was a recent kid of mine who walked out of the hospital with no embolization and no XLAB. In the US, we have a consortium of all of our pediatric trauma centers and have a nationwide non-operative management algorithm. And we recently reviewed that. 1,000 patients had a 93% successful non-operative management rate, and 0% of isolated spleen injuries needed to go to the OR. But pediatric angioembolization contributes a lot to that, although it's not well defined in terms of protocols across the country, and it varies from pediatric centers to adult centers. So if a child or an adolescent walks into an adult hospital or gets delivered to an adult hospital, they're 5 times more likely to undergo angioembolization as compared to if they presented to a pediatric trauma center, and then 9 times more likely if that's just isolated spleen trauma alone, which is fascinating, with no improvement in outcomes. And so why? I think pediatric trauma centers, we often treat based on hemodynamic status rather than radiographic signs such as the blush. And so what happens when we have a really severe bleeding child, I think, is where we in the pediatric trauma community fall short. This was a recent patient at my hospital from a partner, who won't be named, but 11-year-old ped struck, came in with high-grade liver and renal injuries, got massive transfusion started, an epidrip. They went to IR first. Embolization failed, and then the patient subsequently expired in the OR. No rAAA was deployed, unfortunately. So aortic occlusion, it's widely debated due to the dismal outcomes in peds, and that's from the severe brain injuries. And I know we mentioned earlier about organ salvage, and I think that is also widely debated in the peds world, but interesting. But there's no reported survivors in children less than 9 who underwent an ED thoracotomy after penetrating trauma. And until recently, here in Sweden, none for pediatric blunt trauma under the age of 14. So very dismal outcomes. But the Committee on Trauma for the American College of Surgeons still recommends broad application of these adult ED thoracotomy guidelines to children. We just don't have anything else yet. And so the aortic occlusion balloon was first described in the peds world in 2010, so very recently. The vascular surgeons deployed it at Emory University in Atlanta for a 10-year-old with an aortoesophageal fistula and bridged successfully to endovascular repair. And then the Japanese were the first to publish on their rAAA experience, and their youngest patient was 11 years old. And they deploy early and often, and so have better results than the US data, which we then subsequently published last year about the experience from shock trauma as well as Texas Trauma Institute, so 7 adolescents. Our youngest patient was 14, and very similar outcomes to the aorta registry. And then this landmark paper, which kudos to Tal and your group, was the very first survivor to discharge of a patient under the age of 14 for blunt trauma who presented an arrest and did so with the use of a rBOA. So we know rBOA is feasible in adolescent trauma patients, but what about younger children? There hasn't been any description below the age of 11 unless I hear differently, which would be great to hear about. So what's on the horizon? There is some translational research. And interestingly, the 4 French sheath is coming out on the market. And so my thoughts with COBRA is that more pediatric surgeons would be interested in deploying this in smaller vessels and feeling more confident in its usage. But I think more education and involvement in symposiums like this are important. So thank you so much. I love Sweden. It's been a great time here.
Thank you very much. I don't have experience of these cases, but sure they are very dramatic, and lack of equipment is one problem. It's nice to hear that this 4 French rPAA device is coming. Do you know the diameter of the balloon in that device? Millimeters, okay, yeah. I saw that in one case there had been a 14 millimeter PTA balloon, but it's maybe dangerous to use PTA balloon because it's compliant, yeah.
Right, I think that's the aortic diameter in babies in CFA also for access is challenging to determine. There was this paper out of Sweden that talked about trying to predict it based on size, and it's just so challenging. I think the very young, I don't know how young it'll end up being that we can utilize these 4 French balloons, but you also sometimes don't need to. Those are the kids that vasospasm the best.
And with a healthy vessel, so they're very fragile.
Right.
Any questions from the audience or the co-panelists?
I would like to. It's really something that we don't know. I will not say anything, but very blind area for us. Where do you think we should recruit the potential interventional surgeons who are going to deal with this patient from the pediatric surgery with special training in the use of these skills, or the vascular surgeon who should be dedicated to treat the young?
It's a great
I don't know
debate.
what is
Yeah,
the position in USA. I don't know that we know some in Europe.
Right now, the vascular surgeons come over and help with complex vascular. But there's been a couple published articles recently pushing for training of pediatric surgeons to be vascular surgeons in addition, which I've been talking to Emery a little bit about, and maybe in the future, but it's a lot more training. And it's kind of challenging to think I'm going to sit through, going to do 2 more years of specialty training and not do arteriosclerosis. Like I just need training on certain endovascular techniques for healthy babies. So the interventional radiologists do a lot of the work as well right now. So there is PEDS IR training.
Thank you. It's almost time for lunch, but before that, because we have very interesting panelist debate question here, which is all endo or good old open surgery should not be forgotten. I would like quickly that all the panelists say 1 sentence on this issue and pro which one of the questions. All it's ruptured aneurysm, all endo or good old open surgery should not be forgotten.
Oh, I come down hard on open surgery should not be forgotten. There are definitely patients that require, but I think that we also have to accept as the world turns that, we are getting amazing new endovascular options for these patients, like, the in situ fenestration option, the new branched grafts that are coming. And I've been very lucky in both training and working to kind of work in places that are absolute opposite. One side was extreme endo, believing that anything that was open was a failure. And now I work in a very traditional place that views endo, with skepticism. And so watching that huge span has really showed me that there are patients that require the open procedures. But I think that is a moving target. So what I'll say today, this person cannot be done endovascularly, tomorrow can be done endovascularly because we will have that sheath size or we will have that new technique. And so just being nimble and being accepting is what's allowed vascular surgeons to even exist, right? Otherwise our profession might have gone away 10 years ago. And so I think embracing that and recognizing it's not something that's in the books, but something moving and with the journals is the most important.
Thank you. And Greg?
Agree. Open, you got to know how to do open. But I think it was Martin earlier who said that open surgery is becoming more and more complex as we can do more and more things endo, and that's a challenge for training.
Good. And Pirkka?
Yeah, we're slow learners in Finland, so we need to do open surgery still, but it's a development.
I think it's important to have a lot of a big toolbox that earlier it was so that we only could do open surgery, and unfortunately in some places nowadays they only can do endovascular, but I think we should do what's the best for the patient.
Well, in Norway we tend to go more and more for the endovascular solutions, but still there's definitely a need for open repair, especially if you have a bad access or if you're close to the renals. Yeah.
Thank you. Joran?
I work in the hospital where is the endovascular first always staying, but I think our experience from an opener must contribute to the complete treatment of the patient. And I will say good, all, it's the question if the all open is good or the all open, all this is also good or bad, worse. So that means patient tailor endovascular first.
Thank you. And Claes?
Well, we wouldn't continue treating peptic ulcers with resection of the ventricle nowadays. I wouldn't say that open surgery is obsolete, but it just goes, it decreases, and we have to deal with it. And it's a dilemma. And I think in the far reach, we will probably use other methods anyway. But during this stage, we need both, and there is a dilemma with training.
Thank you. And I say that we still need open surgery, but it is moving target, as we heard, and maybe in a couple of years I would vote for other motion. But I would like to now vote with audience. So who votes all endo, 100% endo? There is Tal, who would like to join him, and who says good old open surgery should not be forgotten. Thank you very much. We had a good session.
Thanks.
Is it possible to say?
We forgot her. She didn't raise it. No, it's fine. But 100%, why did you say 100%? So I could not raise it. And then you said almost all that would be good, but then you said 100. Allah. It was good.
We check if online is we are all present. No, we can see. No. Yeah. So I invite all the panelists to take a seat here. So in a few seconds we can start with this session.
I think you can just take a seat anyway. My name is Ivonin. Dr. Ivanov from Latvia. No?
Okay. Hello, the panelists are here, so we can start. This session is about embolization and other solutions for the bleeding patient. So I introduce myself that I'm the first speaker, and the landmark papers on bleeding embolization review.
I haven't had any conferences for like 2 years.
No, it's not too expensive to heat the building.
Yeah, so it takes maybe a couple of weeks to heat it up.
Yeah.
First talk for presentation, thanks.
So normally if there are like 1,000 people, then it will be
Okay.
because of all the people.
Thanks again. Landmark papers on bleeding embolization. These are all the documents that are available in literature. They were published by all the most important society of interventional radiology, of anesthesiology and surgeon. And they help us to manage hemorrhagic traumatic patients. First step is resuscitation, and then after that, the primary and the secondary review can be carried out. Patients who respond at least partially to resuscitation must be underwent to imaging. This is a mandatory step to understand which should be the best treatment for the patients. Patients hemodynamic unstable and who does not respond to resuscitation must be underwent to immediate intervention. The total time to stopping hemorrhage critically affects outcome. Remember this concept. And in most papers that are now available, the time between the arrival of the patients and the decision making is not more than 60 minutes. So the role of angioembolization in the works, in the papers published by the societies mentioned is with the angioembolization to arrest hemorrhage and to repair damaged vessels. The introduction in all over the world of hybrid room is changing this scenario because in the same theater, all the specialists, orthopedics, anesthesiologists, surgeons, interventional radiologists, everyone can work together, can take a decision, and can change the decision on the basis of the condition of the patients, on the basis of what they meet during their work. So there is a multidisciplinary action. Now we analyze each organ. What about the spleen injury? The role of angioembolization is indicated in patients stable or make stable after resuscitation. The clinical status decrease from the grade 1 to the grade 5. No guidelines and no standard of practice indicate which is the best way to embolize, proximal or distal. It seems that the proximal embolization is associated with less ischemic injury for spleen and, as a consequence, less infection risks. What about hepatic injury? For grade 4 and 5, angioembolization is indicated. They are the most of the cases that arrive in our first aid. In the literature, are about 70% of traumatic patients with liver lesion that arrive in the first aid. And this concept of a high grade of evidence in the literature available. Even in this district, we have no indication on how to embolize, selectively or proximal. It depends from the center, from the operator, and from the extension of the traumatic injury, of course. Interventional radiology is very effective in traumatic liver lesions, and in some cases it may be a role even after a surgical packing. What about kidney injury? In grade 3 and 4 is indicated the role of arteriography and embolization. In this case, all guidelines, including the guidelines of Urological Society and Pediatric Society, indicate and suggest to be more selective as possible to arrest the hemorrhage, of course, and to preserve the renal function, even if this is not the first aim in traumatic patients. What about pelvic injury? Angioembolization is very effective, even in case of severe grade of injuries, grade 4, after a stabilization with RIBOA or with pelvic packing, and after a fixation repair of the fracture. Even in this case, we have no indications about how to embolize, and generally in literature, selective embolization is indicated in lesions that have a small extensions, and proximal embolization is indicated when there are more vessels involved. The role of interventional radiologists and so embolization in extremities, so in arms and legs, is limited. There is a role in the deployment of stent for the treatment of pseudoaneurysm or arteriovenous fistula or bleeding from focal arterial range. Another application may be the hybrid solution with the rendezvous techniques with the help of surgeons, of course. For angioembolization, the role is very limited because it depends on the expandability of the embolized artery, and surgery, of course, is to be preferred. So in conclusion, most societies agree on indication described. Angioembolization is indicated in stable or made stable patients, and maybe hybrid room will change this approach. Nowadays, no standard of practice or guidelines indicate which is the best embolic agent to use and which is the best technique to adapt. Only in literature, we have only some evidence, and not for all fields. Thank you.
Okay. Thank you, Doctor. Any questions or comments? Let us get a microphone too, please. Thank you.
Regarding pelvic injuries, I think level D recommendation is quite low, and there is an argument if it's a really first step to embolize and not to do peritoneal packing, which is more immediate. If you are talking about bleeding patient in the trauma bay, immediately you can open and do it, and it takes much more time to reach the angio suite to embolize. And this is a remark. And the question, again, about pelvic injuries is sometimes you see, it's very common to see even major bleeding from the venous side. Do you have any recommendations regarding embolizing the artery in order to stop venous or to slow venous hemorrhage?
Yeah, always for pelvic bleeding, I suppose. Yes, for pelvic bleeding, there is no guidelines about that, but there is an open debate about the role of embolization of arteries when you don't see an arterial blush. Probably when you don't see arterial blush, the bleeding is intermittent, or the bleeding is caused from a venous lesions. In this case, I think that most of literature and the experience, my experience and the experience of most of us that are here in this symposium, is to perform an arteriography and if it's possible, to embolize the district in which you see the hematoma. For example, even if you don't see arterial bleeding, there are a lot of publication about the site of injury on the basis of the fracture of the pelvic ring. So it is indicated to carry out an arteriography, and it is useful to embolize even with reabsorbable embolic agent, for example, just to help the coagulation. So you reduce the flow of the arterial flow, and in this way you can help the coagulation in this site.
Any other questions? No. All right, thank you, doctor. Next, we have Dr. Delle. He will be speaking on choosing embolization agents.
Thank you. Hello again. Everybody who has been taking care of trauma patients know the delicate balance between creating bleeding control with on one side ischemia threatening and on the other side continuous hemorrhage. And this brings us a complex equation with several factors that we have to take into account. And when we look into the literature, there are factors that we all know of that make the decision which embolization agent that we might use. And when reviewing the literature, it's striking that it's missing high-level evidence and RCTs regarding which embolic agent to use. And I'll try to highlight what I have found when I went through the databases. So regarding the spleen, we have some basic principles. We can do proximal embolization and lower the perfusion pressure distally, or we can go distal and do a pinpoint embolization if we see a bleeding or contrast splash on CT. This is an ambitious systematic review from a Chinese group led by Rong, who analyzed 23 studies regarding the technique for splenic artery embolization, and it included almost 900 patients. They found out that coils were superior to gel foam when it came to the clinical success rate, and also coils was about 3 times as low risk for life-threatening adverse events. And proximal embolization was far more safe than if you did distal embolization with the risk of infarction. And this is interesting enough, an RCT, one of the few RCTs from a level 1 trauma center in Alabama, led by Gunn, who found that, who compared 2 groups, one treated with coils, the other with plugs, and found that the success rate was higher with coils compared to plugs. The complication rate was also somewhat higher with plugs. So the message is to use coils and be proximal when you treat these patients. The liver is an organ known to have dual blood supply, but still there is a risk for ischemic complication. This is a systematic review who selected 11 studies out of 604 where gel foam and coils were used, and it showed a very high clinical success rate of 93%, but that it was 15% of cases with hepatic necrosis and abscess formation in almost 8%. So there is a significant risk for damaging the tissue. This is a study from UK, also showing 80 to almost 100% success rate with an ischemic complication rate of about 10%. And of these 24 studies, 2 studies had compared coils compared to gel foam when it came to embolizing the liver arteries. And gel foam was far more associated with severe injuries, ischemic injuries and abscess formation in the liver. And that tells us that even though we have dual blood supply in the liver, we should be as selective as possible, and we should also take into account that the higher grade of blunt damage to the liver, the higher risk for ischemic injury, even though we use coils or gel foam. So finally, regarding pelvic trauma, I think most authors agree that a temporary embolic agent should be used, that is gel foam. And in this study by Bonde, it's a cooperation between Boston and Copenhagen. It was a very high success rate, over 90% clinically, and actually no severe complications were reported, which is a little bit strange. This is in contrast to this orthopedic study from California, Dr. Lindvall, who analyzed retrospectively two groups, one of pelvic trauma groups treated with gel foam embolization, unselective, and the other control group only treated with external fixation. And they had significantly more complication in the embolization group compared with the control group in terms of necrosis and fracture that didn't want to heal. So we should be as selective as possible. This is a study from Italy, Dr. Renzulli, who tried by reviewing the literature to standardize the treatment of pelvic trauma, and he concluded that when you embolize the anterior branches from the hypogastric artery, we should only use temporary embolization agents, while if the bleeding is in muscle and gluteal arteries, we can use coils, plugs, or hystoacryl. So in summary, there is not much high evidence in the literature, and most studies are retrospective. There are some good reviews gathering information, and they tell us to be proximal, use coils or plugs for splenic embolization, and use coils and gel foam for liver embolization, being as selective as we can. And we should use temporary embolization, that is gel foam, for pelvic bleeding. And as I said previously, be selective to avoid ischemic injuries. Thank you.
Thank you very much, Martin. Any question from the audience? No one? You have questions?
I don't think these data are not very controversial. They are in line what we say, but we have no evidence for it. And I think also that each and every physician should use the embolic agent you feel comfortable with and you are used to use. Don't use alcohol or glue or onyx if you don't feel safe, because in a stressful situation, you should be used to what you put in the patient.
Yes.
Yeah.
Yes, it's important. This is an important concept because you have to obtain the result in the safer way as possible. So you must be comfortable with what you are using, microcatheter and the embolic agents, of course. I have a question, but it's more a consideration. Why, if you are performing, for example, an embolization of liver with coils, so I suppose if you are using coils, you are selective over or a minimal, you are segmental, you are performing a segmental embolization. Why to use also gel foam?
Yes, I think that if the patient has bled several units of blood and the coagulation is impaired, and the patient is cold, The coils just let the blood go through because it does not have the ability to form thrombus. And then what I usually do is to try to do the torpedo trick with the gel foam, put in a syringe and inject it so that we help the coil to break down the blood flow and form thrombus. So yes, gel foam should be used if we don't get sufficient blood stop from only coils. So you should really avoid to use gel foam unselectively. Don't use it in the hepatic appropriate artery. Then you can have large areas of necrosis, I think, especially with blood trauma.
But in my experience, for example, and there are some papers about that, the non-selective embolization with gel foam, for example, in a young person after a car accident or a motorbike accident, is very effective. It's very effective because the ischemia has a duration of about 24 hours, not more. If the portal vein is patent, you have a complete restoration of the vascularization, of hepatic vascularization without any trauma. In my opinion, from my point of view, the use of gel foam is controversial if you have hepatic failure, of course, because or biliary disease, because the risk of infection is very, very high. And I don't like to use gel foam with the coils when I'm selective, because if, like you talked right now, if the coagulation is impaired, gel foam doesn't work very, very well. I think that is more appropriate to use 0.1 millimeters of glue to facilitate the occlusion, because coils lost time to work, and not gel foam.
I think that you should take into account if there is a high-grade trauma to the liver, because the literature I went through, reviewed, shows quite clearly that the risk for ischemia increases or correlates with the degree of trauma. So you have to take that into account as well. But I agree with you that if you have a patent portal flow, you in a otherwise healthy patient, you could use gel foam, yes. But I think you should have respect for these methods, because between 10 and 20% of the patients where gel foam is used show ischemic injury within the hepatic parenchyma.
Yes, but they are auto-limited. In most cases, are auto-limited. There are no a permanent damage for the liver. But of course, about that, there is not a consensus.
It depends on if you put in coils as well, perhaps that will permanent your
Yes, we are talking about a selective.
So if you want to if you have a small bleeding or a small extravasation, you could try just use the Spongostan or the gel foam torpedo, and don't flush in more than you really need. Yes.
Thank you,
Martin. Can I ask a question, Martin?
Yes.
Victoria from St. Petersburg. My question is just for understanding about your point on glue in emergency cases. So is it, we are not recommended to use it because of a stressful situation, or, so because we now from Japanese experience, they use NBCA very frequently in unstable scenario, and it is not discussed in your presentation. Could you please, just to clarify, why don't you like it in emergency scenario or during hemorrhage, or am I wrong?
No, I think this comes back to your personal preferences or what you're used to use. We use a lot of glue when we do portal embolizations, for example. And what you really don't want to happen is that the glue spills over and you have unintentional embolization of side branches. If you use gel foam, for example, that occlusion will only be temporary if you hit side branches that you don't want to treat. And also you achieve a permanent, absolutely permanent embolization if you use glue. And in most cases in the liver or in the pelvic area, you perhaps want the occlusion of the vessel not more than a week or 2 weeks, then the gel foam will be dissolved. So that could be a reason why glue is not more frequently used.
Thank you.
Okay, thank you. So we hope to have a few minutes at the end to continue this important discussion. We can go on with Miklos Bala, it is online. Hello, Miklos, with embolization. Hello, embolization and non-traumatic bleeders, indication and solution.
I'm trying to figure
Share
out
the screen.
if you can see my slides.
Yes, you have to share the screen and it's shared. Okay, okay.
Okay, thank you very much for invitation. Sorry for being online. I have nothing to disclose. I would like to address some non-traumatic bleeders, and at least that I put here on the screen is really short, and they didn't cover all the indication that can be used for angio as a solution for bleeding in non-traumatic injury. I didn't mention the postpartum hemorrhage. I think there would be a different talk about that. So we'll be focused on GI bleeding, spontaneous bleeding, vector sheaths, abdominal wall hematoma, retroperitoneal hematoma as well, and some post-op bleeding complication. What I also want to mention, and I think almost everybody probably agree that there is no absolute contraindication for angioembolization whatsoever. The only thing you have to make sure that you take into account that some relative risk of ischemia and necrosis for the organ that's targeted during the angioembolization. And I think GI bleeding is the well-established and very much discussed indication for angio. And it was already mentioned that every society came up with some guidelines, meta-analysis, some recommendations, and toward using the angioembolization in GI bleedings. So it's a lot written in literature. I want to focus and try to figure out what the difference between surgery and angio, what's an outcome for both. And actually, the success rate for surgery and angioembolization is really the same. In terms of mortality also, it's more or less the same. There is a little bit more complications toward the surgical group, and recurrency or rebleeding a little bit higher in the angioembolization group. On the other hand, you have to be sure that when you look at big data, the patient who goes to angio are often older, sicker, and sometimes didn't fit to surgery at all. And when talking about the lower GI bleeding, the evidence is even less. The main indications are diverticular disease, AV malformations in the colon, and the success rate is high, but also red bleeding is high, as well as risk of ischemia. For the small bowel bleeding, I think we have a very well established protocol. It should be localized first, and the CT angio is a main issue to start with. As here in this picture, the small gastrointestinal stromal tumor that was successfully embolized in the same day, and the same day actually was ceased with the laparoscopic approach. Once more, there is a risk of ischemia for small bowel embolization. As much as you stay close to the abdominal wall, probably the risk is still exists. For the rectus sheath hematoma or abdominal wall hematomas, that often is spontaneous in elderly patients who receive anticoagulation. The angio became the treatment of choice, I would say, because it's good for those who are stable and have a CT scan with contrast extravasation, but also for unstable patients who really should be rushed to angio. If it's possible to do it, it's better to embolize than to take them to the operating theater. I think the same is right for the retroperitoneal hematomas. Once more to old folks with anticoagulation on the background and sometimes hemodialysis. The evidence is low, but the one should choose where he goes with the patient in the operating theater or to the angio suite. I think in both cases the results are not that good, with the mortality is really high in that group of population. For post-op bleeding and for biopsy bleeding, there's a lot of indications exist in the surgical world, and there is also often the question where to go, back to the surgery or to the angio suite. And I think the Whipple procedure is a great example of that. So in the high volume centers, the rate of post-pancreatectomy bleedings are pretty high. It goes more than 10%. And in those patients, the mortality is really high in the hospital stay. And gastroduodenal artery is probably the most known one to cause that problem. But also here in the slide, I just show the pseudoaneurysm of the hepatic artery that was successfully stented. But the things really important to mention. And I want to summarize that non-traumatic bleedings, it's still, like actually in the trauma cases, it all depends on stability, hemodynamic stability. And if you can resuscitate the patient, the localization studies are really important one to get to the angio suite prepared and do the right procedure in the real time. It could be a CT angioendoscopy or some nuclear studies maybe, and for the unstable patient, maybe empiric angioembolization is a real issue. I think it's not a lot of evidence about that, but the commitment of the surgeon and the invasive radiologist that works together can solve that problem. The only thing I would like also to mention that probably unstable patient in post-op bleedings that you really should know where to go, may skip this localization study and go straight to angio. And also the rebleeding plan is better to have if you are going to that direction. And thank you very much for the opportunity to present, and hope to see you next face-to-face.
Thank you very much, Miklos. We have a very few time, but if there is a question from the audience or from panelists. Okay.
I just have a brief comment just to make sure Tal's awake. One exception to angioembolization with retroperitoneal hematoma is with femoral nerve neuropathy. Those have to be decompressed promptly, otherwise you get a permanent femoral neuropathy if you leave those large retroperitoneal hematomas alone.
I think you're correct. We often go to OR, but sometimes angio is like, well, you don't want to take a patient that sick to operating theater, but probably you are definitely right. The decompression is better than, and also the abdominal compartment syndrome that can drop with that is also an issue.
May I ask a question also? Hi, Miklos, this is Victor Reva from St. Petersburg. I don't know what are the situation with COVID in Israel now, but do you have an experience in treating patients during COVID with the spontaneous rectal sheath hematoma, cough associated when there is a huge hematoma from the arterial abdominal wall, extend into the retroperitoneal. We just had a few cases in treatment by embolization. Do you have an experience, or maybe someone from panel experts?
Unfortunately, I didn't. The only thing that the outcome is bad anyway, especially for those who are on ECMO.
Comprehensive, thank you.
Okay. So we can go on?
Yes. Next is David McGreevy, talking about 100% EVAR for ruptures over 12 years in one center.
Thank you very much. So the session is titled Embolization and Other Solutions for the Bleeding Patient. So I suppose, as all other talks have been about embolization, this is maybe the other solution. But it's not the only solution, but it's one of the solutions. And I'd like to start off with a slide that I borrowed or stole from our previous mentor, Thomas Larsson here, who started the endovascular era in Örebro a long time ago. And this is a slide that's the first EVAR that's been performed in a rupture case. And since then, ruptures there's been a huge debate about performing either open surgery or EVAR for ruptures. And most of all the randomized controlled trials and analysis that have been done haven't really shown any survival benefit comparing the both means of treatment. What we can see in several randomized trials, the AAC study, the ECAR study, and the IMPROV study, mainly the survival rate in these patients was between 18 and 35% for EVAR. What we could see, however, was that there seemed to be in these studies a gender benefit for specifically women, benefiting more from EVAR compared to open surgery. They also couldn't in these studies define any difference in survival with the older patients. But many of these studies have been criticized specifically because of their design, because of the patients that were included. For example, the ECAR study and the AJAX study, they actually randomized the patients after a CT was being performed. So, and for many of the patients, actually, they didn't include the most hemodynamically unstable patients, which is the category of patients that maybe actually EVAR would be specifically more beneficial in. And there are multiple guidelines that state, for example, the American Society of Vascular Surgery, their guidelines state that EVAR should be a first approach in patients with ruptured aortic aneurysms. However, they do acknowledge the low level of evidence for this. And the European guidelines state that it can be considered. Örebro, together with Swedish, presented quite many years ago where they looked at the use of only 100% EVAR in all their cases, presenting a mortality rate then of 24%, and specifically in Örebro of 28%. And what we decided then here was that we wanted to look at all our ruptures, because in Örebro, ever since 2009, we've treated every single patient with 100% EVAR, both for single or for infrarenal, but also for thoracic abdominal aortic aneurysms. So we looked. We had 143 patients. We decided to remove those that had previous aortic surgery and only look at the pure ruptures. Those that were dead on arrival were also excluded from the cohort, and we had 117 patients that were included in this analysis. 13 of them received best medical treatment, and only 3% was because that the actual physician decided that it we weren't going to treat them surgically. whereas most of the other patients decided that they had already previously decided they didn't want to undergo surgery. So 104 patients in total received EVAR during this period of time, 12 years. And what we could see here was that, as usual, majority of patients are male. And interesting enough, as compared to the previous study, is that over a majority of these patients were hemodynamically unstable. Most of them were performed with local anesthesia, and a total of 17% received aortic balloon occlusion to be able to keep them hemodynamically stable so the EVAR could be performed. We also compared to see, or looked at if there was any defining pre-operative parameters that in comparison to the mortality rate, and it was specifically hemodynamic instability and the use of aortic balloon occlusion. Those patients obviously had lower survival rates. This could be performed 100% EVAR, even with relatively little complications. Only 33% presented with a 30-day complication. Majority being kidney failure, and this is because a lot of these patients we were doing with, for example, chimney techniques and branches, and sometimes then also the renal arteries in some cases had to be, or one renal artery had to be covered. One of the main benefits also for these patients doing it 100% EVAR in these cases is that now, for example, in the COVID area where you have ICU staff and ICU patients or ICU places are very limited, performing EVAR and not having them in the ICU as long will be hugely beneficial compared to open surgery, with only 18% requiring more than 5 days in the ICU. Our mortality rates in these 30-day mortality rates, specifically for infrarenal, was 24%. And interesting enough, what we could see compared to previous studies where women seem to benefit more than men with endovascular, is that actually women had roughly the same type of mortality rate as in previous studies, but however men only were 26% mortality rate, so much better compared to other studies. So maybe this gender imbalance is not actually that huge as we think it is. Yeah, thank you very much.
Thank you, David. Any question from the panelists also, from the audience? Professor Moore?
How large part of these patients were done with local anesthesia only?
54%.
54.
So that's only local anesthesia. However, all patients are started in local anesthesia, but then because of certain reasons, if they need then to be converted to general anesthesia throughout the procedure.
A great talk, David. I noticed a couple of your patients had paraplegia. The rate seems a little higher than I recall from the literature. Were you able to identify any risk factors? You look at Adam Kawitz or anything on CTA? Could you predict those patients who develop paraplegia before surgery?
We haven't looked at that specifically, but that's absolutely. We also looked. We've noticed that that's one of the things, and we want to look at that and continue. So we're going to be looking way more in detail at these different aspects of all this data later on.
And do you treat patients completely percutaneously? How many patients are completely percutaneous? With Proglide?
99% were done with percutaneous. There was only one patient that we did cut down on.
Great.
How many patients, or rather, how many patients got branched or fenestrated grafts compared with straightforward infrarenal?
So 30% got some form of branched or branch grafts. Then a few patients were done. There was 4% that were done with fenestrations.
And for those patients who were inappropriate for repair, what did best medical therapy consist of?
So basically, pain relief and anxiety issues and so on. But then, so these were the patients that mostly because of, I think the mean age of these patients was 89 years. And they're because of complex anatomy and large, big aneurysms, and that's why we decided not to treat them.
Earlier in the beginning of the 2000s, aortounial was often used with the ruptured AAA. Do you still see an indication to use aortounial systems?
Absolutely. I think there's indications, of course, to use aortic iliac systems. We didn't specifically look. We didn't look specifically in this cohort in those patients that had iliac aneurysms. But that's something that we'll be looking at in the future as well in this cohort.
So what do you think had happened if they had been operated by open surgery?
You mean that if the survival rate had been any difference?
Yes. So if you could compare with another material or before, so with this result, it's a good result. But what had happened to these patients if they all had been operated by open surgery? What would you guess?
I mean, I'm thinking one of the benefits is of having only doing one procedure is that all your staff is also very, it's not just the surgeon that needs to be comfortable with performing a certain procedure, but also your nurses and your whole team in the emergency and so on. So one of the benefits of doing it only endovascular is that you have the whole system in the hospital working together and know what they're supposed to do. When you have two different systems, either doing endovascular and open, that can also be an issue. Regarding what would have happened with the patients if we perform them open, I don't know. But we'll maybe what we can do in the future is also compare our numbers or compare our surgeries previously when we performed open surgery on these patients and see if there's any difference in survival and other aspects.
We have another question.
So just a couple of comments on the branches that you mentioned. Most of the 30% of the visual arteries were revascularized. Most of them were done by chimney or pilot grafts, and a few of them by branches and fenestrations. And going back to the survival rate, there historically the ruptured mortality numbers are 50 to 80%. So the numbers of 24 or 28% in our center was significantly much better.
Okay, thank you.
Thank you,
David. Okay, we move to the next presentation. Edmund Sovic. Hello, Edmund. Embolization agents, what to use and how?
Thank you for being invited here. I think a lot of this will be overlapping with Martin's presentation. First, I'll say something about the classification of embolization based on the duration of vessel occlusion. We have to think, is it a temporary occlusion we want to have, or is it a permanent occlusion? For the temporary use, we use a gelatin sponge, gel foam. That's what I have experience with, but also in the literature, it's described that you can use oxidized cellulose or microfibril collagen. For the more permanent occlusion, we have the mechanical agents, coils and detachable plugs. We also have liquid agents, sclerosants and polymers, and we have the non-absorbable microparticles, PVA. Before determining the best agent, can the vessel be sacrificed without putting downstream organs at a significant risk? Is the vessel large or small? For how long shall the vessel be occluded? Is the tissue supplied by the vessel to remain viable after the embolization? When do we need a large vessel permanent occlusion? Well, if you have a GI bleeding, in the traumatic pseudoaneurysms and in renal trauma, but also with pulmonary AVMs and visceral artery aneurysms. We then use coils or Amplatzer plugs. This is a procedure that is equivalent of a surgical ligation. Large vessel temporary occlusion. That's in situations where temporary arrest or hemorrhage is necessary with subsequent recanalization and a vessel healing. Typical large vessel traumatic injury, such as a hemorrhage following pelvic trauma or a ruptured spleen or liver. There's been a little debate here about using coils or gel foam earlier, but I think that we should use gel foam more than we do today, also in our hospital, as a slurry or a torpedo, and or in a combination with coils, for example, in a sandwich combination. Now, this is an algorithm for the large vessel embolization. For the temporary occlusion, we know it's the vascular trauma, and it's a gel foam plus minus coil. For the more permanent occlusion, we have the GI bleedings, the traumatic pseudoaneurysms, and there also coil and gel foam, and eventually Amplatzer device. Now, this is an algorithm for small vessel embolization, and what is most actual in this forum is the permanent embolization, where we want to maintain the viability of the organ, such as in bronchial artery bleeding, small vessel GI bleeding. There we can use small coils or large particles, larger than 300 microns. Now, we must remember that the smaller the agent, the greater the likelihood of ischemia of the organ being supplied by the embolized vessel. Now, this is due to the fact that most organs have some duplication of vascular supply. This collateralization is vital to organ survival following a proximal vascular event. If very small embolic agents are used, the effective level of the embolization is distal to where the collateral vessels join the main feeding artery, thereby effectively occluding inflow from both the primary and collateral circulation. Therefore, for most organ systems, small agents cause much greater ischemia than larger agents. Bleeding in trauma patients, we need a fast reduction of blood loss. Preference should be given to embolic agents that have a simple delivery system and provide prompt vessel occlusion. The use of coils can be both cost and time intensive, especially if you use microcatheters. We know you have coils of different types. We have the macro, the micro, the detachable, and different configurations. Now, we put them in with a pusher wire, or you use the hydraulic pressure from a small syringe and just shoot them in. They're easy to use, but they are dependent on the coagulation status. And the risk is always a misplaced coil. Here's some examples from the Interlock and the Nestor coils. Here's an example of a coiling of the gastroduodenal artery in a duodenal ulcer. It's always important to shut the back door also, due to the collateralization from the superior mesenteric artery. Now, gelatin sponge. Embolization results in almost instantaneous vessel occlusion and hemostasis. The delay in vessel occlusion by coils could be detrimental in patients with, for example, a fulminant splenic hemorrhage. Induced occlusion is not dependent on the patient's coagulation status, and that's very important. Shorter procedure time means decreased radiation exposure. Maybe not so important for these patients, though. Also, worth to remember that you have the recanalization after, well, 2 weeks to 2 months for using the gel foam. And here, how we can use the Spongosan slurry in a mixture of 50-50 saline and contrast. Earlier, we always cut up the Spongosan ourselves and put it into the slurry. But nowadays, we use more EmboTube gelatin that reduces the time for preparation. Thank you.
Thank you very much. Questions, comments? Martin.
If you expect ischemia from your embolization procedure, in what situation do you use broad spectrum antibiotics prophylactically, or do you use that?
In most of these patients in trauma, they are given antibiotics before the procedure. Yes. As a routine. Yeah. I don't know if you do that, Martin.
Yes, we do one dose if we don't have any special suspicion of that the patient is septic or so. For example, when we do a tumor embolization or a spleen embolization, we give one dose. But if there for some reason is some more risk, we give 3 doses during the day of procedure.
Okay.
But if it's open trauma or open wounds, of course, there should be a continuous antibiotic given. But,
yes.
May I ask a question up here? Pirkka here. Edmund, thank you. And maybe also Martin. I've been often wondering about the temporary closure of the gel foam. Why are we closing it temporarily? Because the recanalization comes very late and the potential ischemic insult is happening during that time. So what's the role of the recanalization in these situations actually? What's the benefit?
Well, for example, if you use it in the pelvic area, we can see that you don't have the same necrosis damage by using the gel foam as if you use the coil stove. Yeah.
So you mean that the vessel stays occluded for 2 weeks and then it gets open, and that's relevant for the necrosis?
Well, 2 weeks, I think that in many cases also you have the recanalization much earlier than that. Probably you have that, yes.
But wouldn't the necrosis come in hours or half a day or so?
I don't have the good answer for that, actually.
My experience is hours. I think that the ischemic event is duration of 24 and not more than 48 hours. I have never seen an ischemia.
So perhaps there is recanalization immediately within hours, but radiologically it takes 2 weeks to 2 months to clear out entirely?
By my experience, for example, I have a great experience in liver embolization with the Spongerston. The recanalization is after 24 hours because I perform a CT scan the day after to see if there is a pseudoaneurysm, for example, that can I embolize selectively because it's possible. Then, for example, a laceration creates a pseudoaneurysm, and it is not good to leave the patients with the pseudoaneurysm. And I always, the day after or not after 2 days, not more, I perform a CT scan. And the proper hepatic artery is always patent.
Is there a distinction between your use of a torpedo or a slurry with just contrast and adding thrombin, and does that change things for you?
I use with contrast and the saline, with a mixture.
Okay.
Yes, 50, like him, okay. 50%.
Most likely.
Yeah, about 50%.
50-50.
Yeah.
Can I ask a question about the hemostatic agent injection?
Yeah.
So I agree it's a lot faster than mincing up gel foam on the back table. But I was curious if you alter the concentration of it, because I've found if you give the full syringe or even a full strength of it, it can gum up a catheter. I basically don't use a microcatheter if I'm using it. And even the 035 angle glide catheter can get sticky. So do you dilute it at all, or do you just inject the flow seal directly?
Just put them in directly, yeah. The slurry, yeah.
You mix it with any contrast or just inject it directly?
50-50 with saline and contrast. It's a mixture, yeah. I don't know if that's what Martin or Anna Maria also do, but that's the way we do it, and it works, yeah.
Yes, we inject up to there is flow. When we see the flashback, we stop the injection of spondyal. And I use it without a microcatheter also. When in emergency setting, for example, when the patient is stable or a little bit unstable, in liver or in pelvic embolization also. Of course, in my experience, especially in muscular injuries, for example, retroperitoneal injury or pelvic injury, depends from the coagulation status of the patient, the effectiveness. Even in my opinion, even the creation of pseudoaneurysm the day after, for example, because if the coagulation is not good, it is beginning to be not good, the probability of recanalization or the probability of rebleeding is higher.
All right, moving on. We have Dr. Gadi Shaked presenting on embolization or multidisciplinary trauma team work.
It's not really
Not really the subject. Topic
okay, thank
to be
you.
discovered.
Yeah, so after all the interesting presentations, some refreshment with a real clinical case. And the only disclosure is that it doesn't have nothing to do with the session of embolization. Thank you, Tal. And yeah. So it's a 25-year-old healthy woman involved in a motor vehicle accident at 10 p.m. The mechanism was self-accident as a driver. She rolled over. The injuries immediately seen were a severe head injury and fractures on the right side of the chest. She was spontaneously breathing and no measured blood pressure, and she was, of course, unconscious. The immediate treatment that she got was the right chest needle thoracostomy. We're talking about the scene, intubation, exstabilization, and rapid evacuation by an ambulance. In the shock trauma room, it was about 30 minutes or 35 minutes later. Again, the same mechanism. She had obviously head and chest injuries, and she was intubated and ventilated on way. And again, no measured blood pressure, just palpable pulse, rapid pulse of 125 per minute over the carotid only. And she was with Gauss-Cone scale of 3, temperature 35, so mild hypothermia. And what she got was bilateral chest tubes. On the right side, there was a hemothorax, femoral arterial line, femoral arterial line of 7 French was inserted, and immediately inflation of the reboa balloon in zone 1. And we started the blood and blood products, FFP. EFAST was positive for abdominal fluid, and the patient was immediately transferred to the OR. In the operating room, she got explorative laparotomy, and the liver laceration was found with only 500 mL of blood, intraperitoneal blood, and the large zone 1 retroperitoneal hematoma. So hepatic packing and cattle brush maneuver, to those who are not familiar with the terms, it's a lateral to medial rotation of the colon and the duodenum to explore the retroperitoneum, and no major vascular injury was there. So it was finished with rapidly vac pack and abdominal, for abdominal closure, temporal abdominal closure. And the balloon was deflated, and she remained with around 100 systolic pressure. So during surgery, she received 3 more units of PECT red blood packed cells and 3 units of fresh frozen plasma, along with 10 units of platelets. So basically it was according to 1:1:1 ratio. By the way, now we're already using whole blood. And the problem that the team was faced with was that there was difficulty in removing the balloon. So it was relatively forcefully, along with the sheath, they were removed from air. So now, almost immediately, there was a problem. The leg became ischemic. And the question now was, what should we do now? We're not going to discuss it because of the shortage of time, but we decided, or they decided, that D comes before ischemia, because she was immediately transferred to the operating theater. So we didn't know what is going on in her severe head injury. So in this case, she was taken to the CT scan, and the severe brain injury was demonstrated, but nothing that required surgical evacuation. So at this point, she was returned to the OR in order to put an ICP bolt and open femoral artery exploration with thrombectomy and repair of the vessel. 2 days later, second laparotomy was done after she was stabilized, of course, and the correction of the physiological and metabolic derangements, and the primary closure of the abdomen was done. And the outcome, she was discharged from hospital after 74 days to rehabilitation center, and unfortunately she remained in a vegetative state, and currently in a nursing institute. So the lessons that we learned was that Riboa was justified even in the face of severe head injury that was suspected. There is a big debate. We haven't said nothing about it in this conference, but you know that there is a debate about it. It improved their status and gave us the window of time to give her blood and blood products and control the bleeding source. We know the pitfall of removing of the balloon and the sheath, and we must expect it. Don't panic if it happens. You must, and here we are talking about the team and cooperation. This is a very good example for it. You must have your vascular, your IR, interventional radiologist, with you, not against you, and they can correct the faults that we do. And from then we decided, actually it was our second case that it happens in the series of 24 cases, and that made me change our policy and to change from 7 French to 8 French. So this is, I think, a point to discuss if everybody agrees upon it or not. Thank you.
Thank you. Okay, gives a point of discussion.
Yeah.
Please. Okay.
I must mention one thing. We didn't use contrast material because it happens in many cases with contrast material, especially if you don't dilute it well with saline, but this wasn't the case.
Thank you. Just to do that, because we have had the same problem and we sent our stuck balloon to the company, and I think they made some modifications in the next generation. But It's actually due to an intussusception of the balloon. So what you can do, you inflate the balloon a bit, and then you push it back up, and it might get straight. And then you push it up and do a vacuum on it, and you get it back. But it gets stuck in the end of the 7 French. So what we did was the same. We changed our protocol to 8 French. But I think the next generation balloon has changes.
Thank you. Thank you, Gadi. Great talk. Just a short thing. We changed also to 8 French. We will see with the newer generations. I saw that the Japanese, nobody is here from Japan due to the pandemic, but I saw several cases that they just take it on block. They just take it out on block. And I'm not sure if it's reported any problems with it. I don't know.
Just briefly, I'll say my experience with the next generation of the rAAA, they have made a tremendous improvement in that. And we've been able to stay with the 7 French.
Thank you, Gad, for your presentation. I have just a question. First of all, how it was like total occlusion of rAAA, and for how long time it stayed a balloon occluded?
In this case?
Yeah.
It was about 30 minutes.
30 minutes, total occlusion. And about TBI, so do you think that the balloon affected the TBI in that case?
What was it? If in the face of TBI, if to inflate the balloon?
Yes, if it's like
Yeah, I think,
30 minutes.
like always, if you go according to priorities, so C becomes before D. It's true that in the literature you can find cases where probably it increased the bleeding, the intracranial bleeding, but I think that C, if the patient is in severe shock, you must correct it first. Secondly, what are the other choices? If there is no blood pressure, you're going to crack the chest and put a cross clamp on the descending aorta. What is the difference? It's the same. So I don't think you have any other choice.
Okay, thank you.
Oh, it's an interesting case, and I commend you for recognizing the femoral thrombosis. I think that we haven't talked about it much this meeting. We certainly have in past meetings, but I think it's important to emphasize that we need to have a complete vascular exam of that extremity before that patient leaves the operating room. And I'll throw out a controversial point, but I would suggest that a thrombosis of the SFA is an emergency, and that should be treated with an open thrombectomy, not hoping that our friend from interventional radiology will come by and salvage us later. We, in fact, lost an extremity this year at our institution because of exactly that scenario. You know, we get a complication, and our temptation is to try to shortcut it and minimize morbidity. But in fact, when you have an occluded femoral artery, that is an emergency, and we should open that up and remove the clot, in my estimation.
Yeah, but the point was that we thought that the brain is, for example, if there is a epidural or subdural hematoma to evacuate, it's even more important. Secondly, all the CT scan, it's nearby, and it's about 10 minutes or not more than that. So it's true that to take the patient off the table, take him to the OR or to the CT scan and go back, it takes much more than 5 minutes, but it's still within, warm ischemia of an hour or less. It's, I believe it's not going to jeopardize the limb, but maybe I'm wrong. I don't know.
This is a scenario in which, if you have a hybrid room doing a cone beam head CT, which doesn't give you the highest resolution images, will at least let you know if there's a space occupying lesion that needs to be addressed, and kind of saves you the transport time.
Regarding the leg, it would
could also be an alternative to just do ultrasound and check for patency below the groin, and if it's a local problem in the groin, perhaps the vascular surgeons were willing to fix it in the room. So ultrasound again, I recommend.
Thank you. Thank you,
Okay,
Gadi.
thank you.
Thank you. We can move on. I invite Professor Moore for the next talk. What should be embolized in trauma patients and when pelvic packing? Our experience and tips.
Thank you. And unfortunately, continue my theme that we can't forget the surgeons in this new world of embolization. When do we embolize? Once again, I think we need to put in perspective what we have available to us, the site, what our expertise is. And as mentioned, if you're in a hybrid room or have one close by, it's completely different than another environment. And once again, as a trauma surgeon, I tend to bias a little more open and recognize that other colleagues would move more toward the emboli. Well, we talked about a lot of the techniques, and it's been a great review. I think, again, if we go through from head to toe, if you look in the neck, I don't think there's any question that embolization of zone 3 external carotid branches and the vertebral artery and stenting when appropriate is clearly preferred. In the chest, there are great opportunities there with intercostal bleeding. Often that can be recognized by putting a Foley catheter in the chest tube site. And if that stops the bleeding, then to embolize. Where we move the abdomen, I think that's where we may come into controversy. Again, my stand on this is if the patient's unstable with a liver injury, we should open them, accomplish total vascular control, and manage the culprit bleeding vessels. On the other hand, if the patient's stable, there is a role for coarse embolization in the liver, but as nicely outlined in the reviews we've heard today, that's not without its consequences. And the controversy continues as to whether and what the role of embolization is for liver injuries. But I would say that if I look at the literature in the last 5 years, we've probably swung to a little more selective embolization for liver injuries because of the risk of necrosis and bile leak. When it comes to spleen, once again, if the patient's unstable, I don't think there's any equivocation that we should be taking out these types of spleens. I'm not sure you expert interventionists could probably spare this spleen, but in our hands, we would take this type of grade 5 injury out instantly. On the other hand, we continue to debate the extravasation for grade 4 and 5 injuries, and I think, again, the pendulum is now swung to where, at least I'm convinced, we should do preemptive embolization for grade 4 splenic injuries, and I think all agree grade 5. Renal is another story, and that's evolving too. Now the experts in our colleagues in urotrauma have divided the kidney into A, B. The A, the high risk being the 3.5 centimeter pararenal hematoma. There are several articles now that seem to suggest the size of the hematoma, the medial location, and so on warrant preemptive embolization in high-risk kidney injuries. Now, the controversy continues, and again, we're a little biased in this about what to do with the patient with pelvic bleeding from fractures. This is the most recent series from the United States, a relatively large series of patients that arrived in shock from pelvic fractures from 12 level 1 centers in the United States. And remarkably, the mortality in this series was 32%. The last multi-center study from the United States was 33% 5 years previous to that. So we're not really improving, at least in the United States, our overall outcome with patients with bleeding from pelvic fractures. Remarkably, in this series, this is published in 2019, only 2% of the patients had rAAA and 10% pre-peritoneal packing. And as many of you know, the old studies out of Scandinavia showed decades ago that convincingly on autopsy that the overwhelming majority, 85 to 90% of bleeding from pelvic fractures is from the venous source, the bone or venous structures themselves, suggesting that, as proposed then, that the key is repositioning this pelvis and allowing hemostasis in a closed compartment. Our approach is pretty much summarized here, and I suspect that is also common among many that attending this conference. We believe that rAAA is pivotal for patients with persistent shock with pelvic fractures, and zone 3 is particularly safe because of the prolonged tolerance to warm ischemia. If those patients then require ongoing blood transfusion, we take them immediately to the operating room where we do pre-peritoneal pelvic packing. And we modified the European technique somewhat, is that we make a suprapubic incision and place 3 packs on either side of the bladder to gain hemostasis in the retropubic area and close the fascia so we have tight tamponade in that area. Then if the patient remains unstable, ideally we should be in a hybrid room. But even in our scenario, Chuck Fox taught us that we can do simple on-table angiography to identify those who require further therapy. If they remain stable with the packing, then we send them for total body CT, because these patients invariably have a high risk of other associated life-threatening injuries, particularly torn aorta. If the patient is stabilized with this, then we access the contralateral femoral artery and do an on-table angiogram. This was a patient a year ago that had a occluded external iliac artery, which we then repaired in the operating room following packing. In our series now, we've gone from mortality that was roughly the rest of the United States in the range of 25 to 35%. In our most recent series, we presented to the trauma community 2 years ago. We now have a mortality that's 14% in our recent 5 years using rAAA and packing. And none of these deaths occurred from uncontrolled bleeding. So I appreciate the opportunity and recognize I've raised a number of controversies. Thank you.
Thank you, Professor. Is there a question?
Just a few words about the algorithm of pelvic injury. So we can argue about it, but for example, in our place, what we do is pre-peritoneal packing in the shock trauma room. And only if not like you said in the OR, I mean, it's preferred to be done in the OR, but if the patient is obviously with severe pelvic injury and no blood pressure, we start with pre-peritoneal packing, and only if blood pressure is not raising up, only then to put the rAAA. And we have good results with it, because good correct pre-peritoneal or extraperitoneal packing should stop roughly almost 100% of the cases, will stop the bleeding.
Now, I recognize that would be a controversial point, but given the 1/3 mortality reports out of the United States, we remain enthusiastic about promptly stopping the bleeding. And again, you could argue which patients, but I'm referring to patients who are in persistent shock in whom we place the zone 3 Reboa. But I'd have to acknowledge I'm a zealot of Reboa, but believe this is one of its very important roles.
Dr. Moore, do you have an opinion on the AAST modification such that pseudoaneurysms will bump up a splenic injury to grade 4? And do you think that that has resulted in overtreatment of splenic injury?
Well, certainly the upgrade in the AAST system where we've incorporated CT findings has enhanced our granularity a bit, but the results thus far, I'm not convinced, have shown us that this modification has improved outcome. And I think particularly, as you mentioned, small pseudoaneurysms, I think can be re-studied in 3 to 7 days and treated. I don't think every small little pseudoaneurysm needs embolized.
Here. Thank you, Dr. Moore. So you dodged the more controversial question about the splenic injuries and the grading. The grade 3s, should we preemptively embolize those that are stable, semi-stable, or not?
The grade 3?
Yes.
I think the grade 3s should be infrequent that we embolize, and more recently it's been suggested in children in particular that perhaps we're being over-aggressive, both 3s and 4s. But I think, as I understand it right now, the real debate centers around 4s, in which I go on the side of preemptive embolization.
Thank you.
All right, thank you, Dr. Moore.
Thank you.
Next, we have Ilan Bruchen from Israel, presenting gynecologic bleeding and intervention, what and when.
I hope you see my screen. Do you see my screen?
Yes, we see.
Hello, hi. Thank you for inviting me to present in this conference. And I apologize that I couldn't attend the meeting because of the COVID pandemic. I'm going to present on gynecology bleeding and intervention, what and when. When we talk about gynecology bleeding, there are two main bleedings, hemorrhage. One is the obstetrical, antepartum and postpartum, and the other is the gynecology, intraoperative after hysterectomy or during hysterectomy, myomectomy, lymph node dissection, or other gynecologic causes, ectopic pregnancy, hemorrhagic corpus luteum, cystectomy. I'm going to concentrate today on the gynecologic bleeding. Tomorrow I'm going to speak about the obstetrical bleeding. So first definition. Definition is blood loss of more than 1 liter or requiring a blood transfusion, or massive hemorrhage, blood loss of more than 25% of patient blood volume, or requires emergency intervention. Obviously, preoperative evaluation, preparation of every surgery is mandatory, medical and medication history, full laboratory evaluation, correction of any anemia, and some consider prophylactic tranexamic acid prior to surgery. Obviously, the surgeon, the team should be prepared to handle any intraoperative hemorrhage. And when we see, or when there is a issue of a significant hemorrhage in surgery, so first we apply pressure. If we are during laparotomy, so immediately we're using sponge stick, laparotomy pads, or if we are during laparoscopy, as you can see here, in a rupture ectopic pregnancy, we use the atraumatic laparoscopic grasper to the site of the bleeding. We insert sponges through the 10 millimeter port. And in severe significant cases, we consider laparotomy. Usually we can handle these cases by laparoscopy. If it's a vaginal surgery and we can control the bleeding through the vagina, we consider turning into laparoscopy or sometimes to laparotomy. And of course, in cases of significant bleeding, we give massive blood transfusion, blood, platelets, and fresh frozen plasma. If bleeding continues, of course, we need to identify and control the localized bleeding. Common sites of major bleeding in the pelvis are first the organs, obviously the uterus, during hysterectomy, during myomectomy, the ovaries and the fallopian tubes. The vessels that could be involved in bleeding are the ovarian vessel, iliac vessels, parametrial vessel, and paracervical vessel can cause retroperitoneal bleeding, bladder pillars, and presacral veins. We will continue, if there is bleeding, to locate the bleeding site and dissect the pelvic. We dissect the pelvic fascia, we identify the vital structure, the vessel, the viscera, and isolate and ligate the bleeding vessels. During the surgery, gynecologic surgery, we should be able to identify all the spaces, the paracervical space, the pararectal, and the vesicovaginal spaces. All can be involved in surgery. You can see here on the left side, sharp dissection of the bladder from the uterus during hysterectomy, and on the left lower, mobilization of the rectum and detachment for the posterior uterus during hysterectomy. If there is any retroperitoneal bleeding, we apply direct pressure on the area of the bleeding. We expose the area, open the peritoneum over the paracolic gutter, and mobilize the colon medially. And then we need to isolate the vessels. If there are small vessels, we of course coagulate surgery or put clips. If there is venous bleeding, so gentle pressure usually helps. Large vessel, aorta, vena cava, or common iliac vessel, we usually ask the assistance also of the vascular surgeon. We use the topical hemostatic agent that you talked about it during this conference. And in patients that are stable and can maintain the volume status for at least 2 hours, we also consider interventional radiology's embolization. If there is persistent bleeding, we should consider doing vessel ligation. First, we do internal iliac artery ligation. We need to know that bilateral internal iliac ligation lowers the pelvic vasculature by about 85% and blood flow in about 50%. Complication of this procedure is ligation of the external iliac artery or injury to the iliac veins or external iliac artery. We open the anterior leaf of the broad ligament, and we use a non-absorbable suture or silk suture around the artery, usually done lateral to medial, and we can use also clips for this procedure. If internal iliac artery didn't help, so we do uterine artery ligation. And in very severe cases of bleeding, when patient is not interested in pregnancies, we go for hysterectomy or oophorectomy. and also use prolonged pelvic packing for 48 to 72 hours. Again, in a stable patient, we use embolization. Thank you very much.
Thank you. Questions from the audience or from the panelists? I have a question. Do you use a prophylactic balloon inflated in internal iliac artery for risk partum?
Yes, so I'm going to talk tomorrow about the postpartum hemorrhage. Today I talked about the gynecology surgery. So to avoid the postpartum hemorrhage, usually during placenta accreta surgeries, some use the intraarterial balloon. There is no good or significant evidence showing that this procedure decreased significantly the risk of severe bleeding after removing the placenta or during these surgeries. But some use this procedure. We used to do it. Now we're not using it prophylactically, I mean.
Yeah, we use, and another advantage is that if you have a bleeding, you are ready with the catheter already in the internal iliac artery, and you can embolize very fast. And for surgical, I think that, I don't know, but I think that in my experience, and there are some papers that demonstrate it also, probably interventional radiologist, the role of interventional radiology is before the pelvic packing. What do you think? I ask to you and to the panelists and to the audience also.
Yes, so for doing the interventional radiology or embolization, if you didn't prepare it preoperatively, so you need a stable patient. When the patient is not stable or developing a DIC during the surgery, so we go priorly to packing in these severe cases. But if you are already prepared with prophylactic balloon, so you can, of course, inflate the balloon.
Yes, of course, if you...
We are considering now, according and after reviewing the literature, using also rBOA for cases with PPH, with postpartum hemorrhage, also prophylactically preparing them for surgeries.
Yes. Some observation from the panelists? Okay, so we can move to the last presentation. Aina Kratowska, small vessel embolization in trauma.
Good afternoon, dear colleagues. My name is Dr. Aina Kratowska. I'm an interventional radiologist from Riga East University Hospital in Latvia, and today I'm going to talk about the small artery embolization in the patients with a trauma. So when the patient comes to the shock room, we assign the main leader of the trauma team, and usually in our institution is the main radiologist, main surgeon on the duty in that day. And if the patient is hemodynamically stable or made stable, then he's transferred to a CT room where examination is performed. And if the patient is having hematoma, extravasation, or carotid artery sign, the main surgeon calls interventional radiologist. And then two main question comes to interventional radiologist. Can you access the artery? And the next question, in what time you can do? Well, basically, to answer those questions, we can say that endovascularly we can access nowadays mainly all kind of arteries. The only question now is left at what time. In a trauma patient, we do not have hours and hours for catheterization. That's why before answering the question, can you do it? First of all, interventional radiologist has to answer himself the following questions. Can you access through the general access sites, so femoral arteries or arms? What is the complexity of a target artery catheterization? Can you do it quickly enough? What is the stability of the catheter when you are in place? And do you have all the necessary materials, especially if there is a case of graft placement? So for yourself, you have to decide whether this will be a straightforward case or this will be a very complicated. And depending on that, you decide for yourself how much it will take. In our practice, if the trauma patient goes for embolization, if you spend more than 60 minutes for doing the case, then most probably you lose the benefit of endovascular access, and maybe you should rethink whether this patient goes to open repair. In our experience, we have done a broad spectrum of large and small artery embolization in trauma patients, starting from classical splenic and renal artery embolizations, and also distal branches or proximal embolizations, hepatic arteries. But the more interesting cases, of course, are those small arteries like suprarenal, lumbal arteries, and from pelvic arteries, although we are not fans of proximal embolization of internal iliac artery, but if we can detect specific site of bleeding in a pelvic artery, we do that. Or if the preperitoneal packing fails, we also do pelvic embolizations, and also patients with thoracic bleedings when we go for intercostal artery embolization. So moving forward with those cases, which are the most interesting ones, small arteries. Here you see the patient with a car accident. That on a CT we see the pelvic fracture and also the bleeding perirenally and in suprarenal area. From a CT there is a suspicion for bleeding from suprarenal artery, and when you go for it in the angio room, we detect the bleeding from suprarenal medial artery. The catheterization is done by the 5 French USL catheter and supraselectively with microcatheter. And in these cases, when the anatomy is tortuous and your access is not so stable, we like to do the embolization with the coils which are detachable, because they offer you more stability, and also what is very important in trauma patients, dense packing of the artery, because as it was spoken before, if you do not achieve dense packing with coils in bleeding patient, you lose benefit of what you have done. The next case also the trauma patient with a blunt abdominal trauma and on anticoagulation. CT reveals the carotid artery syndrome in the left lumbal area. And when we go for endovascular, for angio room, we assess the lumbal artery. In this case, the stability of the access is not appropriate because there is osteostenosis of the artery, and we change our catheter to a 6 French sheet for a better stability and do embolization in indoor-outdoor technique, again proximally using detachable coils instead of pushable because it offers better stability. And another case with the lumbal artery pseudoaneurysm due to compression fracture of the vertebra. We again access the lumbal artery endovascularly, but in this case, if the artery is transected, sometimes it's almost impossible to do indoor-outdoor embolization. In these cases, you finish up only with the proximal embolization. And the last case with the patient with a polytrauma, there is hemothorax, there is bilateral pneumothorax, compression fractures of the thoracic vertebrae, and also we see extravasation in the right pleural cavity. The thoracostomy is placed, but still active bleeding comes out. And in these cases, you expect not only single artery embolization, but multi-level embolization, which of course takes time due to arterial anastomosis. And to conclude, I would like to say that to win the case quickly, you have to use the tools that you are most familiar with, then you will be quick and endovascular approach will be beneficial. Thank you.
Thank you very much. Congratulations. Questions from the audience or from the panelists? Okay, we have a few minutes, but I think that there are a lot of questions and of points that we can discuss. So, thank you, Aina. And the panelist debate is embolize these patients, proactive versus don't touch, conservative approach. What do you think, panelists? Is there a district I don't know, but I can't. I think that there are some situations in which we embolize without see any bleeding. Without, what do you think? In which situations and how, when, why?
I'll start. I want to talk about the liver specifically. I don't think that the choice is actually between open surgery and endo. If a patient's hemodynamically unstable, they belong in the operating room. But I think that angio and embolization can be a very useful adjunct to open liver surgery. Every time we've had success with this, it's because not only have we looked at the liver, packed it, then shot an angio, but rather than embolize to the point where you can no longer see extravasation, we're able to limit embolization until we don't see significant bleeding in the abdomen, or we see bleeding that we can control with packing. And so I think if you do that, your risk of hepatic necrosis is lower because you're not aiming for a perfect picture, you're aiming for a reasonable clinical result. So I don't think the distinction for hepatic trauma is embolized versus open surgery. I think that the two can work in concert.
Yes, thanks. There is sorry, Martin.
There is something that in debate, and it actually Professor Moore mentioned it also in his presentation, about a dogma that I think that we should think over it. Maybe it's the time to change the paradigm of the saying that unstable patient is not for angiography and embolization. For me, this is another tool, acceptable, also for to replace open approach. I mean, if you have a good trained team, you can take the patient to the angio suite. All the team is covered with aprons, lead aprons. You continue to give the patient the massive transfusion infusion while the IR starts the line and do all his stuff. And you continue with the nurse, with the anesthetist, everybody there, exactly like in the OR. So in severe liver injury, for example. Not the cases that the patient is collapsing in front of your eyes and you rush him to the operating theater. But he was relatively stable enough to take the patient to the CT scan, and you see massive, he kept his blood pressure, of course, and everybody with him, with the infusion running, and you see a lot of blood in the abdomen. It's not contraindication for me from taking him to the angio suite. It's more rapid to perform the access here and to get control over the bleeding, at least as good as or rapid as to open the abdomen, even if in my hands.
Yes, I think that the moment to change this paradigm is arriving, is not now, because probably the introduction of hybrid room will change this aspect, because it's very difficult to convince all the specialists, anesthesiologists that are the first actors in these situations to bring the patients and to put in the angio suite, even if you have a very skilled interventional radiology team. Federico question?
Professor Chiquet told us something that is really interesting. In my reality, we perform something like what he said, but differently. We use the operating room as a combined angio suite. So we took the patient to the operating room. If there is room to try to embolize without operating the patient, we try in that sense with the surgical equipment ready to operate. And in the case the angio and angiographist is not able to reach in a quick manner the embolization, we may operate immediately. But the patient should not be the one, as he said, is dying immediately in front of you. So something that you should have a small room to operate in order to keep the patient relatively stable, in order to have the angio suite, but not in the angio suite, inside the operating room, in order to have the second tool immediately ready to be used.
Yes, so with a portable CR.
I agree with that, but fortunately, But fortunately, it's problems of rich people, as we can say, that we have a lot of options today, and good clinical judgment is required in order to decide with all these options which one is the best for a particular patient.
Okay.
And with that, we are 10 minutes over our allotted time. So thank you, everyone. And coming up is session 5.
Thank you very much. Thank you very much. We will continue with the next session, and I think Kalle Wallgren is somewhere here, and he should be here somewhere. He's coming, and we will fight the time issues with the new tool. We will try to work on this. As you know, it's very intensive to try and keeping the time. We continue, and I'm not sure if Stefan Halun is online, but Kalle, the next section. And this is your tool to hold the time. Good luck.
All right, thanks. And so good afternoon, everybody. So let's, as Tal said, let's get started. So very welcome. The first speaker to this session is Anna Romagnoli, that is going to talk about landmark papers on imaging in the bleeding patient. So very welcome.
Thank you very much. So I have no disclosures, and I am just going to get right into this because this is a broad topic. So it's hard to talk about landmark imaging in vascular injury without talking about how we describe vascular injury. So just a brief review, the hard and soft signs of vascular injury appeared in the surgical lexicon in the 1984 edition of Rutherford's Vascular Surgery. And this was a bifurcation of a previously reported indications for immediate operative exploration that were published first in 1960. In addition to the hard signs listed here, penetrating proximity extremity trauma was also an indication for emergent or immediate operative exploration without preoperative angiography. Routine operative exploration of PPET patients persisted into the 1980s in spite of the fact that there was only a 25 to 50% positive exploration rate in the setting of penetrating proximity trauma. Freichberg et al. In 1992 reevaluated hard signs and concluded that they should be promptly explored in the operating room, and then went on to say that soft signs had no clinically useful predictive value for the diagnosis of arterial injury. And all of these papers leading up to this point were founded upon primarily observation and expert opinion, and they do not really suggest anything about the underlying pathology and operative exploration or additional workup. So the concept of exclusion angiography entered the scene and ultimately became the gold standard for evaluation of peripheral arterial injury in 1981. This was performed in patients without hard signs of vascular injury who had a high suspicion for presence of vascular injury. PPET patients undergoing exclusion angiography had a 10% incidence of injury to major arteries, but only a 1.8% incidence of injury requiring surgical repair. So essentially overdiagnosing injuries that were clinically irrelevant. This, in combination with the 1% to 2% false negative rate of contrast arteriography, led to a decrease in the use of exclusion angiography as the primary means for diagnosis. In the 1990s, Doppler became very prevalent. Doppler indices were shown to have a sensitivity of 95% and specificity of 97% for detection of major arterial injuries. Building on this paper with a subsequent paper 5 years later, screening arteriography was discontinued in patients with an ABI or injured extremity index greater than 0.9. And several years later, Conrad et al., followed by Sajati et al., demonstrated that it was safe to discharge asymptomatic PPET patients with ABI greater than 1 initially and then later greater than 0.9 without any imaging and without any inpatient observation. In the 2000s, CTA becomes reliable as a standalone screening modality for vascular injury. In 2009, Seaman et al. Published a really important paper where they prospectively compared CTA with either subsequent catheter-based angiography or operative exploration in patients with suspected extremity vascular injury and an ABI less than 0.9. They found that CTA had a 100% sensitivity and 100% specificity for detection of clinically relevant vascular injuries, and also there was a significant cost savings. So this cemented CTA as the gold standard for diagnosis of extremity arterial injury. This is a representative algorithm for workup and management of suspected extremity arterial trauma from the Western Trauma Organization. Hard signs, you can kind of see on the left side of the screen here, the majority of those patients are directed to proceed directly to the operating room, while soft sign patients undergo injured extremity index or ABI, and then if those are less than 0.9, they go on to additional imaging, and in most cases that ends up being a CTA. In our group's presentation from the AAST this year, hard, soft, and irrelevant, we found that hard and soft algorithms are not being followed in clinical practice. That in 40% of patients presenting with hard signs, CT scans were obtained before going to the operating room, and in 45% of patients presenting with soft signs, they were diagnosed at operative exploration. And again, these hard and soft distinctions do not suggest pathology, physiology, or outcome. This is our group's 2021 Journal of Trauma paper that preceded the hard, soft, and irrelevant paper. But we, using the PROVIT database, evaluated a very large number of peripheral arterial injuries and found that the hard, soft distinction had no difference in parameters associated with depth of shock and did not suggest any underlying vascular pathology. And they were, we then reevaluated the data using hemorrhagic or ischemic as the distinction between the two presenting kind of decision trees or algorithms. And there was a more consistent correlation with both pathology and management decisions. The hard, soft, and irrelevant paper then went on to show that there were differences in blood transfusion requirement and in his hospital mortality rate when patients were evaluated in that regard. As a result of this, we proposed an algorithm in which patients come in either in hemorrhagic shock or not. If they're responders with suspected extremity vascular injury, they go directly to CTA, which obviously we go into more in the paper. And then patients who are not responders and have hemorrhagic signs would go directly to the OR for exploration. Ischemic signs only, assess for other source of life-threatening hemorrhage, and then plan for damage control, revascularization as necessary. So in conclusion, this concept that our group has put forward that perhaps hard and soft signs are not the best way to describe vascular injury in the era of the ubiquitous multi-detector CT scan has been met, with some resistance in the community. But I think it's important to remember, kind of as we look back at the modern history of the management of peripheral arterial injury, we have, been largely all over the place, from exploring everybody to starting to do exclusion angiography, to using Doppler. Exclusion angiography is no longer favorable because we like Doppler more. We discontinue it altogether. Now we use ABIs and we scan almost no one and send them home. And now we decide that CTA is a gold standard for diagnosis. And if CTA is the gold standard and it's fast and effective, should we be using it more liberally going forward? Thank you.
Thank you very much, Anna, for an excellent review. So any questions from the audience?
Yeah, I have one. That was a very nice summary, Anna. I'm not familiar with the algorithm, but if your ankle brachial index is less than 0.9 and you're a partial responder because your SFA has been transected and you've got a large hematoma, then do you get a CT angio and then go to the OR and get your SFA fixed, or do you just go right to the OR because you have a penetrating injury with an abnormal ABI?
So we have not parsed out the utilization of ABI completely in that proposed algorithm. Patients who are non-responders, so if you respond enough to get your CT, then you have your diagnostic information. But if you're a non-responder with hemorrhagic signs, then we would recommend proceeding directly to the operating room. An area of further exploration would be kind of the presence of concurrent or sequential hemorrhagic and then ischemic signs. And does that mean the patient's sicker? Does that change the approach to the patient? So that's kind of in the works for something to look at going forward.
Yeah, I like that answer because, you know, in community practices, asking for a CT angiogram may cause unnecessary delay for an ischemic injury, where in larger centers, getting the CTA isn't a big deal because they're probably getting other imaging and it's very fast because you have the CTA in proximity, or you have the CT scanner in proximity to the trauma room. So I think it really depends on your practice location, but thank you.
Can you say anything about any benchmark times for the CT and, you know, time from admission to
I don't have anything. I mean, I don't have any objective data to report on that, but I think that that is definitely something to be looked at. You know, practicing somewhere like shock trauma where the CT scanner can be, you know, obtained, we like to say instantaneously, but probably in reality in a 10 to 15 minute time period, and then the operating room is ready to go. You know, that's a very different decision-making process than a place where the patient has to be rolled across the hospital and is left unsupervised, and then they get their CT, and then, you know, so I think that benchmark times, kind of in the same way that we look at cardiac catheterization or, you know, needle to balloon time for, or needle to embolization time for stroke would be useful parameters when we're kind of reevaluating this.
Hey, Anna, sorry, quick question over here. Great talk. So we're recently going to all CTA every penetrating extremity injury with normal ABIs because of a lot of early collateralization in young patients. And is that what your paper supports a little bit, or what are your thoughts there?
You know, I think that and these are in patients with signs of hemorrhage or signs of ischemia, or these are in patients who have a proximity injury? Yeah, so the paper did not look at proximity injuries yet, and that's, I think, another thing to consider. Ultimately, I think CTA is going to be the way that goes, because the proximity, and then defining proximity becomes a whole other issue in and of itself.
Is there any role for on-table angiograms in this, in modern trauma?
You know, I think that, again, this is very institution and resource dependent. You know, if you're at a facility with a hybrid room and you as the trauma surgeon are capable of doing an on-table angiogram, I think that simplifies the decision significantly. I don't know if putting a patient with a hemorrhagic vascular injury, even if they are a responder to their initial resuscitation, into the IR suite is the best plan. So I think that will also
maybe in a hybrid suite.
Yeah, well, if you have a hybrid suite, yes, but if you are going to, you know, if it involves going to interventional radiology or to a separate cath lab, that doesn't rapidly convert to. And then I also think that there's the other element that will come into play is, is this an isolated extremity injury or is this a polytrauma patient? Because I would be a lot more comfortable with an isolated extremity going to a remote location than, a high-speed MVC.
Okay, thank you very much. We can come back a bit more during the panel discussion. So next speaker is my colleague Per Skog from Gothenburg, who's going to talk about the use of hybrid suites and hybrid rooms for vascular surgery, benefits and evidence.
Thank you very much, Carl. I want to thank the organizing committee for inviting me here. Thank you very much. It's nice to be here. The use of hybrid suites and hybrid rooms for vascular surgery, benefits and evidence. Well, asking a vascular surgery to talk about hybrid suites, it's like having a sweet tooth talk about candy. But I'm going to try to be a bit formal as well. And I first want to describe what's a hybrid suite. Well, a hybrid suite is an operating room where you can perform all kinds of surgical procedures, and simultaneously you have ability to do advanced fluoroscopy. That's the definition of a hybrid suite. And is there any evidence that the hybrid suites are superior to operating rooms only? Well, no. There is extremely little research in this area. There is a few descriptive papers, one here by, for example, Mr. Holland, that describes the impact on different specific procedures in the hybrid suite, and they compare most with the retrospective data from the cath lab or the operating room. But if you search on PubMed on hybrid suite, you get a lot of hits, but it's only a few papers that really go into the hybrid suite. And there is one RCT and there is no meta-analysis. So the evidence grade for using hybrid suite is low, and that's not because it's bad, it's because people hasn't looked at it. This is the only RCT. It was a transaortic valve placement study, and they found that the only significant difference between using a cath lab and a hybrid suite is that you get increased radiation in the hybrid room. So, and I can see that because it's in most places hard to place the radiology or the radiation protection screens in the hybrid suites. So that's something for us to consider when we work in this environment. But nevertheless, we love those places, and that's because we have the ability to use all the tools available. It used to be like this. Most of us have experienced this. We are in an ordinary operating room. We are performing vascular surgery, and the flowmetry isn't really what we wanted, and we want angiogram in the end of the surgery, and we roll in the mobile C-arm, and it's low quality imaging with low quality assistance, and it's not beneficial for the patient. Nowadays, we perform our vascular surgery. It can be open or total endovascular, and we are in the perfect environment. We have better imaging. We can use preoperative images and diffuse to ideally lower the dose of radiation, and we can do our final angiograms, or we can evaluate the procedures with cone beam CT, and it's a total different quality of the procedure. There is a lot of tools gained with advanced imaging.
for these of you that don't work with this daily, fusion is having the information of a pre-op CT, for example, layered on the fluoroscopy pictures with the intention to be able to pinpoint vessels or osteums without continuous angiograms. And it has been extremely valuable, for example, when you put in branched stent grafts, but it's also very good for access in trauma patients if you have difficult vessel access in visual vessels in embolization. And there is in most the companies that do the products, they have guides. So there are embolization guides, needle guides, etc. This has opened up a whole new ability during vascular surgery. If I encounter a hostile groin, I really like to be in the hybrid suite because it can be solved with endovascular methods, but most of the time I need needle and thread as well. There is, of course, a lot of elective hybrid procedures that I wouldn't do anywhere outside the hybrid suite. And I will like finally to highlight this cone beam CT. It's simplified CT that can give you extremely good imaging, and it has improved the quality of the endovascular procedures, because you can have a final check that all the stent and stent grafts are in place, that you are not leaving the procedure with some major failures. Thanks a lot.
Thank you very much, Perry. Okay, you have to stay. Short questions. Anything from the audience? Any any preference? Should we have a table-mounted or the C-arm? Should that be floor-mounted or ceiling-mounted? Any preference? Pros and cons?
I've mostly worked with floor-mounted. It's a little easier to have radiation protection mounted in the roof. The roof-mounted C-arms, my impression is that it's harder to get good radiation protection. And if you can argue about that, but that's my impression so far. It has a lot to do with the local prerequisites, what the operating room looked like, and the stability of the roof, etc. But I think a floor-mounted is a very good option.
Okay, any more questions? All right, thank you very much, Per. Sorry.
Just one comment on the floor or ceiling mounted. I think that the best advantage with the floor mounted is that when you're going to do the open surgery, you can park the robot on the side of the room. So it's going to give you a lot more space if there are other people who want to operate on the patient.
The other reason I like the ceiling mounted system is we're constantly struggling with anesthesia. Even if you have familiar providers, someone changes over and moves a Pyxis machine or one of their circuits, and they're always in the way and fighting. So I like that for that reason, the ceiling.
Yeah.
Can I ask a question?
Absolutely.
We're encountering actually quite often that they have some kind of a breakdown. I'm not saying which company we have been using, but the devices every now and then they need service. So is that something that you experience as a problem as well?
I started up my career, I'm not that old, but I started out with a mobile C-arm, and we had to put ice on the C-arm in longer procedures, and they failed quite often. So with that perspective, I'm happy with the equipment we have today. But yes, there is quite a lot of service time on them. Most of the time it's planned, so it's more a logistic problem for the operating department. And I haven't experienced any, well, just a few failures during surgery. So that's not a main concern as I see it, no.
What do you think is a proper lifespan for one machine? I mean, there are $1 million or €2 million depending on. So what's the lifespan? You purchase one machine and when should you expect to renew it?
It's a really good question because it's a huge investment for the hospital. I think with the software upgrade, you should be able to prolong the lifetime of these machines a lot. And I don't know if the companies are cunning and try to limit the lifetime by not upgrading the software, because after 8-9 years, you have to do something because they are running out of time. But I suppose that you can have a quite old hardware and chase it up a little with software updates, so that it should be at least 12 or so years, I think. But it's a huge investment for the hospital.
Okay. All right. Thank you very much. We can maybe come back to more questions later on. Thank you very much, Per. So let's move on. Next speaker is Takahiro Kinoshita from Japan, who's going to talk about the use of hybrid ER suites with Gentry CT. Is it working, and is it worth the price?
Hi, everyone. So let me start. I am working as an AI researcher in Philips, but all of these studies were conducted before employment. And today I want to talk about the hybrid ER, which installed Angio-CT, consists of sliding gantry CT scanner and C-arm in trauma resuscitation room. So let me first share a video of severe pelvic ring fracture case that was treated in the hybrid ER. As you see in the video, we started a CT examination after 5 minutes from patient arrival, and we found multiple rib fractures and open book type pelvic ring fractures with massive retroperitoneal hematoma. In this case, we embolize both internal pericardial arteries and save the patient. And we have published an article in Annals of Surgery in 2019. It was single-center historical control study comparing the outcomes in the conventional ER group with those in the hybrid ER group. First, we found that the time to start CT scanning was reduced from 26 minutes to 11 minutes, and the time to start interventions were decreased from 68 minutes to 47 minutes. As a result, the 28-day mortality was decreased from 22% to 15%, and deaths from exsanguination became less than half. And the hybrid ER group was significantly associated with improved patient outcomes. And we received a lot of questions when we present these videos in international conferences. So let me ask two of them. Let me answer two of them. First, who should be the candidate, or who should be selected when, especially in mass casualty incidents with multiple patients? And to answer this question, we conducted a study to investigate heterogeneous treatment effect of the hybrid ER. And as you see in this figure, the adjusted mortality started to separate from at ISS of 25, and as you see, severe patient benefited from the hybrid ER. So currently, we recommend to use hybrid ER for patients with ISS more than 25. And there are criticisms that this the capital investment cost of $2 million are too expensive. So to answer this question, we conducted cost effectiveness analysis, and this is the result. So ICER, which represent the average incremental cost associated with one additional gain of quality adjusted life years, was $32,000 US, and which was lower than the willingness to pay threshold in Japan and also in the United States or other European countries. So we concluded that hybrid ER is not only effective, but also cost-effective health technology. So in summary, hybrid ER system shortens time to CT and interventions, reduces exsanguination, and decreases 28-day mortality, and it rewards the capital investment. So thank you for your attention.
Thank you very much, Takahiro, for this very interesting presentation. So questions? Yeah, we're waiting up there.
Sorry to talk all the time. Hello, Takahiro. Very good to hear a presentation. Pirkka Vikatmaa from Helsinki. I was a bit worried when I saw your video about the radiation protection of your personnel. We, of course, don't see the whole picture from your video, but do you measure it, and what measures do you take in the Raptor suite or hybrid ER suite to protect the personnel?
So actually, we haven't measured the actual radiological exposure yet, but like we usually avoid to go into the hybrid ER during CT examination. It's really rare to see a patient stand by the patient during CT scan, and of course we use protection gown. So that's the kind of regular management workflow in our hospital.
Okay, thank you. So we have Per, I think. Then.
Just a short
Okay,
one.
Tal.
Hi,
Tal.
Taka. This is Tal. It's very nice to have you online. Unfortunately, you couldn't come.
Yeah, I'm sorry.
Just a practical thing. Is this only for trauma? As usual, you're first in the world on this. But is it, we're getting the room, it's almost ready, the total hybrid in Örebro in Sweden. It's almost ready now, and we're thinking how to work with it. My question, is it only for trauma, or can you can use it for other things, but should we use it for other things? How are you using it?
The short answer is no. We use for many severe emergency patients. This is why we call it hybrid ER rather than hybrid trauma room. So I can show two videos in the later presentation. One is for OHGA and the other one is for postpartum hemorrhage. But like basically, we believe that this system is super effective for the patient who needs both CT examination and endovascular treatment.
All right, thank you. A final question, Per.
Thank you very much, Takahiro, for a nice talk. Reducing the time to a CT image, how much would you say is the new hardware, the equipment, the hybrid ER, and how much was the team training?
Oh, that's a really good question. So probably half and half. So to use this system effectively, you need a lot of training, not only doctors, but also like nurses, radiological technicians. And so like basically you do not need to transfer patient to CT room. So that's a kind of huge benefit, but it also like requires a lot of training to like get used to this system. So I really recommend to set up that kind of training system before you implement this system in your hospital.
Okay, thank you very much, Takahiro, and please stay online for the panel discussion later on.
Sure.
So next speaker is Martin Malina, who's going to talk about practical use of hybrid OR. Don't forget open surgery. I don't know if Martin has arrived yet, or...
I have...
Oh, here, oh, there you are, Martin. Great to see you again.
Great to see you guys.
Okay, very welcome. Go ahead.
Thank you. I'm trying. Wait a minute, this one.
You just popped up there from above.
Yeah, I made a mistake about time zones. I'm so confused now because I have been traveling and I basically mixed up the various time zones in the different countries. So I'm sorry. Okay. Thank you again for having me, and particularly for having me in this lovely town that means so much to me. Oh, sorry for the misspelling. That's not how the town is spelled. It's anyway. It's in my heart because this is where I went to school, and this is
Martin. We can't see your slides yet. Have you shared your slides?
Aha. I did.
I'll let you know when we see them. If you like share a screen or something like that on your computer.
Yeah, I did. Wait a minute. I'm trying again. I'm pressing the green button, share screen, and I'm pressing there. One more button, perhaps.
Oh, it's coming. Yeah.
Now it's coming.
Yeah, we see you. You see your desktop right now.
Okay, but how it's got stuck? I did press that before.
I know if you sometimes have double screens.
Can you see it now?
Exactly. Now we have the castle. See if you move forward. Is it? See if it's moving forward.
I think it will.
Okay.
So you see this.
Perfect.
A beautiful castle, and in this beautiful town. Sorry for the misspelling. And this was my school, one of the eldest schools in Sweden, with classrooms in the old king's stables. And this is the place where we had our first ball. And this is where I gave my first and only piano concert. Thank you for doing this for us, Tal and David and the entire team. And thank you, Thomas, for building such a great center of excellence in Örebro. Tal asked me to, can you hear me, everybody? Hello?
We hear you, yes.
Okay. So Tal asked me to talk about practical use of the hybrid theater and not to forget about open surgical repair. And this is a problematic area. I think that we need to accept that most procedures are endovascular nowadays, or at least can be. And if they can be, they probably should be, because it's a lesser trauma to the patients. I think that when you build a hybrid theater, it is a great advantage if you can build it such that you allow the purely endovascular cases to bypass the theater's area. So that for those patients, you actually can use the hybrid theater pretty much as an angio suite. Because in most angio suites, the efficiency, the turnover of patients would be much higher than in the theater's area, where everything seems to be much more sluggish. What we did both in Malmö and also here in London is that we have a special entrance to the hybrid theater. So basically we can run it as an independent angio suite without involving the theater's staff and anesthetists, etc. And I find that very useful. It is efficient and time-saving. Because the endovascular bit is so important, I would always prioritize imaging and equipment in the hybrid theater. Right now, I struggle with a hybrid theater where we have a motorized table, because this theater was built in a time when it was felt that major open surgery still will be a very important part of your business. That is very unpractical. The free-floating table is much more convenient, and the actual need for a motorized table like a Stiller table, I think, is not very common. Also, I have seen many places hybrid theaters with very poor opportunities to store all these extensive endovascular materials, and people then are running forth and back between other rooms and angio suites, etc., collecting materials for their procedures, which is clearly inefficient and nighttime even dangerous if you don't have the equipment at hand. But then Tal wanted me to say something about not forgetting the open surgical repair. Well, I think that the most important part when it comes to open surgical repair is to try to build a merged nursing team of both scrub nurses and IR nurses. I think that this old organization that we have with independent surgical staff and interventional staff is not appropriate for these days. It becomes very difficult to govern such two different pools of personnel. I think that by merging the teams and allowing them to share their skills, it makes life much easier, and it also facilitates governance of things like leave and working hours and on-call, etc. Right now I cannot advance my slide. Let's see. Yeah, I talked about the equipment and also another thing that this facilitates is the actual radiology equipment, the radiation, the ultrasound, etc. Now, this type of merged nursing team, I think, is great for the extremities, for the femoral cut down, for the bypass, for perhaps an AV fistula, probably also for the carotids. But the dilemma is, now I can't see my own text because something is superimposed, sorry. The dilemma is the open transabdominal and thoracic surgery, which becomes difficult when you have staff who don't have enough opportunity to practice that. As the indications for endovascular repair expand, this will have implications on the open surgery. There will be continuously less and less open surgical repairs as the endo repair expands. And every open surgical repair will be increasingly challenging because you will only be doing those cases that you cannot do well endovascularly. My estimate is that if you do, say, up to 20% of the aortas by open surgical techniques, then at most vascular centers, there will only be about 2 cases per year per vascular surgeon. And I don't think that is sustainable. I keep hearing, and we heard it also at this conference, people mentioning that certain procedures are being done to sustain or maintain the skills of open repair. And I think that this is, in my world, unethical. And instead, we need to reorganize our business. Somebody made the parallel to gastric ulcers. We don't operate on some patients with gastric ulcers instead of giving them the usual tablets, only to practice gastric surgery. And likewise, if a patient can be operated endovascularly in a good way, that should be done. And they shouldn't be operated on just to sustain a particular surgeon's open surgical skill. And to achieve all this, my belief is that the open major vascular surgery needs to be centralized quite aggressively, because otherwise each center will see too few patients and each surgeon will operate too few of these, the most difficult cases. So that is what I believe in right now. Hybrid theaters for the extremities and perhaps the minor open vascular surgery, while the major transabdominal and thoracic open surgery on those relatively few occasions when it will be needed should probably be centralized aggressively. Thank you for your attention.
Thank you very much, Martin. Very interesting as always. Any questions from the audience? We have time for one or two questions.
I have a question. Martin? Hello?
Yes. Hi, Simone.
Hi, Simone. I'm sorry, I'm in the car. Regards here. My problem is that not only are the surgeons doing less vascular surgery, but the staff, the surgical nurses and the anesthesiologists have very little experience with major open vascular surgery. And this has a great effect on the morbidity of the patient. The anesthesia teams that are not exposed to major vascular surgery, there's a very big problem in this area as well. So I also agree about centralizing. On the other hand, major trauma or ruptured aneurysms, it's not all about the vascular surgeon anymore. It's the whole team, which is deficient in experience for major vascular procedures.
I think we have to ask ourselves, what are actually the patients that you cannot treat endovascularly today, but that you can treat with better results by open surgery? I would like to suggest that they are very few. We had people claiming that it was the young patients that needed open surgery. I think one has stepped back from that. Then over a long period of time, it has been popular to say that infected aneurysms and aortovisceral fistula should be operated on open. And I believe that that is also being taken a step back from increasingly. In my world, I think that what the significant group that remains for open surgery are aneurysms and dissections that involve the aortic root. The aortic root is something that I feel we are very far from being able to attack endovascularly yet today. But the rest of the lesions, I think, on the majority of cases, can be treated endovascularly. And I've actually been asked repeatedly to give talks on the topic of that patients who are not candidates for endovascular repair are those who actually benefit from endovascular repair the most.
Okay, I think we have one more questions up there from the audience, a
Yeah,
short one.
So this is an ethical dilemma, I guess, and somewhat controversial, but, and I'm curious to see how people manage this in other countries. But in the United States, we often have multi-tiered sort of level of care where some patients who have private insurance can get a certain level of care, and other patients who don't have private insurance or don't have insurance at all and go to a county hospital get a different level of care. And oftentimes they don't have access to complex endovascular procedures, so they might be getting more open abdominal surgery, open aortic surgery, whereas if you go to a private hospital, you get a different standard. So it's somewhat ethical, a questionable ethics, and I worry about this, but at the same time, it is an opportunity for our trainees to learn how to do these complex operations and to do open surgery. I'm just curious if that exists in other places and what people's thoughts are on that.
Kalle, may I respond briefly to that? I think that if it's a financial incentive, then I believe that most studies in countries like the United States or the Nordic countries and Western Europe, the endovascular option is more cost effective than open surgery. Although the actual operation will cost less, the open operation, whatever you may gain there, you will lose out by longer stay in intensive care and longer rehabilitation of the patients after extensive open surgery, I think.
Okay, thank you. I think we need to move on. We can save the questions for the panels. There are so many more questions here, Martin, but we need to move on. Thank you very much, and welcome back, Anna Romagnoli again, who's going to talk about ultrasound and other tools for the unstable patient.
Hello, thank you again. Again, no disclosures. So point of care ultrasound in trauma has established itself in the form of a focused assessment with sonography for trauma as something that's commonplace. It is essentially designed to determine where you should make your cut in a hemodynamically unstable patient following blunt trauma. We look at the pericardial views to assess for pericardial blood, and then parahepatic, perisplenic, and pelvic windows to assess for hemoperitoneum. Using a curvilinear array or phased array probe, low frequency. And then the EFAST is in addition to the above, which utilizes a linear array probe to assess for pneumothoraces and hemothoraces. So this has been formally adopted as an adjunct to the primary survey by ATLS. A meta-analysis of 62 pooled trials showed a combined sensitivity of 78.9% and specificity for 99.2% for detection of intra-abdominal injury in the setting of blunt trauma. And in penetrating trauma patients requiring laparotomy, specificity between 94 and 100%. In addition, the FAST exam has resulted in reduced time to definitive operative care, decreased CT use, and decreased diagnostic peritoneal lavage use. The baseline ultrasound for trauma takes this concept a step forward. The point of the FAST exam is to assess for accumulated hemoperitoneum or hemopericardium, not to assess the parenchyma of solid organs. The baseline ultrasound for trauma is used frequently in the pediatric trauma patient population, and due to their relative decreased thickness of the abdominal wall and the proximity of their solid organs to the abdominal wall, they are great candidates for this study. Benefits of it are that it's available, no radiation exposure, and it has a high sensitivity for small amounts of hemoperitoneum. Detriments are that there's very low sensitivity for evaluation of parenchymal lesions when hemoperitoneum hasn't accumulated. So the next evolution of this, which is kind of over the last 5 to 10 years has been gaining popularity, is the contrast-enhanced ultrasound. This utilizes an intravenous injection of gas-filled microbubbles, usually with a phospholipid shell, in quick boluses. There's an arterial phase that can be visualized between 10 and 20 seconds to 30 to 40 seconds after administration. and then a venous or late phase that's visible for 2 to 6 minutes. The organs of interest are subsequently scanned, and the blood has enhanced echogenicity. So normal parenchyma will appear homogeneous and hyperechoic, while traumatic lesions appear hypoechoic. In some scenarios, you're actually able to visualize ongoing hemorrhage extravasation of microbubbles. So this is an important study done by Menicini et al. That looked at, it was a single center N of 73 evaluation of pediatric patients who presented with normal hemodynamics after a minor blunt trauma, and they underwent standard abdominal baseline ultrasound, contrast-enhanced ultrasound, and CT. And they found that the contrast-enhanced ultrasound was equivalent to multi-detector CT for diagnosing the solid organ injuries that they evaluated. And that in comparison to the multi-detector CT, the contrast-enhanced ultrasound had a sensitivity, specificity, negative predictive value, positive predictive value, and accuracy of 100%, which is definitely not the case with the standard baseline ultrasound. Here are some examples of what these studies look like. So the kind of first picture is a standard B-mode ultrasound image. The second picture is the contrast-enhanced ultrasound image, and then the representative CTs. So this is looking at a hepatic injury. So these appear as absent or reduced perfusion during the venous phase, which lasts for about 2 minutes. So you have 2 minutes to get all your pictures, or you have to rebolus the microbubble solution. This is a similar idea, but with a splenic injury. You can see on the standard ultrasound that maybe there's a little bit of irregular appearing parenchyma here, but then when we look at the contrast-enhanced image, you can actually see a pretty severe splenic injury that correlates quite well with the CT scan. Splenic lesions are best looked at in the venous phase, which starts 40 to 60 seconds after injection and lasts for 5 to 7 minutes. Due to the splenic sinusoids, the arterial phase results in a strange differential flow pattern that looks like zebra stripes and is hard to interpret, so they don't recommend you look at the spleen during the arterial phase. Renal ultrasound, the cortex enhances rapidly, and the medullary tissue is a little bit slower, but optimal time to visualize the kidneys is 30 seconds to 2.5 minutes. Each kidney must be explored with a separate microbubble bolus. And especially of note, if you're trying to exonerate the abdominal cavity for traumatic injuries, you are not able to detect lesions of the collecting system using this modality. So utility, no sedation needed. It outperforms conventional ultrasound. It can suggest the presence of associated vascular injuries by active extravasation. In low energy trauma in the pediatric population, it allows for kind of an intermediate level of diagnosis when you have a high suspicion for injury but are trying to avoid a CT scan. But by that same token, if a lesion is detected on the contrast-enhanced ultrasound, a follow-up CT scan is recommended for better characterization of the lesion and potential treatment planning. In the setting of high-energy pediatric trauma patients, the hemodynamic status of the patient should dictate the decision to CT scan versus operate, and the contrast-enhanced ultrasound has not much of a role that's defined there. I think the real promise of this technology is its potential to be utilized in a resource-poor setting or in a deployed military setting where you can have access to serial, relatively high-fidelity abdominal exams, which can help inform your medevac priorities and are repeatable by the provider if the provider is trained in doing so on site. Limitations, so cannot identify collecting system injuries, so there's still a little bit of a black box in the belly. Some of the papers describe difficulty in identifying active bleeding prior to the development of hemoperitoneum, that it can be hard to determine microbubble extravasation from parenchyma versus vascular tissue versus mesenteric tissue. And like all of our other ultrasound studies, it's operator and volume dependent. So if this is going to be in your toolbox, either you personally or your technologists need to be competent and use it regularly, and it does require a separate software package. So ultrasound is here to stay. Contrast-enhanced ultrasound is attractive for use in the pediatric trauma population. Unclear what the role of it will be in adults, but it is definitely something that I feel warrants exploration for the austere or resource poor environment.
Right, thank you very much. Any questions? Can start. So do you suggest this is more for the pediatric patients, or should we also consider to move on to the adult patient trauma patients?
I mean, I think that's where it's being looked at mostly, because in the pediatric world, there's some real reticence to expose children to ionizing radiation if you don't have to. Which I suppose is not the case at all trauma centers, but a combination of lab markers and urinalysis and an abdominal ultrasound that's high fidelity could, potentially take the need for CT scan off the table in a large portion of patients. And I think that it's definitely worth evaluating if, in the adults with American body habitus, for instance, if we are able to use this information the same way, is it as reliable as a CT scan the way it is in children? I definitely would have some questions about that, because I've done some work with the microbubble solution actually in the rBOA catheter to try to confirm balloon location. And, in any but the smallest cadavers, it's very hard to visualize even with the agitated solution, so.
Yes, go ahead.
Just curious, Jermaine at UNC, can this be done with relatively portable ultrasound technology and stuff? So I'm visualizing HEMS doctors in Europe potentially doing scans and stuff and forewarning on the way.
Before I started researching for this talk, I didn't know very much about this, so I don't believe that it requires a special machine. As far as it being able to be done on a handheld, butterfly or something like that, I'm not sure. Perhaps it's something that, you could dock it to a computer to do the image processing. But by the same token, I'm active duty military as well. So it's very interesting to me, knowing how much I enjoy having an ultrasound for hemodynamic assessment. If I can do my own CT scan in the field with an ultrasound, sign me up.
Excuse me. Final.
Only a comment, that's not a question. I think that the contrast enhanced ultrasound should be useful when you finish, for example, in an embolization and you are not sure that embolization was effective or not, because you real time you can follow the contrast enhancement, the arterial, the venous, and after the tardive phases, and you can see if there is an extravasation of bubble. I use it, for example, in these cases, and I use it for when I have adapted for iatrogenic lesions, for example, after percutaneous biopsy or percutaneous dermablation.
Do you use it at the time of procedure, or you use it as a surveillance method?
As a surveillance.
Okay.
Or before to finish the procedures. If I'm not
so
sure,
both.
for example, in a renal embolization, if I'm not sure if the bleeding is stopped, I perform it and I see if the bubble are outside the ring or not.
Okay, thank you so much. So next speaker is Patricia Ivanova. Is going to talk about the experience in Latvia, what has been done and moving forward in endo and hybrid bleeding management. Very welcome.
Dear colleagues, I'm Dr. Patricia Ivanova from Riga, Latvia. I'm a vascular surgeon. And I want to share our experience from a small country. Latvia is one of the Baltic states. A population, it's 1.9 million inhabitants, small country. And I'm coming from Riga East University Hospital. It's the largest hospital in our country. It's an emergency hospital, around 2,000 hospital beds, but of course, a lot of them are elective and acute. And it's a polytrauma center in Latvia. and actually covering whole territory of the country. We have a 24/7 trauma team, experienced trauma team, and of course we have a vascular surgeon on duty and interventional radiology, but on the daytime it is on site, of course, but on call in the non-working hours. Our trauma team is experienced. A team leader is a general surgeon. In the trauma team consists of the ICU specialist, experienced traumatologist, experienced radiologist, and as well could be invited specialist, a neuroradiologist, neurosurgeon, or vascular surgeon, or interventional radiologist. As statistics, we have around 400-500 polytrauma cases per year, and around 100 cases are severe trauma. For example, last year, 27 cases, we did first, like from our protocol, is extended fast, and then patient was immediately taken to the operating room for damage control surgery. Mortality rate last year was 3.5. A trauma management, we have a protocol, a trauma protocol, and of course, first investigation method actually extended fast when patients are in hospital period. And of course, we are very curious about rBOA. And actually, colleagues, I want to present you our first case of rBOA procedure. It was a 52-year-old male admitted to the emergency department in a deep hemorrhagic shock, in tachycardia, in a hypotension, and the trauma mechanism was body compression between wall and construction machine, and he admitted to hospital 1 hour after trauma. Patient was intubated, extended fast, large hematoma and lesser pelvis. It was a massive infusion and anti-shock therapy, but unfortunately stabilization of patient was not possible, and trauma leader called to us, to an endovascular specialist, and asking for a aortic occlusion balloon. Meanwhile, we was doing aortic occlusion balloon, a rBOA procedure. There was a lesser pelvis tamponade done on the site of the emergency room. And afterwards was a C-clamp for a pelvis stabilization, and patient was taken to the operating room. rBOA procedure, actually it looks nice in the books and here in the conference as well. It sounds very nice when we listen. It seems very simple, 4 steps and it's done. But these are pictures from our case, and it was even for us, we believe as well, we are already experienced specialists, quite challenging. In real life, in the morning we talked about puncture. First we puncture without ultrasound. Then we involved the ultrasound. And even with ultrasound, a non-stable patient, actually without palpable pulse of the femoral artery, okay, with a second attempt of a needle, we can puncture an artery and had access. Then we was very happy, we advanced a G-shaped Amplatzer guide wire, but actually it was not so easy to advance and not further to umbilical level. We was very frightened, and then we did a fluoroscopy control, but yes, we are in aorta, and we decided to place a CODA balloon. Then there was no going through 12 French sheet, but in end we did a CODA balloon, and it's all take for us a total time, because in our protocol every procedure are strict times, 11 minutes. A patient was stabilized, and we was very happy, and the effect of procedure was, and we could take it to the operating room. Then it was done a C clamp for a pelvis, and patient was taken to operating room. In a operating finding, it was actually there was no anterior body wall at all. There was a multiple mesenteric root ruptures and devascularization of the small intestine. And we already was moving to 1 hour exposure of our balloon, and we deflated it and removed it. Despite the tissue tamponade, abdominal tamponade, patient repeated picture of hemorrhagic shock. We tried to mechanically press the aorta, And we decided, trauma leader decided to do a total tamponade of abdominal cavity, and patient was taken to the intensive care unit. And fortunately, this is a case not with a good ending. It's not like a fairy tale. It's usually like as now as Congress, maybe not a Congress case as well, because patient died in an ICU unit, and in total, he was in 14 hours in the hospital. We as well was participating in the forensic examination, myself as well, and we was happy that there was no damage or dissection of the aorta found. Our conclusions and maybe discussion. A hybrid operating room and C-arm equipment is very important, and we believe it's very helpful for us, doctors, and for patients, of course. But we can't forget about specialist resources as well. Yes, about reboa procedure, we believe that the aortic balloon occlusion, it's temporary method promoting hemodynamic stability. But who performs reboa procedure in your countries? It should be a well-trained specialist in endovascular field in the right place and in the right time. Thank you.
Thank you very much, Patricia, for sharing your experience. Questions? So what kind of facilities do you have at the moment? Do you use the C-arm in the theater, or do you have access to a hybrid suite?
No, we don't have a hybrid suite. Yeah. And in operating room as well, we have only an X-ray machine. We don't have a C-arm.
So you don't have a C-arm.
Yeah.
You can't borrow from the orthopedics or anything?
No, we can do it from orthopedics. We can borrow it. Yeah.
Okay.
But it's not a very good quality of image.
Okay, I see.
But I have a question, for example. We have a very good trauma team, and who do a reboa procedure? Because at night, it's impossible to do this procedure, because a vascular surgeon and interventional radiologist is on call. Is it trauma leader who do it? Our trauma leader, he's an excellent general surgeon. He do plenty of things, but actually he's not as skilled in the endovascular field.
I suppose you can have different opinions from the audience here. Maybe we can discuss that because I think everybody that includes in trauma, from trauma surgeons to IR to vascular surgeons to acute care physicians, anesthesiologists can probably do this with the right training, but it's of course open for discussion. Okay. So maybe we can come back to that question, because I think maybe that's going to be probably covered during the program here. So thank you very much, and please stay for the discussion. I think we have the last speaker, which is Stefan Haulon, Paris. He's online.
Hello there.
Hello, Stefan.
Can you hear me?
Very welcome. And you're going to tell us a little bit about the angiography suites and what a view of heavy use and future perspectives of the angio suites. Very welcome.
Thank you, Kaf. Nice to hear you, and sorry again that I cannot be with the dream team here in Örebro and with all my friends from Sweden. Let me try in 6 minutes to talk about what I expect from the hybrid room, having in mind that don't trust anything I say, because I'm a consultant for GE. The hybrid room is really the best of the open world and the best of the imaging world, and all that is gathered into a single room, which is called the hybrid room. Obviously, I will talk about latest generation with flat panel technology. And what is interesting with those most recent rooms is that there's the option to really move from the open world to the endo world quite easily. And you can see here we're in an open mode. Here we're working on the axis, performing a conduit to the iliac. The setup is a real open room with a laminar flow and with the best light and everything that you would expect. And what is also very important is that in those rooms you need the anesthesiology to be able to work safely. Sometimes we also need a pump for some of those complex cases. So you cannot expect to be able to do all those complex cases in a very tiny room. You need, of course, to have all multidisciplinary team with a working space within that room. What is very important in my mind is when we had the discussion this morning or during my previous talk is that you can use all advanced imaging modalities from table side, or at least that is the workflow is user-friendly enough so that anyone can use it 24/7. It doesn't make any sense to have a system where you need 2 PhD on the workstation because this will mean that when you really need those advanced imaging applications in the middle of the night, there's no one to help you. So what is interesting about 3D imaging is that it will help you to select the appropriate patient and to plan the procedure, including planning the endograft or the stent or the coils or whatever you're going to do. It's going to guide you throughout the procedure, for example, with the fusion mask, and then it's going to help you to assess the technical success of your procedure with 3D imaging with a cone beam CT at the end. Just to show you here insertion of the endograft, and you can see on the left side without fusion and on the right side with the fusion. Again, here is opening an endograft without fusion, and then on the right side with fusion. And you can see how this augmented reality is a real game changer. It completely changes your perspective. You don't need to inject contrast many times. It reduces the need for contrast media. And altogether, it's a much swifter workflow. Now, I told you that at the end of the procedure, we do a 3D imaging to assess technical success. At this stage, everyone moves away from the hybrid room, and then again from table side, we can check that there's no leak. If it's a ruptured aneurysm, you want to make sure there's no type 1 endo leak. And if there's anything that is not perfect, you might fix it right away. And the cost of doing a cone beam CT is very low. You can see that just adds 7 to the AP, 7 gray per square centimeter. This is the type of image you get with the cone beam CT 3D reconstruction. So it's CT-like reconstructions, and it can be very helpful. For example, in this patient, fourth and endograft, everything looked good on the 2D angio, but there was a crush of the left renal stent, and I could fix it doing another cone beam CT with the patient lateral. What we did is the cone beam CT helped us to do a fusion with the pre-op CT in order to use another advanced imaging application, which is the needle guidance. So you can see the system selected where I needed to puncture the back of the patient, and my target, which was here a large endoleak, and you can see that guided by the system, we went directly into the endoleak and could embolize it with a coil and glue. And here in a patient where we had a kinked renal artery, we could directly puncture the renal artery, kinked renal artery stent. We puncture the renal artery just distal to the stent, advance the wire back into the aortic lumen, and then over this through and through wire, we managed to reopen that kinked stent. Other advanced imaging application for other specialties, for example, here the TAVR cases, you can see calcification enhancement, and there are specific tools for every type of procedure that one will perform in the hybrid room. And I would like to finish quickly by telling you how efficient those later generation hybrid room are in protecting you against X-ray. Automatically, the system will position the flat panel you can see here on this video against the patient to reduce as much as possible scattered radiation. Then if you work lateral, you will have warnings telling you, be careful, in this position, you're increasing significantly the amount of radiation that is required. You can work in very low dose protocol and still have a great image. Having said that, if you don't see what you need to see, you can switch to a better protocol and switch back afterwards. Also, by having a large display monitor, you can use digital zoom and combination to also decrease significantly your exposure to radiation, and also use fluoro loops rather than DSA you have to realize that one DSA image is approximately 500 fluoro image. And I think what is very important for the future is to integrate all imaging into the system and to be able, I told you, to include the pre-op CT for fusion imaging, for example, for complex dissection, but also to include 3D ultrasound or any type of augmented reality setup will be included in the near future. This slide is from GE, but it's just to show you that they're working on various solutions for the next generation hybrid rooms, and that kind of summarizes everything I told you, including neuroergonomics and robotics with the 3D logo augmented imaging. Again, the hybrid room in the near future will be completely different from what it is today. So I think we need those equipments if we want to be performing those procedures in a very swift workflow and to protect ourselves against radiation. It will improve the technical success. And but having said that, it's a new field, and we need dedicated training for our young ones to make sure that it's not. You know, when I use my iPhone, I use 5% of its capacities, and we want this to be the opposite in the hybrid room. We really want people to be able to use all those advanced imaging applications 24/7. Thank you very much for your attention.
Thank you, Stefan. And questions from the audience? So I can just start off. What do you think about radiation, Stefan? And are we moving away from that in the future? And it will be like GPS. Why you do everything with a GPS system instead of X-ray? Is that the future, or what do you think?
I fully agree, and we have technologies that are almost ready. One is already released, which is the force that Philips is providing with his hybrid room. It's optical lumen. The other one is electromagnetic fields, which are not its way, but currently it's quite cumbersome and it's not user-friendly, not easy to integrate, but it is really making huge progress. And I'm sure that, sorry, 3D ultrasound will also be one of the technology we'll be using soon to guide us in the hybrid room.
Thanks, Stefan, for a nice talk. We earlier had a question about ceiling-mounted or roof or table mounted, floor-mounted fluoroscopy equipment in the hybrid room, and you were pro floor-mounted. And do you know if there is any articles or data on the radiation dose?
Oh, radiation, I think, is really due to the hardware and the various advancing imaging application that you're using. I think the people that are driving your choice between floor-mounted and ceiling-mounted are the hygiene team from your hospital. For example, in my previous hospital in Lille, there was really no debate because we were also doing open heart surgery in this room. They were not open to any kind of discussion. They wanted a floor-mounted system to make sure that we had no rails and the setup was similar to a usual OR room. Having said that, I know that the ceiling-mounted system now can integrate also laminar flows and things like this. So I don't know if we have data to support one way or the other, but what I know is hygiene people can be a pain and have a real impact on the choice at your hospital.
Okay, any questions from the audience? Okay, thank you so much, Stefan. Great talk and good seeing you again. So I think we maybe have a couple of minutes for the debate. Should we ask the panelists to come down down here to the podium? Maybe it's only you and me.
Yeah.
Maybe the rest maybe are online. So let's open up. We could just spend a couple of minutes. I know it's coffee time soon here, but maybe we can just very briefly. So the question is, is hybrid suite the place to be, or is it good enough with surgical suite with C-arm? So maybe the panel can just maybe start out. Is there anyone who's using the surgical suite with a C-arm? Have they been so much improved in recent times? So it's maybe good enough for at least for the trauma situation or even for the vascular situation. Does the panel have any thoughts about that?
I have some experience. There is a lot of county hospitals that haven't got access to hybrid suites that use modern mobile C-arms, and for sure the radiation dose isn't really a problem anymore. So modern mobile C-arms can have comparable radiation doses as mounted C-arms. So that's you must be. It's a reality. Everyone can't have access to hybrid suites, and you can do magical numbers without that.
Yes, Martin.
I think that Stefan just mentioned a very important thing, namely that the room should be set up such that the operator actually can maneuver it himself. And I'm saying this now working in a country where the majority of operators don't maneuver the equipment themselves. And I see, the way I perceive it at least, very many disadvantages of that. So whatever equipment you use, make sure that you as operator govern the instruments and that they are at your hand and you know how to use them. Because otherwise you will get tired of instructing people what projection you want to use, what frame rate, what radiation, etc. And then you will start using suboptimal imaging and you will start making mistakes.
I would like to comment on the ZIM we use in our operating room. We are using the ZIM hybrid room on wheels, which also gives us excellent autonomy on our equipment as well as less radiation. And we have built a little mini hybrid room in our OR room with all the radiation guards as if we were in the hybrid room, which is not always available for trauma and our surgical cases. So I think we have the best of both worlds, and with a room next door with all the equipment that we find necessary in the OR. I also wanted to make a comment to Patricia from Latvia. We also have a big discussion in our hospital about who is supposed to do the rebar implantation. In our hospital, the vascular surgeon has the honor of doing so with the trauma team. Too many possible complications if the vascular team is not involved, and it's usually the senior vascular person on call.
Very good. Going back to the suites, I sometimes struggle a little bit in our hybrid suite with the table. Sometimes it's a bit too wide. Sometimes you can't, or if you have a preference towards more an angio radiology table as we have, you can't break the table sometimes because you need that for some exposures. If you're working up at the neck, for example, when you do your endo procedures. Any comments from the panel, or can operation theater tables be more optimized than they are today? Can we see something in the future coming?
We have a floating table with the possibility of breaking the neck to change the direction of the neck. So I believe there are, don't know exactly what in your country, but in our country we have the possibility of having the floating table for the OR, and it's excellent option.
Okay.
Perhaps one should mention, since we are largely in Sweden, still a mobile free-floating table, which I think is an interesting solution to some hospitals. Even if you have a hybrid theater, it may be practical to be able to bring a free-floating table into some other theaters as well.
Could I add one recommendation? That we should pay more attention to the rails, because there are times when you might want to use a self-retaining retractor. And also pay attention to the extensions, because there are times when you want the patient more northward on the table so that you can image down at the feet. And these are things that we really have to be involved in when the room is set up for us in a trauma situation, because a lot of times we're reviewing CTs and doing other preoperative planning, and then the patient's already positioned on the table, but the arms aren't tucked, or the head's not far north enough, or there's no rails. So these are good things to think about.
Good comment.
Touching back on the original discussion, I think the question of hybrid room versus C-arm, it depends on how old your hybrid room is and how new your C-arm is. Because a lot of times in the newer C-arm, you can get very high quality pictures. And if you're, simply shooting a runoff study, a C-arm is probably more than adequate. But I found that, when trying to do interventions with a C-arm, your inability to kind of track where you are as you move the C-arm or automap back to the same location results in more radiation exposure and extra contrast load, because you can't, automap back to where you were previously.
All right, there were some comments, maybe some final comments from the panel before the coffee.
Well, to summarize, I would just say that I think it's extremely important to have dedicated training in the hybrid suite. It's not the same thing as an ordinary OR, so you have to train the team. I think Martin had a very important point with merged nursing teams to be efficient in the room.
I think for the sake of, okay, we have final, Gene.
Yeah, let me quickly give some comments. So, I'm actually an advocate of hybrid ER rather than hybrid OR. So, and the biggest strengths of having CT in the trauma theater is that you can easily exclude traumatic brain injury. So, like, you can quickly start bleeding control surgery under general anesthesia. So, yeah, you may love it to have if you have that system in your trauma resuscitation room.
Right, Gene.
Well, I just wanted to comment on the question raised, who should be doing RAAA? And I think the crisis is escalating in the United States. I'll just speak from our situation. If endovascular trauma management is going to continue to save lives, then we have to be colleagues and train whoever's going to be there 24/7. Now, frankly, Tal's brought us all together. We're great friends, whether interventionists, emergency physicians, surgeons. But the fact is, that's not what happens in the United States, most of our individual institutions. We have territorial TERFs who has access to the room, who has access to the equipment, and that has to end. And the problem is that's now enhanced because in the university centers, where everyone is super specialized, there is no general surgeon capable of taking care of trauma, because none of those general surgeons actually do any surgery other than laparoscopic cholecystectomy. So either we've got to train and demand that vascular surgeons be in there with us all night long, or the vascular interventionists have got to train the general surgeons taking trauma call to be capable 24 hours to at least temporize till the air team can get in. But we've got to change the paradigm, because in the United States, as you know, over the last 5 years, the mortality for trauma has actually increased despite the public proclamation of no more preventable deaths. It's actually gotten worse.
All right, thank you very much. I think we have reasons to come back to this discussion even more during this this conference. So I think it's time for coffee. Sorry, we're running a little bit late, but thank you all the speakers and the panel for great talks and good comments. So thank you very much.
And please visit the exhibition, and it will be get together here in the evening. I think you would like it, so I think you should stay. The last session will be in some minutes. It will start on time. Take your coffee and come here if you can, and join us this evening, and I think it will be fun. I hope so. Thank you. Here, it will be here in the exhibition area.
Yeah, no, I hadn't realized.
All right, ready to start? Great. Okay, so welcome to session 6, last session of the day, hot topics in endovascular resuscitation for the non-trauma patient. Now, Jim, we're going to have to work a little bit quickly because there's a party later, so we have to make sure everybody gets to that.
Sorry.
So I'm Saf Kassim. I'm an emergency and critical care physician in Philadelphia, and my co-chair here is Jim Manning from UNC, and we were meant to have Lionel Lemho here in person, but he'll be joining us on Zoom. But just to represent him, I've got a SAMU mask on, so it's all good. All right, Jim, so quick question for you. A cardiologist and an emergency physician walk into a bar and give us a talk. So I guess it's the cardiologist that's going first. Paul Reese, over to you.
Thanks very much. So I'm going to talk now about vascular access in the arrested or peri-arrest patient, how to do it, and tips and tricks. So I think the first thing is you've got to have the right operator. I think people doing this need to be competent at overall patient management, but also able to delegate. Because if you're going to go and do this, and certainly in the pre-hospital setting, you're going to be pretty focused at getting access. You can't manage the scene. And pre-hospitally, we think a team of 3 is good for this. 2 physicians, 1 critical care paramedic. With all the equipment to hand, we'll talk about that shortly. I think your background is unimportant, but don't forget that you need to train. When we set up the military SOP, it said 1, get 8 French access in the groin. Then I realized I'd done hundreds of them and nobody in the room had done any of them. So you need to train. So in the UK, for both our pre-hospital service and for the military service, we aimed to blend the best in our training program from the EVTM workshops, the peer course at the Royal London Hospital, the UK Reboa trial program, the Paris ECMO rescue course, we took some bits from that as well, and your excellent Raptor course, which I came to in Houston. So to take the best bits and blend them and aim to provide a package for our people to sign them off to provide safe and effective Reboa using whole team training and complex sim. So we start off, you need to know some anatomy. I'm not going to labor the points here. We spend quite a bit of time showing them quite a lot of video resources on Seldinger access and showing them anatomical correlations. And we then move on to, if you can just click on that file, please, that would be great. So we then use the femoral line man simulator. You can see there, needle's going to enter from the top right, and enter the vessel. And we get our people to do this basically one-on-one, mentored with a trainer. And it's actually a pretty good, it doesn't have a bifurcation, but it's a pretty good trainer. See the wire coming any second now. There we go. We then escalate. This is some military training here. We do some simple task-based stuff to get them used to the kit. And then on the right-hand side panel, we do escalating complexity simulations with multiple patients presenting at the same time. So on the right there, we have a Navy team being trained. Training, I think, is absolutely key. At East Anglia Air Ambulance, we think there's probably a need for us to target therapy after ROSC from cardiac arrest or during CPR. We think there's probably a coronary perfusion pressure threshold below which you won't get ROSC. And as part of that, we needed a safe arterial access program, which is ultrasound guided. We train a cohort of our staff to get safe access into common femoral artery and femoral vein. And the aim of this is to build expertise within the organization and future-proof us for providing rAAA or providing eCPR in the future. So here's the equipment. Get the best you can afford. This is our spear bag. It's like your rAAA to-go kit, Tal. In there is everything you need to do the imaging, drapes, skin prep, 4 French sheaths, 7 and 8 French sheaths for venous access, and sutures and ancillaries. It's a bit bigger than I thought it was going to be. This is why. On the left-hand side is the sterile pack that we designed. It's actually got a cath lab size drape. It's a bit too big, and we'll make it smaller with time. And on the right-hand side, you can see everything you need to clean and prep the groin is in there. The ultrasound is in there. And even little things like you're going to need to flush the arterial line. So it's there, taped onto the transducer set, ready to go, so that one person can just get busy in the groin and nobody else has to open all the other pouches and give them kit. This is what it looks like inside. So we've got a 4 French SMAC, Minimac Merit set, and a 6 or an 8 French Merit Prelude set as well for venous access. This is the military rAAA kit. That's what it looks like on the outside. And on the inside, it has everything you need, including a reminder card, because if the wheels fall off, you'll forget everything. So there's a laminated reminder card. There are 2 ER rAAA catheters, because you might drop one or one might fail. And then there are all the access, bits of access kit there, all in one place in a logical sequence. So for imaging, we've gone with the Butterfly IQ. Okay, if you can click on the right-hand side panel as well, this allows us to do all the other scanning we need to. So we can do chest, we can do EFAST, but also you can see on the right-hand side panel that is live biplane imaging. So you can do longitudinal and short axis view of the vessel. Okay, and that's what it should look like in a lovely, neat and tidy simulation setting. Why are we doing this? Well, there are some AHA guidelines that you should try and get a diastolic blood pressure above a given threshold. There are some places in the US that do this, and we've written this into our SPEAR, so Specialized Percutaneous Emergency Aortic Resuscitation algorithm. Basically, do decent CPR, get access in the groin, and do something to make the coronary perfusion better than it is. I'm going to show you some cases now. These are exclusively pre-hospital. This is a man in his 30s in PEA cardiac arrest with some intermittent cardiac activity in ROSC. So to help us guide, you can click on the left-hand side panel. That's the vessels you saw earlier. Okay, during mechanical CPR, click on the right side panel for me as well. So that's us getting into the groin during CPR on a kitchen floor, half underneath the table. It is not as straightforward as doing it in hospital, but you'll see a needle appear on the right-hand side and go into the lumen. We're able to use that to get a 6 French sheath in to help guide our optimizing his blood pressure and getting him out, so getting his ROSC more stable. It's not great, but it's, that's the reality of doing it pre-hospital. Got another one coming up now. This is a patient, click on the left-hand side panel, a 65-year-old man post-ROSC, so that's his heart beating there. Click on the right-hand side panel for us. His blood pressure was unrecordable, so this is me looking in the groin to find his vessels. You can find a vessel in cross-section there, and then we're able to cannulate that. This is the long axis, click on that for me as well. So this is long axis view, lovely images actually of his femoral artery. You can actually see the bifurcation on the right-hand side of the panel, and you should hopefully see a needle appearing from the right-hand side. It's not a brilliant image, and at that point it enters the lumen and I get rid of the probe. Okay, and this is the guy who, I think it is worth doing what we see on the right here, which is a wire sweep. So once you've got your wire in the vessel, I think it's worth doing a longitudinal sweep to make sure the wire is actually in the lumen before you dilate it and put your sheath in. And we were then able to secure that, get his blood pressure up to 80 rather than 40, and get him out the house and off to a PCI center. This patient here had bilateral CAT tourniquets on, pressure dressings on his neck. He'd slashed through both his radial arteries. And initially, my plan was only to put a femoral sheath in to give him blood products at the scene, unrecordable blood pressure. But actually, you can see on scanning his groin, that artery is actually quite easy to see. And we managed to get in there. And this is the image of him being accessed. Click on that for me, please. So in there, blood pressure was 40. And then after some units of red cells and lyoplast, his blood pressure then came up to about 70. We're also able to use that for ABG analysis. pH there, 7.2. Hemoglobin from the saline he'd been given was 7.8. So it does tell you how sick they are. There are other utilities other than just pressure monitoring. And that's him on his way to hospital with a MEQ warming device here, giving him warmed blood back into his femoral vein. Okay, and this would be in Paris an ECPR case, but we don't have ECPR available. So this is a patient he's got right femoral arterial and venous access. That's a mitral pump you can see there, which is squirting in adrenaline at 1 mic per kilo per minute. It's an infusion. And actually shortly after that, these are his pressures during CPR, 134/25, not quite a good enough diastolic, gave a bit more adrenaline and actually got ROSC. And then we're able to use our arterial access to monitor him in the helicopter on the way to the primary PCI center. Okay, I've shown you that already. Top tips, if you can click on that. We put the 4 French Minimax set in there because we thought it was safer, but actually the wire is straight. The 035 wire in the bigger sheaths will deflect out of the little vessels, but it's possible to put the 4 French one into one of these iliac circumflex branches here. Can you see that? That's where the tip of the 4 French sheath is. So that's my only caution is if you're going to use the small devices, you probably need to know where they are. Easy with fluoro, less easy pre-hospital, but the wire won't go when you try and put it through if you do that. So easy in the cath lab, we just pull it back into the main lumen. Top tips, get everybody in your service doing arterial lines. So everybody's used to running through transducers, zeroing them, interrogating invasive pressures. Scan every groin you can for practice in and out of hospital. Talk to your receiving units, because if you rock up with a load of stuff hanging out the groin, people are going to want to know why. Get properly trained. Be brutally honest with yourself about ultrasound guidance. I see a lot of people with the probe here, looking down here, not at the screen. You've got to really do it on ultrasound guidance and review every case. The other thing I've not mentioned here is have a plan B. There is another groin, or have an open technique at your disposal if you need it. Quick scan of that if you have 5 seconds. The vascular access management and closure stuff by the American Society of Cardiovascular Angiography and Intervention isn't bad. The first few pages of that are actually quite good if you're setting up a program. Okay, great. Thank you very much. I think I've spoken enough. I'm going to stop there and take any questions. Thank you.
That's great. Thanks a lot, Paul. Any questions from the audience? Yeah, Jim, you have a question?
Paul, my question is before you do the ultrasound, obviously you're trying to use ultrasound guided access, but do you assess the anatomy, just sort of typical landmarks first, just to try to get a sense of where the artery is before you start? Probably more important in obese patients where sometimes it's difficult to tell where, but.
Yeah, if they're big, you might need somebody just to remove the abdominal stuff out of the area. I tend not to feel, because I don't find it very helpful now. I just put the probe on and look with that and identify where I am with the probe. So I tend not to do what I used to do, which is put my hands on and do it by landmark. I tend to just go with the ultrasound now.
Okay.
Paul, I have a question. So lots of different people here from different systems. There's always a challenge about skill dilution. So should you train a small group who will do this frequently, or should you train a larger group who may do this infrequently?
Yeah, it's a very good question. So we started with a small group initially of more senior consultants. We don't generally get the trainees in the service to do this. It needs to work well. We need to not have leg complications. So we've honed our training on people who A, want to do it, and B, turn up and do a sort of familiarization program. So yeah, a smaller group first to grow it, I think, and then roll it outwards.
Fantastic. Anything else from the audience?
That's it.
All right.
Lionel.
Oh. Lionel?
That's sure. Just a comment. I think the major, as you said, the system is very important. And one of the major part of the knowledge we need to have is if your system, depending where you are, the level of care change or not. For example, if you are in Paris or London with HEMS, the level of care is the same in hospital or out of hospital. In my unit, we are able to do ABG, everything. The second question is the level is different between out of hospital and in hospital, change really all the mind if you can have an access or not on femoral way, because we have not sure the good person to do that.
You know, great point. All right, so I think we'll move on to the next talk. Emmanuel Dogan is talking about endovascular occlusion methods in non-traumatic cardiac arrest.
Thank you. My name is Emmanuel Dogan. I'm a resident here in anesthesia and intensive care.
and I'm going to talk about endovascular occlusion methods in non-traumatic cardiac arrest. And I have to also say that I am the anesthetist on call tonight, so after my talk, I have to go directly to the hospital. No conflicts of interest. Out of hospital cardiac arrest, poor prognosis. Only 10% survive, and most of the cases are by a non-traumatic cause. And what we do to improve this bad prognosis, we think that the higher CPP, coronary perfusion pressure, is correlated to the ROSC. And what about rBOA in non-traumatic cardiac arrest? There are some previous experimental studies that show that rBOA increases the coronary and cerebral perfusion pressure and blood flows, and also increases the rate of ROSC. And there are some fine case reports that all show beneficial effects of rBOA in non-traumatic cardiac arrest, and this review state that rBOA has a potential to revolutionize the management of cardiac arrest. But what is the optimal occlusion level during CPR? We have studied this in our animal lab here in Örebro, and we've done some experimental studies. And there we have divided zone 1 into 3 different subzones. So zone 1A is above the heart, zone 1B is behind the heart, and then we have zone 1C, which is below the heart. And we have performed animal experiments where we have induced myocardial infarction and cardiac arrest with a occlusion of the left anterior descending artery. And then we have performed CPR with Lucas, and then we have inflated the rBOA. And we divided animals into 3 different groups. One group got the balloon in zone 1B behind the heart, and then one group got the balloon below the heart in zone 1C, and then we had a control group. And we saw that we increased significantly the blood pressure when we occluded below the heart in zone 1C. And why is that so? Why shouldn't we inflate the balloon behind the heart? Our hypothesis is that a balloon behind the heart, this is the left atrium and left ventricle, this is the aorta, will interfere with the pumping and filling of the heart during CPR. This is the sternum, so one can think that when you press the heart against the column vertebra, you will get mechanical interference if the balloon is inflated here. So rBOA should be placed in zone 1C. But what about the visceral circulation? Is it possible to achieve the same circulatory response but with a sustained visceral circulation? So we have also compared zone 1C against zone 3, but we didn't see any beneficial effects of zone 3 rBOA. So in that study also zone 1C was superior. So we think that the optimal occlusion level during CPR is in zone 1C. It should be outside of the compression field, not like in this picture. And this could also be in traumatic causes of cardiac arrest also. And now there are 4 ongoing clinical trials globally, so it will be very interesting following these. And do we have to have a continuous occlusion of the aorta when we perform CPR? Because when the patient achieves ROSC, the rBOA will substantially increase afterload and oxygen consumption of the heart. And this is a major risk factor for re-arrest. So therefore, we have also studied the use of intra-aortic balloon pump during CPR. And this is the most used device in cardiogenic shock patient. It's a counterpulsating balloon. It inflates during diastole and deflates before systole in spontaneous circulation. And this, so it increases myocardial perfusion and reduces afterload and oxygen consumption. But when should we inflate and deflate the balloon during CPR? In our study, we saw that if we inflate the balloon before, this is the chest compression by Lucas, if we inflate the balloon before start of chest compression, we get significant increase in blood pressure and carotid blood flow. So endovascular occlusion method in non-traumatic cardiac arrest to be continued. Thank you very much.
Any questions from the floor?
I've got a quick comment. So we've done that for patients in the cath lab who've arrested on the table. So with the IABP, and it is possible to synchronize the device if you switch it to pressure. So it will synchronize. I think there's a case report that we published somewhere about that, but it does seem to do, you're able to do that in humans as well. So it is potentially useful therapy if there's a balloon pump already in.
So, I'm curious, the arrest times that you used in the laboratory were, the total arrest times were in the, what, 4 to 8 minutes, I think I saw? Is that?
8 to 10 minutes.
8 to 10 minutes, okay. Have you looked at longer arrest times to see what happens to perfusion and stuff if you have a more extended arrest time?
No, the longest arrest time is 10 minutes we have used. So.
Probably would be worth looking at that.
Yeah, well, part of the reason I'm asking is that the effect that you're going to have in terms of systemic vascular resistance will depend a lot on what's the vascular state of the of the residual peripheral arterial resistance.
Yeah.
And so that's the question: is if you actually go out to a longer arrest time, do you still see the same benefit with rAAA?
Difficult question to answer, but I think in the next study we will have shorter arrest time. We will also see how it affects ROSC. And if we have a longer arrest time, it's impossible to get the ROSC.
Right. Now, what you did when you were using the intra-aortic balloon pump during CPR is you were timing it so that you were inflating the balloon as you were compressing. Is that correct?
The problem was that the Lucas had one frequency and the balloon pump had one frequency. So it was a phase shift.
Okay.
So we saw when the phase was like, when the balloon inflated before the Lucas, then we saw better.
Could you differentiate between those when the balloon was being inflated during the diastolic phase as opposed to the systolic phase? Could you tell repetitively over time which seemed to be better in terms of generating flow?
Just before the start of compression, so during the decompression time.
During the decompression phase, okay, because that would sort of, it might make sense because it's coordinate perfusion pressure. You usually think of it being the flow during the diastolic phase of CPR, and if you can actually increase the aortic pressure during that phase, theoretically, you might actually increase your true coronary perfusion pressure, or CPR, diastolic coronary perfusion pressure. Okay. Other questions? Comments? Anything?
Great work.
Oh, very good.
Thank you very much.
Results. All right.
Well, our next speaker is my co-chair, Dr. Kassim. Take it away.
All right, great. Thanks, Tal, and everybody here for this fantastic conference. Always great to be back in person. So Tal asked if we can use rAAA for non-trauma indications, and the answer is yes. So thank you very much, and now you can take a break for 5 minutes. Now let's just go on and talk about this a little bit more. So I'm not going to talk about rupture AAA or medical arrest because we've already had some great talks and we're going to hear from some real experts on that. But I will talk about hemorrhage, and certainly non-traumatic hemorrhage remains a big problem. But whenever somebody asks about whether you can use rAAA for these things, you always wonder, and sometimes the skeptics will always ask, is this just a procedure looking for an indication? And I'll say, well, not quite, because our knowledge is certainly expanding. And at the end of the day, bleeding is bleeding. And so when you're addressing this, though, certainly in trauma, we've noted rAAA use in emergent situations, but we can find some conditions where you can actually look at this perhaps in a semi-elective way. And I want to kind of focus on three key parts here, and I'll give you a rough overview just with the time limitation. But let's start with pregnancy and obstetric and gynecological bleeding. And certainly we have probably, many of us have seen a case of ruptured ectopic pregnancy, young woman who bleeds torrentially into a non-compressible site. And these act exactly like anybody else in hemorrhagic shock. And so there's been a few case reports now published about the utilization of rAAA in an attempt to temporize bleeding from this source in order to get these people to definitive care. But I think the real benefit of this, as we heard a little bit about earlier on, and we'll hear more tomorrow, is postpartum hemorrhage. Certainly a significant contributor to maternal mortality around the world, especially in the developing world, and certainly many causes of it, including abnormal placentation, abruption, uterine damage, and atony as well. And certainly there's been an increasing body of evidence that's using rBOA in the setting of these conditions, postpartum hemorrhage. And Dr. Karen Fox, listed in the top paper there, is kind of leaning on a registry here. We're getting evolving evidence, and this is different from the iliac balloons that were used before. There is actually building evidence for the use of rBOA in terms of decreased blood product utilization, decreased time in the operating room and in the hospital, and a trend towards survival for both mother and child. So certainly great outcomes from this, and we're learning more over time. And certainly with, you can anticipate the presence of some of these conditions like accreta and almost place these prophylactically, hence reducing that risk of iatrogenic injury that sometimes happens when you're doing this in a hurry. All right, so let's move on to non-variceal gastrointestinal hemorrhage. So I'll show you a case that I had a few years ago. This middle-aged woman presented to our non-trauma emergency department where I was working at that day, had a little bit of blood in her stoma bag, and then rapidly exsanguinated out of that stoma. And this is really just the blood that we could catch with suction catheters stuck in there. There was much more around the floor. You know, if we'd had rBOA at this hospital, I would have placed one. Unfortunately, she exsanguinated and arrested. So certainly this is a role for rBOA in this instance. And certainly the Japanese, as well as others, have published case series on these. Often they have an older patient population that they're utilizing this, but they've clearly shown feasibility as well as mortality benefit of using this for non-variceal gastrointestinal hemorrhage. And the final group I'll kind of focus on is emergency general surgery. So there's been a number of publications that kind of looked at data from the ABO trauma registry as well as the aorta trial and other sources that have looked at the utilization of rBOA in non-trauma emergency general surgery. And when they describe the cases, they look at a significant number of GI hemorrhage, but they also look at non-aortic aneurysms. So for example, I had a patient when I was a fellow in Baltimore of a patient with a renal artery aneurysm who presented from an outside hospital for ongoing care. The aneurysm ruptured when we utilized zone 1 rBOA to temporize that patient. Oncologic bleeding, so we've had several instances at our institution as well where the oncologic surgeons know that they're going to be dealing with a pretty vascular mass, and so might utilize rBOA prophylactically to help address some of that bleeding while they're dissecting the tumor. And similarly, patients with a hostile abdomen, so multiple surgeries, multiple adhesions, difficult to get access to, likely vascular, again, can utilize rBOA in that instance, either emergently or even semi-electively to be able to temporize these patients. So is rBOA indicated in non-traumatic hemorrhage? Yes. Which conditions? Elective surgery, non-aortic aneurysms, complex abdomens, GI hemorrhage, and I'll really emphasize obstetric hemorrhage here. I think there's a great role for this with rBOA. In common with trauma, it can certainly address non-compressible torso bleeding, which is the source for a lot of these scenarios that I was just talking about. But different from trauma is that some of these conditions do allow prophylactic placement, and so you can curtail some of those complications that might happen with more emergent placements, such as iatrogenic vascular injury. Thank you very much.
I'll hang right there. All right, just have any questions? Okay, well, I'll start with one. Certainly the time frame for aortic occlusion has sort of gone in trauma from like an hour down to 45 minutes, more to 30 minutes. So it's gotten less. My question is you know, for all these other potential etiologies that you could use this for, is the time frame for occlusion different? Is there any evidence to suggest that, you know, can you leave it longer because you don't have the tissue trauma and stuff? Is there anything to suggest that you have a longer time frame or just a different time frame?
Probably. I think the ischemic burden still is there, especially if you're putting up a zone 1 balloon. I think the benefit is that if you're placing this prophylactically, you can time the inflation exactly to the point where perhaps you know you're about to dissect into a mass or into the area that's, or address the placenta. And so you can really limit your times because of that. And you might actually just end up being able to put this down in zone 3, especially for more pelvic stuff, and then limit your times there. But I think the ischemic burden is there regardless, and we need to be mindful of that.
Other questions?
Zaf, have you an idea if in a pre-hospital system we can, for massive GI bleeding, do reboa? What is your thinking about that?
Yeah, why not? I mean, if you're faced with this and you're convinced that this is like a non-variceal source, then certainly this can be used to temporize the patient in order to get them either rapidly to care or, as in your system, get your motorbikes to get some blood on scene and start transfusing them and resuscitating them while on scene or while getting to definitive care. So I think certainly, especially in systems that don't have a lot of trauma, this can be a potential role.
Thanks.
Other thoughts, comments from anybody? Oh, there we go.
We recently had a debate with our gynecologic team about the placenta accreta and how to approach it. And our approach for a long time has been to pre-cannulate in the really bad cases, pre-cannulate both internal iliacs and then wait and see. And we are gradually going towards the reboa, but when we went through the evidence, I don't think it really was there to guide what you should do. You said quite quickly that's old-fashioned, but actually if you have to do the embolization, you're already there with the internal iliacs. And after we put more focus on it, we actually never did have to do anything since the 10 last cases or so. So maybe the whole team has improved a bit. But can you repeat your opinion, and should we not at all cannulate the internal iliacs pre-cesarean section, or are there cases for that still?
Yeah, I think it's a good question. And whenever I broach this with the obstetricians, they always bring up that, you used to put iliac balloons up or iliac cannulation, and there were some significant documented complications with that, including gluteal necrosis, and that they often cite as, we don't want to do this again. And I think the reboa kind of acts as slightly differently in so much that you can certainly utilize this for a very short period of time to allow your operative care to happen, and so you're achieving your hemorrhage control surgically, but you're essentially just putting an internal tourniquet above to stop the bleeding to allow the standard operative care to happen. And so the overall kind of ischemic insult time, I think, is less, and it's also less directly focused on a small part that could lead to potential ischemic necrosis.
Can I comment on that? Pirka, we performed, so in St. Petersburg, we developed this technique of ultrasound-guided reboa, and Zaf cited this paper when we summarized our first experience with 12 reboa patients with placenta accreta versus 16 patients with common iliac artery control. And when I joined the team of obstetricians doing this, they started with the procedure you discussed with both internal iliacs, but it turned out that the bleeding is continuing during the C-section, and then they go up with the common iliac, and it also doesn't work. And the idea was so the blood is coming from ovarian arteries, and that's why the reboa control, and we saw this during these procedures, diminished the blood pressure blood loss compared to the control group with common iliac artery control by 8 times or 10 times. So we operated on one woman, 160 kilograms, third child, and the blood loss was just minimized, less than 200 milliliters. We even couldn't use a cell saver because there was no blood. So we use it as a standard procedure now for every severe placenta accreta.
Yeah, I think it's a great point about knowing the anatomy in particular. And I bring this point up when people ask me about use in ectopic pregnancy or ruptured ectopic pregnancy because people think that they can do a zone 3 rAAA occlusion on this, but just remembering the anatomy that sometimes the gonadal vessels arise near the renals, and so if you're too low, you might not actually occlude that, and so just understanding the anatomy, just as Victor's explaining there, can certainly affect how you're managing the balloon there. Great, thanks. Should we move on? All right, so I'll switch places with my co-moderator, and Jim Manning's next.
Great, so we're up. So the question that I was tasked with is, could rAAA or SAP be used as a bridge to ECMO? And the one-word answer is yes. Both of them could be. So let's talk about those for a little bit. My disclosure is the same as before, and I'm talking about selective aortic arch perfusion here. I've been working on that for 30 years. So rAAA, obviously the therapeutic intervention for rAAA is occlusion of the aorta. And what that does, as has been sort of mentioned, is that when you blow up a balloon in the aorta, zone 1, and a patient's in cardiac arrest, you quickly significantly increase their systemic vascular resistance. And if there is enough resistance otherwise, and you've got good CPR going on, you can actually generate a higher coronary perfusion pressure by raising the aortic pressure. And that's what you're trying to do. It does require that you have good CPR going on because you need something to actually generate blood flow. But in a sense, rAAA acts like mechanical epinephrine, because that's the purpose of epinephrine, is to actually raise the systemic vascular resistance by peripheral arterial vasoconstriction. And it also, when your rAAA cath is in place, you also have continuous measurement of your of the pressure in the aorta, which means that not only do you get the systemic vascular resistance, you can also change the way you do CPR in order to try to maximize your coronary perfusion pressure. So there have been studies on this over a long period of time, laboratory studies. One of the very first was back in 1989, which showed an average 8 mm increase in coronary perfusion pressure, which doesn't sound like a lot, but if you're right at the borderline of 15, which is the threshold, and you can go from below 15 to above 15, that could be the difference between getting return to circulation and not getting return to circulation. An interesting study that was done by assessment in 2002 looked at, if you just look at the graph here, what you'll see is that this is during balloon occlusion, balloon deflation, balloon occlusion, balloon deflation. You can see that the coronary perfusion pressure is better during rAAA, balloon inflation, than when the balloon is down. The interesting thing they did here is that this is the average right here, but you can see that they actually plotted each individual animal, and you can see there's wide variation. This is one of the puzzling things about what happens during CPR is what is it that affects one animal or one person to have low coronary perfusion pressure versus another one being high, and how can you actually adjust that? So the best data that we presently have in humans is from Yossam Brady. I'm not going to talk much about this because he's probably going to cover this, but they certainly looked at this. And one of the things I found interesting is they did the same thing. They plotted the mean data that they have here, but they also plotted the individual data for end-tidal CO2. And if you look at this, you can see that there were some that really responded very well, some that didn't really change at all, and there were others that were intermediate, which is just, again, this interesting question about what's causing the variability and how can you potentially predict that. So we have some case reports that show that rAAA can actually improve coronary perfusion pressure, can result in return of spontaneous circulation. And there's a rationale for that by increasing coronary perfusion pressure. There is variance. We need to figure that out, and we need to actually get the clinical trials that are presently underway, get data from those to really try to define what's the level of benefit that we can expect from rAAA. Okay, I'm going to quickly move to SAP. This is what I've been working on for a long time. It's called selective aortic arch perfusion. I'll only add that this is a technique that was actually designed for non-traumatic medical cardiac arrest in the pre-hospital care setting. So as for the debate later, it was designed for this purpose. It also works for trauma. But the idea is that the fundamental difference is that selective aortic arch perfusion is an extracorporeal perfusion technique. It's intended to actually generate the perfusion itself, and that's sort of the fundamental difference. The balloon is actually there just to limit the blood flow or the flow of the perfusate to the heart and the brain. It just so happens that if it's a trauma patient, it would also potentially allow you to get hemorrhage control. But the fundamental idea is perfusion just to the heart and the brain. And you can also give drugs and push other agents.
Now, what we presently do is go from, with ECMO, you're going from CPR, ACLS, the standard things we do, straight to large bore catheters and ECMO, which a patient will probably be on for hours or days. What SAP has is 3 steps on the way to ECMO, potentially allowing you to get return of circulation and maybe not have to go all the way to full VA ECMO for an extended period of time, if allowable. What those are is you begin with an exogenous oxygen carrier, something you would take with you. It could be blood, stored blood, an oxygen carrier such as hemoglobin or fluorocarbon. You start with that and initially begin to perfuse. At some point, you're going to hit a volume limit for that. In the meantime, while you're doing that, you put in a venous catheter so you can begin to pull off their own venous blood so that you can then give autologous blood through the catheter. Now, I call it autologous blood SAP, and that's what I named it 20-some years ago, but you could also call it, like I said, just ECMO to your aortic arch. It's fundamentally the same, taking out the patient's blood, oxygenating, putting it back in. If you get return of circulation with the autologous blood, so if it's a non-hemorrhage case, what you want to do is get the balloon down as fast as possible. If the patient is still relatively unstable, having myocardial dysfunction and not responding well, you can let the balloon down and continue to do the perfusion. You can't do full VA ECMO perfusion with SAP. This catheter is too small and too long in terms of resistance. But you could give up to maybe a liter and a half of perfusion support and to see if the patient actually stabilizes very quickly, or you use it as a bridging perfusion therapy to prevent rearrest until you can get the larger cannulas in to begin VA ECMO. So the stepwise approach to this is, from ACLS, you start SAP, you try the exogenous oxygen carry. If you get return of circulation, they're stable, you stop. If not, you can move on to autologous blood. If you get return of circulation, they're stable, you can let the balloon down and stop. If they're still relatively unstable despite return of circulation, you can go to letting the balloon down, partial support with this. If they rapidly stabilize, fine. If they don't, you're just doing bridging perfusion until you get the larger catheters in to put them in, convert them to full VA ECMO. The idea being tailor the care to the needs of the individual patient. And just lastly, so yes, can either rBOA or SAP be used as a bridge to ECMO? Yes, it just depends on what happens once you're in the process of actually using these two. Do you get return of circulation that's stable? If not, you can use those to bridge you all the way to ECMO, either directly from rBOA to ECMO or SAP through its various stages, to ECMO. That's it. Thank you.
Thanks a lot, Jim. Any questions from the audience? John, you have a question?
Yeah, cheers, Jim. So delivery of drugs directly to their target site. So that's one of the things I'm really interested in with the SAP catheter. You can actually deliver adrenaline to where you want it to work rather than, we know that circulation is poor when these drugs are inserted in the venous circulation. So can you tell us a bit more about the application of that? I think there's some real utility, but you'll know better.
What we found in the laboratory is, at least in the cases that are traumatic cardiac arrest, where we actually have some leeway with volume, we generally don't use epinephrine intra-aortic initially, only as we're perfusing. If we begin to get the heart back and it's weak, we may need to give a little bit of adrenaline just to sort of get more of an inotropic kick, really, to get the heart really beating well again. For medical cardiac arrests, with the vasodilation, I think it's probably good to put a small amount. I'm talking about a small amount of adrenaline. We're talking about maybe 200 micrograms, not a full milligram, maybe 200 micrograms in with the initial perfusion to get a little bit of vasoconstriction. That actually raises the pressure and hopefully actually sort of diverts more of the flow to the heart and the brain. So in medical cardiac arrest, they do it a little differently than they do for trauma. Otherwise, in terms of drugs, one of the things that SAP can do is be a platform for, as you're getting to these patients, you begin to really reperfuse them. If you have some sort of a cocktail, which I hope is going to be part of my research for the next 20 years of my life if I'm still alive, is to actually try to figure out what's the anti-reperfusion cocktail that you can actually push in at the time of reoxygenation so that you stabilize membranes, limit the development of reactive oxygen species, and hopefully improve the outcomes that way.
Thanks. Victor.
Yeah, Jim, as you're saying that selective aortic arch perfusion is a step to ECMO. But so I'm just trying to visualize how it happens in a real patient. You need to cannulate both artery and vein, right? And to use SAP catheter, which has a lumen of so about 10 French, right?
9 French. The one that's going to
So 10 French, it probably allows to make blood flow a little bit higher than 1 liter per minute, right?
Right.
And you cannulate, if you start with SAP, you do this, you insert this catheter with maybe not acceptable flow if it is VA ECMO. Do you need to change completely the catheter to ECMO cannula to maintain, because ECMO cannula, arterial cannula, can allow you 2 liters, 3 liters per minute, which can be enough for the whole body ECMO. So is it a step-by-step procedure, or you should decide at the very beginning, will it be enough to stop at SAP or go immediately to ECMO? Just from the logistical points of view.
Well, I think what's going to happen is in an individual cardiac arrest patient, you don't know whether they're going to stabilize with either the SAP exogenous oxygen phase. I mean, it's possible that you may be able to put this in, the catheter in, use your exogenous oxygen carrier, maybe with a little bit of epinephrine, CPR, and you may be able to get them back within a couple of minutes and not even have to go to the autologous blood phase. If you go to the autologous blood phase, the question is that going to be enough to get return of circulation? The big question is going to be, once you get return of circulation, is the myocardium beating well enough to beat on its own and take over full body perfusion? If the heart's beating well, you may not have to go all the way to VA ECMO, but you're not going to know that until you actually have gotten return of circulation, and then you have to observe and say, how well is the heart beating after that? If the heart is beating well, you may be able to stop, and that's one of the advantages, is that you may be able to stop, pull the catheters, and you're done. However, if they're really unstable, if they're still hypoperfusing, the myocardium's not recovering, then you may have to go ahead and then just continue it until you can get the larger cannulas in, because you can't do full VA ECMO with a SAP catheter. You'd have to switch the catheters.
Great, thank you. All right, I'm going to save the further questions because there's going to be a debate at the end just covering exactly this. So, Lionel, are you there? All right, so let's hear from Lionel Lameau from Paris, talking about medical arrest and eCPR physiology.
Thank you so much. We will start my conflict of interest. Okay, as you know, I think the best things happening for eCPR this year was the publication of Dimitri and Apollos from Minneapolis, where they showed something very nicely for everybody on an RCT increase, a major increase of survival rate with eCPR compared to standard advanced life support. And they need to stop the study after just 30 patients. That's amazing things. Probably we cannot replicate everywhere. Probably we have some limits, but that shows to everybody eCPR save life, and many lives probably. Anyway, the major problem of the study is where we can take the patient, because in these studies, it takes the patient to then go strategy, and the patient goes directly to the hospital with a circle around the hospital. You have the green one, where it's possible without any problem, it's possible. We have probably a part where it's feasible but very complex, and a part it's no way, it's too far, because we have a goal to be in 60 minutes on pump, and it's very hard. This is why we have developed the pre-hospital eCPR. So pre-hospital eCPR is to do the eCPR where the patient is. You take out this red bar. So the red bar is the time to transfer to hospital, and you use the advanced life support time to prepare your eCPR to be on time. And as it was explained this morning, it's not so easy to go very short in 5 minutes to hospital. All people working in the hospital system know that. And this is why we have developed this system, and we are able to do everywhere now the eCPR in a small, very small, teeny place. If you need to do an extraction from here, it's very hard on the skeleton everywhere. Anyway, and we have shown in a larger study with more than 500 eCPR, and when we have compared in hospital eCPR and out of hospital unseen eCPR, you can see on this slide, pre-hospital eCPR is directly correlated to survival rate. That's a good thing for us. Anyway, a lot of people now work on pre-hospital ECPR, and particularly I take this example of US, because US is very strange for us, because during 20 years, they doesn't want to speak about pre-hospital doctors, and now they do some doctors for ECPR. We have some example of Albuquerque, for example, doing an ECPR now is likely 2 years ago in pre-hospital, but Albuquerque is very special because they have MD in pre-hospital. And now Minneapolis, with the randomized study, thinks it's not ethical to have just one green circle around the hospital to have patients, and they have developed a system with pre-hospital. This is US, this is a huge car, it's not a car, it's a truck with an angio inside because they are cardiologists. Anyway, that means a power of thinking is to think we have no time to reach a hospital, and many people would like to have ECPR on scene. And a lot of people speak about the cost of this ECPR. That's a very important point. I like this study because we have the cost of classical WASC after cardiac arrest, and the cost after ECPR is less than classical WASC. Why? Because when you have a ECPR, generally the patient who dying very shortly in the first day. And when you have a patient with WASC, 2/3 of the patient dying in hospital, half of them by a neurological problem. But this neurological problem need to have an evaluation and take many days in ICU. The cost is more expensive. Anyway, you have to think always when you do ECPR, cardiac arrest, I think organ donation. Sorry, it's in French, but anyway, you have to believe me. We have do a group with ECPR and a group with classical CPR, a donation, sorry, and the quality of the organ of the kidney is the same in ECPR and likely better than classical brain death. Then it can be a very potential source of organ. And in the design we have to think about that. And to conclude, we have to shift the mind we have about cardiac arrest. Classical cardiac arrest, we describe electrolytic phase, AD, the goal is a ROSC. 4 minutes, circulatory phase, the goal is a ROSC with CPR. And after 10 minutes, we have metabolic phase, and we do a lot of things with any proof, like epinephrine, like intubation, what you would like with no proof. And the goal is ROSC. After 16 minutes, generally, you have to decide if the patient is dying on scene or we have a ROSC, and after in ICU, it can die in organ donation or survive. I think the new thing of the change of paradigm is after 10 minutes, we do CPR AD. It's like people do that to have a ROSC, and this is the first line of treatment. And after, we have to switch to a second line for the brain. And this is ECPR, and we have time to treat the cause, the etiology, and evaluate the brain. And we check what the patient doing, and particularly, we have a mind about organ donation. And just Jim speaking about before, probably we can insert Trevor or SAP to extend the time to go to state the brain with this CPR, or try to replace epinephrine by mechanical way. Thank you for your attention.
Always great to hear from your system, Lionel. Paul, you have a few questions?
Yeah, thanks for that, Lionel. It's a world-leading service. Thanks for that presentation again. I've got 2 questions. The first one is case selection for complex therapies like this is absolutely essential. So of the cases that you go to as the ECMO team, what proportion that you attend do you think you then put on VA ECMO? What percentage?
It's finally it's low because we go on scene for all cardiac arrest less than 65 witness cardiac arrest. We are alert and dispatch. Generally, is 1 for 3 to 5 alert. We go on ACLS.
Okay. And the second question is, when you go on VA ECMO or ECPR at the scene, you know, I used to think this was just going to be a bridge to going to the hospital and unblocking the LED, but actually the heart organizers, they often come out cardiac arrest and develop ROSC. So what proportion of the patients you put on actually get ROSC in the few minutes after they go on VA?
After VA, generally is 90 to 95%.
So the vast majority get ROSC, organize their rhythm, and come and get ROSC at the scene. Yeah, yeah, that's interesting to know. Yeah, thanks very much.
What we have shown is when a patient has a ROSC shortly in the first hour or few hours after the VA, all dying. So that's a very important point. And I know some team like Dimitris, I think, when they have no ROSC after the angio, they stop the care.
Great, thanks. Any questions from the audience? All right.
Lionel, one last quick question. So the protocol in Paris has been up to now giving ACLS 20 minutes to fail. If you were the master of this, what time frame would you change that and make it 15 minutes?
No, in fact, we have changed today. It is not 20 minutes of advanced life support. It is 20 minutes of care with AD, because we think the time don't start when a doctor is on scene. So cardiac arrest appear before. That means I think we can reasonably give a chance to the patient to have 3 shots for ventricular fibrillation. And for other, I'm pretty sure we can go very earlier in the sign of life in ACPR. But I think 3 shots, it's a good time because we know in the literature after 3 shots, the change to have a ROSC is very low.
Great, thanks so much. I'm looking forward to this next talk because when I saw that previous talk of the hybrid ER, I was reminded of that video of the Formula One where they're doing that rapid tire change in like 2 seconds. So I'll hand it over to Takahiro Kinoshita from Japan, who's talking about hybrid ER and applications for out-of-hospital cardiac arrest.
Thank you for the introduction. So I will talk about the application of hybrid ER to other diseases. And again, I'm currently working as a researcher in Philips, but none of the this work was related to the Philips products. So, as you know, ECPR is becoming a popular choice of treatment for out-of-hospital cardiac arrest, especially VSCPA. And I published correspondence explaining the how we treat patient of out-of-hospital cardiac arrest in the hybrid ER. So let me share the video first. So as you see in the video, we believe that ECPR using the hybrid ER is a fast and safe strategy. And we believe this is super effective because we can conduct ECPR and CAZ/PCI seamlessly. And this is just descriptive statistics, but we conducted 47 ECPR for 47 patients, and 34% of them survived the discharge. And we also use this system for a postpartum hemorrhage because several studies reported that rBOA is effective for bleeding control in postpartum hemorrhage. So again, let me show a video. And besides severe contrast flush in the CT, we found that uterine rupture. So we decided to conduct hysterectomy for this patient. So as you see in this movie, hybrid ear enable us to perform rapid hysterectomy under reverse support. And again, this is just a descriptive statistics, but we conducted UAE for 20 patients, and we used REBOR for 3 patients of postpartum hemorrhage. So in summary, we believe any emergency patient who needs immediate CT examination and endovascular treatment can benefit from the hybrid ER. And hybrid ER system may accelerate improvements in cardiac arrest and PPH management. So thanks for your attention.
Thanks, Taka. That's a great kind of example of what you guys are capable of over there. One question for me is, how many of your emergency departments in Japan have this hybrid ER available?
Currently, it's about 15, around 15. 15 trauma centers implemented this system.
Wow, that's amazing. And the other question I had just before going to the audience is, when you have the cardiac arrest patient, there was a recent paper about pan scanning these patients after return of circulation. I saw you just scanned the head in this patient. Do you ever scan, like do a complete pan scan on these, looking for any injuries like rib fractures or splenic injury or anything?
Yeah, we originally conduct like whole body CT scanning using contrast enhanced, primarily to exclude PE, because like it changes the treatment strategy. But yeah, we sometimes like find a lot of like rib fractures, as you suggested. Yeah.
Great, thanks. Any questions from the audience or panelists?
Yeah, quick one. Could your scanner do CT coronary angiography at the same time? If you're in there, you could then get the answer. You wouldn't need an invasive coronary angiogram. Is it capable of that?
I'm sorry, what did you say? Like,
Could you do a CT coronary angiogram at the same time?
Not really. So it depends on the like machines, and we implemented this system in 2011, so our CT scanner is not good enough to do coronary CT. But potentially we can do that in the newest CT scanner.
Okay, thanks.
Amazing work. I'm just curious, you've got the capability to do coronary angiography there. How about pulmonary, to look for like a large saddle pulmonary embolism and then directly intervene?
Yeah, we can also do that. So like at least we can establish the ECMO there, and so we can like earn time. So and like we can like bring the patient to the OR for like definitive surgery, or like start TPA or like any kinds of treatment. But the decision is made by cardiologists and cardiac surgeons. So, but anyway, so we can do that in our hybrid MRS room.
That's amazing work, Tech. Please stick around for the panel discussion at the end. I'm going to move on to John Barrett, who's going to be talking about indications for ECMO and what's possible now and what does the future hold.
Thanks, Af. Yeah, good evening, everybody, and thanks, Tal, for the invite. So that's me. I'm going to be talking predominantly about the time that I spent as an endovascular fellow at Guy's and St Thomas's NHS Trust, which is one of the ECMO centres within the UK, and that's what I do in the rest of my time. So ECMO for me was the great escape because I finished there in February last year. And then very shortly after, St Thomas's is one of the high consequence infectious diseases units in the UK. And the plan was that all of the patients that came back from China with COVID would be managed within the 5 high consequence infectious diseases units. Well, that didn't happen, obviously. So when we're talking about ECMO, and I'm conscious there's a really wide experience within the room, and over the course of yesterday as well, realize that there's people that have got extensive experience of ECMO, but there's also people that maybe what we've been talking about over the course of today, when ECMO drops into conversation, may be new. So what we're talking about, well, it's either VV ECMO, respiratory support with femoral vein cannulation, typically is what we were doing in St Thomas's, or VA ECMO, which is what we've been talking about when we're talking about ECPR as well. So with femoral venous and femoral arterial cannulation, typically how we perform that in the UK centres using percutaneous access to give you cardiac support. So this is what the ECMO setup looks like, exactly the same as what we saw yesterday, those of us participating in the workshop. And just running through some of the main players within the ECMO circuit that do all of the magic. The access limb of the ECMO circuit, the one that's typically coloured dark. The return leg, usually bright red because it's been oxygenated. The magic red box that does all of the oxygenation, and then this familiar console. And those of us that are used to using other types of ventilators and renal replacement therapy, lots and lots of different dials and things to set. Well, really with the cardio help, it's pretty easy. You just turn that single dial in the middle that controls your revolutions, and everything else will be derived from that. And that was quite a difficult concept, I think, initially when I was starting out in ECMO to get my head around. So VV indications then, and then we're going to just run through very briefly a VV case. Predominantly for severe respiratory failure. So the centre I was working was set up as a severe respiratory failure centre. Most of the UK centres are the same. It's predominantly VV workload. That's what's commissioned and that's what's funded by the UK government. So patients referred when they had a high Murray score with reversible etiology. So that's the key here, that we need to be able to reverse the underlying pathology with supports from ECMO. And whether that's predominantly down to infection, obviously COVID has made a massive increase in the workload, and there was a huge surge in the centre that I worked just after I left to accommodate for that. Inflammation, so worth acknowledging that the MDT for ECMO is huge. So the centre that I worked in consisted of not just the ECMO intensivists, but also the respiratory physicians, the rheumatologists who worked on the sort of lung inflammation side, radiologists, it's extensive. asthma, aspiration, those other sort of smaller number indications. And then I know we're in the non-trauma theme, but I think it's worth acknowledging that particularly for VV, thoracic trauma is developing interest, and the old previous sort of concerns around anticoagulation and things like that, I think are massively reducing with the use of new circuits that are heparin bonded and the reduced requirement for systemic anticoagulation. Contraindications wise, really it's sort of significant life-limiting conditions really. Other things such as previously, HIV was previously a contraindication. That's no longer the case for VV in the UK. I'm just going to run through this case. Hopefully this will loop through. This was an interesting case. This was a patient that was a motorcyclist who was injured on a rally in the Middle East, had a long pre-hospital time, over 2 hours, and was retrieved to a centre there, and then retrieved back to the UK as is conventional, intubated and ventilated, but to a major trauma centre. And it's worth acknowledging that none of the UK major trauma centres are ECMO centres. So he arrived in the major trauma centre, failed conventional ventilation, and then was retrieved back to our centre. You can see there the extensive lung injury. This was the first time we had managed to actually get any UK cross-sectional imaging for this patient, and I think that's another thing that was quite unique to me when I was seeing these referrals. Often the patients were too unstable in the referring centre to get any cross-sectional imaging. It was only once we established on ECMO and retrieved them back to our centre could we actually get the dedicated CT imaging that we required. VA indications, I'm not going to talk too much about VA, but predominantly for cardiogenic shock, and worth acknowledging that the definitions for that are much more variable, unlike the sort of severe respiratory failure side. And the survival is hugely variable depending on your centre and how much VA workload you have. Indications there, and I think again worth acknowledging that trauma is an emerging indication for VA ECMO. It's definitely something that's under exploration in the centre that Paul and my other military colleague Max are working in at the Royal London, looking at those patients that have maybe had a RAAA and then have this post-RAAA, they've gone through the damage control surgical phase, but then they're in a state of cardiogenic shock with all of the metabolic insult that's occurred, and then they're struggling to come off the operating table, and actually those patients may benefit from VA. As a bridge to transplant, that is a potential option with VA and in one of the centres, but there's a huge amount of risk of complication. So we saw some of this yesterday with the machine that we were using, the membrane failure, risk of clotting and bleeding, and they were the catastrophic complications that I experienced, not infrequently in the sense that I was working in some of the patients that were clotting and bleeding at the same time, which is super difficult to manage. And then also with the VA specific complications at the bottom there, some of which we again managed to demonstrate yesterday in the VA case that we did in the lab. So very briefly, just in the last few minutes, just to give you a feel for what ECMO retrieval looks like within the UK. As I say, it's centrally commissioned, which means that it's all ran through one single point of access. So you don't have to ring around the different centres. They sort all of that out. It may not necessarily be that you get retrieved to your nearest centre, depending on the surge capability. And outcome-wise, you may be referred and then potentially recover. You may be retrieved on conventional ventilation with a view to go on to ECMO at the centre down the line, or retrieved on ECMO, and that was the sort of specific area that I was interested in. Cannulation-wise, just in the last slide, locations for cannulation. So we would cannulate on the ICU if there were a patient that was in our institution because we had the surgical setup, we had surgical table, we had the access to fluoroscopy. But predominantly we'd be doing it in the OR. We'd be doing it in a hospital that weren't familiar with the team, so we had to be really self-sufficient. The only thing that we needed from the team was really access to fluoro, and the rest of it we could pretty much do ourselves. Obviously for ECPR, you're not necessarily going to have that luxury, so places that can occur obviously on the street, like Lionel's been talking about, in the ED, like US colleagues like Zach Shiner are doing, and emerging in the UK, and then in the cath lab, Dimitri's paper shows how efficient that system can be about cannulating there. Very finally, just some references. If you want to just hold your camera phone, smartphone up, you should be able to get those VA, and then the referral checklist is something that we produced at GSTT to help teams that were referring to us for ECMO consideration.
Yes. Great, thanks so much, John, for that. Just a question, and I'll be a little controversial. So should the person who's, say, an emergency physician, be cannulating, or if they have the skills to cannulate, but should they have spent time working on an ECMO ICU for a period of time, or do they not need that knowledge?
Yeah, I think it's a really interesting aspect, because the reason why I did that job was to get the experience. It's one of the few opportunities in the UK to see sick patients who are difficult to get access on. These patients are on maximum dose inotropes usually when you go to retrieve them. The vessels are tiny and they're really difficult to access. So for me it was a great opportunity to get exposure to that group of patients. Where I think maybe things will develop in the UK, which is still very much centered around retrieval to those specific centers, is that maybe, as an emergency physician, you might be involved in the establishing the patient on ECMO, and then the retrieval team will come and collect that patient and take them back to the specialized center for the longer term, long to medium term sort of management of their ECMO run. So that's a potential, especially for VA. We'd get VA referrals, but ultimately we're not going to get there in timelines that are going to allow a meaningful outcome, whereas VV, I think you've got a little bit more of a window of time. Doesn't really answer the question, but gives you a flavor.
Fair enough. Any questions from the audience? Panelists? No. All right, great. Thanks,
great.
John.
Cheers.
All right, so in our last speaker of the session, our colleague from Trondheim, Norway, Dr. Jostein Reddy, he's going to talk about the RAAA trial.
Last speaker. That's quite an honor. Thank you for this kind invitation. This is perhaps my favorite topic to talk about, next to freeheel skiing down mountains, but I'll try to make it in 6 minutes. I'll talk about an ongoing RCT called RAAA, which will assess the efficacy of RAAA used as an adjunct treatment to ACLS in non-traumatic pre-hospital cardiac arrest. I have no disclosures. And as you may know, and as Jim Manning just told you a few moments ago, it's about trying to improve aortic pressure. If you increase the aortic pressure during the decompression phase, you may increase coronary perfusion pressure, as demonstrated in the figure on the upper right. And if you increase the coronary perfusion pressure, you may increase your chance to achieve ROSC. There's a lot of preclinical studies that support the idea of use of RAAA in medical cardiac arrest, and some of them are here from Örebro. And as far as I know, I may be wrong, but as far as I know, this is all the human data that are published on the use of RAAA in non-traumatic cardiac arrest. As you can see, there's some case reports, and we have 4 prospective studies, with none of them with control group, and the number of patients are small. 3 of them are performed with pre-hospital deployment of the balloon, so it's quite feasible to perform pre-hospital RAAA given the right training. And that's why we need to perform an RCT, because we have to increase the level of evidence from expert opinions and case reports and to RCT. RAAA arrest is a parallel group RCT. It's multi-center international, and we will include 200 patients, 100 patients to a control group to receive ACLS, and 100 patients into a intervention group that will receive ACLS and RAAA. So the only difference here is RAAA. All patients will receive gold standard ACLS. Endpoints, the primary endpoints is the amount of patients that achieve sustained ROSC, meaning ROSC lasting more than 20 minutes. We have, of course, the important secondary endpoint, 30-day survival with good neurological outcome. And we have other endpoints such as hemodynamic variables, difference in organ function, adverse events, and 1-year mortality. We use a group sequential design, which allows us to re-estimate sample size at the interim analysis. And we plan to perform 3 interim analyses. Then we can consider to stop the study if we find a difference in either the primary endpoint or the secondary endpoint, 30-day survival with good neurological outcome. And that's safety reasons. All our providers are air ambulance workers. So it's a HEMS physician and a paramedic. So it's a 2-man band. And all have to participate in a structured educational program. It's a 4-step, quite comprehensive program, and it's described in this publication if you want to read the details. And such a structured training program allows us to have a similar approach, a similar inclusion to rAAA REST trial, and a similar rAAA procedure on site for the intervention group, regardless of the study site. I added this slide due to the discussions we had this morning. In rAAA REST, it's mandatory to use ultrasound. You must see 2 vessels, and you must cannulate with an out-of-plane technique. Because if you cannulate the vein and you include vena cava inferior, you can go home. The trial is ongoing. We have included 4 patients, and we estimate that we will need about 3 years to include all 200 patients, which obviously is dependent on the amount of study sites and how quickly we can implement this procedure at high volume study sites. All patients are adult patients, 18 to 80 years, and with no more than 10 minutes low flow time. The exclusion criteria on the right side, the last one of them are other factors as decided by the treatment team, because performing rAAA pre-hospitally is very different from in-hospital, as discussed earlier today. It's 2 different worlds. There's a lot of limiting factors that will limit the possibility of rAAA in a pre-hospital environment. You have wind, rain, snow. Perhaps you're in a safe or unsafe location. Perhaps you don't have enough space. So it's important that we have a pretty large exclusion criteria called other factors. Okay, we know that ACLS works, but we do not know does rAAA work? Does rAAA help patients with cardiac arrest? We also do not know if the rAAA procedure will negatively influence the ACLS quality. So it's very, very important that we assess that. So we have a rather comprehensive safety monitoring program. We have 3 interim analyses, and we have a lot of committees that will assess quality, and we have a case review panel that will review every single included patient. All our documents are available on our homepage, rAARest.com, and a lot of them are also in the published study protocol. And I think that's it. Thank you for listening.
That's great. Thanks for that. We're really excited to see the results of your trial for sure. So I'll take the privilege of being a moderator, asking a question that, and we have to bring this up. What if the patient is arrested because of COVID? Do you think that'll affect your outcomes at all?
A very good question, and I don't know the answer, but it's not an exclusion criteria.
All right. Any questions from the audience yet?
Hi, great talk. And this is an interesting approach that has been talked about many times and from our colleagues from UK. So you have included 4 patients. How many patients did you try to get that access and it was not feasible because of the cold weather, or the patient didn't have any pulse, or the ultrasound batteries were not working? That's my first question. The second question is, when you do this pre-hospitally, I think that data, if it comes out that it's not doable, I think we're going to do us an unfavor. If we are having these patients that somebody on the side of the road are trying to put in the reboy, have you thought about that? That have patients that are more likely warm in an environment where it's more feasible to get the access? Thank you. Great study.
Is it possible to go back to the slides? No. Okay. We can, from our experience in Trondheim, Norway, we have 100% success rate when it comes to performing the procedure. So we have no patients where we have tried to do reboa and we couldn't make it. From the studies in Italy and the Swiss studies, I think they report 90% and 80% success rate. But this is definitely a very selected patient cohort, and it's very selected group of health care workers. And in reboa rest, they will all be very specifically trained to do this. So I don't think it's a good idea that everyone should just, here's a balloon catheter, go out and place it under cardiac arrest. I think that's a bad idea. So I think it's highly important that you train very hard. And well, for all difficult procedures, regardless of medical specialty, you need to train for difficult procedures, which we will do in reboa rest, which obviously will bias the result.
Can I ask? I have two questions. The first one is we developed the system of pre-hospital reboa in St. Petersburg before pandemic. Now it is frozen. And we also discussed the issue of non-traumatic cardiac arrest, and our ambulances are equipped with the reboa sets. But the main concern, we didn't start with the non-traumatic, with medical cardiac arrest, because of the main concern of our emergency physicians was what will happen with the kidneys because of zone 1 reboa. It is uncontrolled because of for future possible transplantation. Did you think about it, and how did you solve this problem?
Yeah, we have talked about this, and we have also we have a survivor. That's our happy story. We have a survivor that got her reboa at 57 minutes, asystolic cardiac arrest, balloon occlusion, and the patient is now back to work. She had ischemic bowel, and was the surgery was performed. And after that, we had Helsetilsynet rapport. Help me out, Sweden. The government looked at this and told us it was okay. So thing is, if you have a cardiac arrest in 40 minutes, 50 minutes, for an hour, you have a very, very low flow state. This will definitely damage your kidneys or bowel or colon. Oh, sorry.
The brain. The question is about brain, right?
Yeah, brain. But yeah. If you have an occlusion, yes, then the situation go from low flow to no flow. Yeah, but if you don't get ROSC, you're dead. So for this patient, we had a complication. Great, we had a complication that we could discuss.
Okay, the second short question. May we compare zone 1 reboa for medical cardiac arrest, which is difficult to adopt to pre-hospital arena, and abdominal aortic junctional tourniquet applied over the belly, AJT, for zone 3 occlusion, which is easier and faster? And are these compatible techniques, or this absolutely from?
That's a great question, and I don't know the answer. because I don't know if any studies has compared this very good. But it's obviously much easier to put on like the tourniquet than to perform advanced invasive intervention such as rAAA. Personally, I think you may have more hemodynamic response in zone 1 rAAA than with the abdominal junction tourniquet, but I don't have the data to back it.
Okay,
all right, I'm going to transition just in the last 10 minutes. Let's just talk about this debate about rAAA or SAP having a place in cardiac arrest. Should we use that or should we use ECMO? So Taka and Lionel, you'll feed into this. So, I don't have much skin in this game right now, but I've got some world experts sitting here with me. So who's pro for rAAA or SAP over ECMO? John?
Yeah, so, I mean, I think we've got to be realistic about what's, if I was to want to deliver an intervention tomorrow in our service that currently doesn't have either options of rAAA or ECMO, what is actually likely to be achievable in a short timeline? It's got to be rAAA. The amount of procedural skill and investment and all of those elements that we require to operationalize this, the rAAA or SAP would be much more feasible, and it builds on the program that we've already done in our service of getting the vascular access early in cardiac arrest, in medical cardiac arrest. I think ECMO would be a significant step for us to move to that within the organisations that we work with in the UK, which is the advanced pre-hospital providers being usually provided separately to the hospitals.
So certainly it sounds like systems are important. Lionel, you have a system where you can put people on ECMO pretty quickly. It's all established. You're kind of leading the world on this. Should rAAA be part of your system, or just to wait until you get there and put them on ECMO?
Just I think it's, we have not to compare rAAA and ECMO. We don't do the same thing. It's two different strategies. rAAA is there to try to increase a little bit the flow for the brain and the coronary. In fact, they replace epinephrine. The goal is to have a ROSC. Your goal is to have a ROSC. Or extend time to go to ECPR. ECPR replaces completely your flow. Your goal is not to have a ROSC. Your goal is a brain salvage. It's a neuro prognostication and treat the etiology. It's not the same goal. You cannot compare something with not the same goal. That's completely different. It's likely for trauma. You don't use rAAA to treat the etiology of the hemorrhage. Just to stop the hemorrhage and waiting the definitive care and evaluation. That's the same. That's why I think we can do together rAAA and ECPR. After just depending your system. If your system like mine is able to do directly ECPR in time, do ECPR directly. If your system is not able to do ECPR directly and you have a time, you can try rAAA to replace epinephrine or give more time to go to ECPR. I think it's a misunderstanding to try to compare rAAA and ECLS because it's not the same goal.
Taka, what do you think? I mean, you have 15 hybrid ERs in Japan, but what if the cardiac arrest patient shows up at the non-hybrid ER? Should they put in a rAAA while they wait to transfer to you?
I don't believe rAAA for out-of-hospital cardiac arrest is common in Japan, and we do not usually transfer CPA patients. So in some rural hospitals, they do conduct regular HLS plus ECMO if available. So that's probably the common strategy in Japan. And again, so the biggest concern for me is the cerebral, not only perfusion, but also oxygenation. So SAP does make sense for me in some extent, but like only for like I think it's a little bit risky if like we cannot obtain ROSC immediately. So that's my concern.
Jim, he's saying SAP has a real potential here, but what are your thoughts, and when are we going to have a SAP catheter in our hands?
Yeah, really. I'd like to know the answer. Yeah, I'd like to know the answer. I guess the thing, I obviously I have the sort of a bias here, but selective aortic arch perfusion was really designed for medical cardiac arrest and the pre-hospital care setting in order to get perfusion to the patient as fast as possible. It is, I keep trying to say, I know it's a balloon occlusion catheter, so it looks a lot like Rabo, but it's really an extracorporeal perfusion technique, but it's a temporary one intended to give you perfusion of the heart to get return of circulation, but at the same time perfuse the brain to keep the brain alive and promote neurologic recovery. However, it's still a temporary technique. If you don't get return of circulation that's stable within a matter of minutes, that's fairly stable, you have to move on and escalate up to, as I showed, to full VA ECMO.
Paul?
Yeah, I've got some thoughts. I mean, I think they're doing different things, like Lionel says, aren't they? Reboa, for me, is an adjunct to CPR. It's a way of perfusing the brain and coronaries and hopefully getting ROSC. If you haven't got anywhere to go after that, you're still going to possibly have a dead patient. Let's remember that survival from cardiac arrest is abysmal. It's much worse than major trauma. You've got a 90% chance of dying if you have an out-of-hospital cardiac arrest. And it's actually probably 2 or 3 times more common than major trauma. So this is a huge worldwide problem. SAP is very attractive in the setting of the cath lab, or an ED cardiac arrest where you may not have ECMO available, it might be out of hours, it might allow you to establish some flow and hopefully get ROSC. And I think eCPR is the gold standard, but in the UK, how many hospitals actually operate ECMO?
So you've got 5 in England that are commissioned to provide it.
So it's not ubiquitously available at all. So 5 centres in England are commissioned to provide. Some extras do as well. So that's how they work for me in terms of tiering and where they sit.
So I think a common theme that's kind of coming out here is that systems of care are really important, and what can be done in certain systems. We heard from our colleagues from Latvia what they could do, and others around the world. So just to kind of tie all this together, and I'll ask for everyone's thoughts, is it time that we designate places as level 1 cardiac arrest centers, and we look at the system of care from the street to the cath lab?
Yeah, definitely. I completely agree that, we need to move to having, like we have major trauma centers, to having, level 1 cardiac arrest centers. That is something that is desperately needed within the systems that we work in the UK. But I also think there's a massive change in mentality that needs to go with it, because at the moment, and I don't know for, not to speak for other countries, but in the UK, the EMS mentality is very much you get ROSC at scene or not. And the amount of cardiac arrests that are conveyed with ongoing cardiac arrest, either on mechanical CPR or manual CPR, is extremely small, because there's a belief that there isn't really a treatment available at hospital, and that's going to have to completely change if we're going to access, if it's going to be a hospital-delivered system in any sort of reasonable timeline. It's going to need to be a strategy very similar to like what Lionel described, like the guys do in Minnesota, where it's, no ROSC after 3 shocks, you package and you move and you get to somewhere that can then deal with the problem. And that's going to be a massive system change within and culture change within our system in the UK.
Yes, is that feasible in a wide geographic area like yours?
The main problem in Norway is that we are too few people. So we have, last year we had 3,000 cardiac arrests outside the hospital. So we don't have the numbers like in the States or any other, like in Paris. We're 5 million people scattered around a pretty large, or at least long country. So like ECMO in pre-hospital in Norway, that's not going to happen. And cardiac arrest centers would be great, but we don't have enough cardiac arrest patients. Thank God for that, but we don't have the numbers. And I think that's kind of the issue in a lot of northern part of Europe, like Finland, or Scandinavia, Finland, Iceland, Denmark, Sweden. We're not that many people.
So systems really matter. All right, so I keep looking at this word party, so I'm going to give Tal the last minute or so just to give some closing words for the first day, and then we'll call it a day.
Thank you very much. The closing words would be thank you very much coming here and doing this. We will go now to the get-together party here and try to have some fun. Thank you for today. It was amazing to listen. And thank you for coming and traveling. And thank you for the people online with us and all the technical team here. So let's go and have a drink.